क्लियरली करता है ना? नहीं लिखा हुआ होगा टाइम पे कितना रहता है, मुझे नज़र आ रहा होगा।
Assalamu alaikum. Good morning, everyone. Welcome you all on the behalf of EC PSNM on the second day of our 8th annual conference of Pakistan Society of the Nuclear Medicine. So we'll just start off with our first scientific session, and I would like to ask the moderator for the first session, Dr. Amreen Khawa, to take over and start the proceedings. Dr. Amreen Khawa.
Good morning and Assalamu alaikum. I'm Dr. Amreen Khawa, as I have been introduced by Dr. Zahir Chiragh. I'll be moderating this session. To start the session, I would like Dr. Khalid Nawaz, Chairperson, Diagnostic Services and Chairman, Nuclear Medicine at Pakistan Kidney and Liver Institute, to please take the stage as a chairperson. Along with him, I would like Dr. Musab Riaz, Director, Atomic Energy Cancer Hospital, Ennore, Aptabad, to assist Dr. Khalid Nawaz as co-chair. Now, I would like to call our first speaker of the session, Dr. Ahmed Qureshi. He is an esteemed nuclear medicine physician, PhD from Japan. To his credit is the establishment of the first PET-CT and cyclotron facility in the public sector in Pakistan. He is currently serving as DG NMO in PSC. He will share his views on nuclear medicine future outlook in Pakistan. Please, sir.
Assalamu alaikum. Should I be speaking in English or I can do a hybrid thing?
As you like, we have some
Okay,
international
we have got
audience.
international audience as well.
Yeah.
Okay, I'll try to stick to English, but I don't have much knowledge about English. So first of all, I must say that there is a little bit change in the title of. Mostly, I will be talking of the past and present. Future is something which I think audience will be trying to. I will involve them, and I'll try that their views should be added from past to present. That's the progression of nuclear medicine in Pakistan, and what should be the future. So we will talk about that. So layout is like historical perspective, overview of the current status, what are the challenges we are facing, opportunities and areas of growth will be identified in there, and now emerging technologies which are there in the world, and what technologies are being introduced in Pakistan nowadays, and what will be done in future. We have got research, education, and then we have got initiatives from the government, and then international inputs. So if we talk of Nuclear Medicine Center, it was first center was laid out in Karachi back in 1960s, and this center was having a rectilinear scanner, a few like counters, survey meters, and that was all. And that is 1960. Now we are 63 years down the lane, and as I will explain that Atomic Energy took the initiative to build this center. Initially, there was no such center in the private setup or any provincial setup. Only Pakistan Atomic Energy, with the help of IAEA, was establishing these centers. This is an older picture of same AEMC, Atomic Energy Medical Center, that was renovated or upgraded along with radiotherapy facilities somewhere in 2006-07. If we talk of the private hospitals which took up nuclear medicine as one of their specialties, it came in 1993, 1960 and 1993. That is 33 years. Here I was told, I have never visited this facility, but I am told that the first gamma camera in private setup was installed here. What is the current status? If we count in all how many nuclear medical centers are there in Pakistan, we have got 50 of them. And out of these 50, Pakistan Atomic Energy Commission has got 20 established and running facilities, while one is under construction in Azad Jammu Kashmir. In public sector, we have got 18 of them in, I should say, in the, it is quite, I mean, I'm surprised. Most of them, they are located in Karachi, I believe, because first center, I will explain later, was established in 2009 and second was established in 2010. So after 12 years, 13 years almost, we have got 12 of them. So 10 were added in the last 10 years, and that's quite commendable. There are cyclotrons which are 9 in number. Sorry. Can you please remove this? I believe I didn't do anything wrong.
No, it's not. I'm really sorry.
Don't worry, you will add 2 minutes into your talk.
Sir? Sir, sorry, I couldn't hear.
I said we will add 2 minutes for you in your talk.
Our Dr. Shabana, she is the greatest teacher, professor of nuclear medicine, and she has already asked me, cut it short by 10 minutes, I will take those minutes.
Then it is between the two of you.
So cardiology setups are 9 in number. That's quite promising again. But as I'll go down my presentation, I'll show that there are still deficiencies present in our setups. 15 SPECT CT and 58 SPECT only gamma cameras are available. When I started, there were like only single head gamma cameras, static, without computers, and they were like films, etc., etc. That time is now gone, and I believe that with hybrid technology is there, and it's growing, and it will keep growing, and even that SPECT only gamma cameras will be gradually phasing out. So this is this current status of nuclear medicine in Pakistan. These are the atomic energy cancer hospitals, not the private ones. We have got one in federal capital Islamabad. In Punjab there are 7 of them. In Sindh there are 5. KPK is 5 again. Balochistan only in Quetta, and there was recently established in Gilgit. That is in the northern part, a beautiful part of Pakistan. If you find a chance, do visit this area. We have got a big hospital plus a very beautiful place. Latest addition to our setup is DCN, Diagnostic Center of Narowal. They have got little bit radiology, a nuclear medicine facility, and clinical labs. We talk of the world. According to IAEA, this is the figure taken from a Lancet publication of IAEA, I believe. They show that there are like almost 1400 institutes all over the world, and university based, non-university based, private and others. Nuclear medicine is something which is difficult, it is expensive, but as you can say that university based hospitals are the maximum number all over the world anywhere. We are not getting the data from Europe, Western Europe, and from Canada and America added to that. We are talking of like South America, Africa, Eastern Europe, Asia, and Oceania. We are not even talking of like Australia. Their facilities are, I believe, that much more better than the rest of the world. But still, if we talk of all these countries, only 1400 institutes of nuclear medicine are available. Among these, talking of Asia, there are like out of 1400, 800 are present in Asia, and they have got 656 SPECT gamma cameras, SPECT CT 224, planar only gamma cameras phasing out gradually. I believe that that's true for Pakistan as well. And then we are talking of PET scanners. This is something which is need of the hour and the latest development in nuclear medicine. So their growth is something which shows that the priorities of the governments, priorities of the oncologists, the ultimate users, priorities of the private setups. So PET scanners and cyclotrons, they indicate the progress of any country. If we talk of nuclear medicine staff, again in Asia, we have got nuclear medicine physicians, about 3,000 of them, physician in training 450, medical physicists, again part and parcel of our setups, they are like 387 or almost 400, and the nurses are like 1,500. Radio pharmacists, they are like 229 all over Asia, and technologists, they are equal to nuclear physicians. So talking of SPECT scanners per million population in the 212 countries, again as we talk of like Canada and US and Western Europe, there you can see the highest number of SPECT gamma cameras available, more than 10. Talking of the area where we live is Pakistan. This is the country. So here only 0 to 2.5 per million. We have got a population of about 250 million, almost 230 to 250 million. So our number of gamma cameras, I will explain a little bit later, they are not according to the standards which are present in the advanced countries. And now coming to first PET-CT and cyclotron was established in 2010 in Shaukat Khanum Memorial Hospital and Research Center in Lahore. We started working on that, but they took the lead and they started having clinical studies in 2009, and we joined them about 10 to 12 months later, and now PET-CT at Inmol is like 13 years of age, and they have done more than 40,000 patients up till now. PET-CT at Shaukat Khanum contributed a lot. They are adding up to their facilities. They have added one PET-CT scanner in, I believe, Dr. Amna is here, if she can. No.
One in Peshawar and one.
One in Peshawar, one is in another one in Lahore. So there are two of them, and Lahore is the fortunate one, because now we have Pakistan Kidney and Liver Institute, PKLI. Dr. Khalid Nawaz is the person behind the show there, and they have got one PET-CT scanner. There are two of them in Shaukat Khanum, and Inmol is currently having the PET-CT scanner of 2010, but soon, I believe in a year time, they will be having another digital PET-CT scanner. So the efforts in 2009 and 10 culminated ultimately the progression of nuclear medicine in Pakistan overall. Sorry, Dr. Shabana Sahab, ये वाला टाइम निकाल दें.
मॉडरेटर इधर हैं, आप उनसे रिक्वेस्ट करें.
एक्सक्यूज मी, ये आप जरा इसको देख सकते हैं आके. So there are 12 PET-CT and cyclotron centers throughout Pakistan. Are they enough? They are not. We have got a large number of patients which are on the waiting lines, and they are like asking for FDG, which was initially started. Now we have progressed towards Gallium-68 based PSMA, DOTA, and other new pharmaceuticals. But the thing is that the number of scanners, they are operational like 8 o'clock, 9 o'clock in the morning till 6, 7 o'clock in the night, and still we are not able to complete the requirements. So if overall we see that how many PET scanners are there per million internationally, and then what about Pakistan? We are in the gray area. Here somewhere that 0 to 1. Not gray area. So this is Pakistan, this is Afghanistan. So Pakistan is having something like 0 to 1 PET scanners per million. A lot has to be done in this regard. Nuclear medicine in Pakistan, as I told earlier, that atomic energy took the lead in 1960, establishing such things. And initially, they were importing technetium-99m generators from abroad, iodine-131 from abroad, thallium and all the other radioisotopes and pharmaceuticals from different countries. But then, gradually in 1980s, the initiative was again taken by Atomic Energy Commission, and they started producing their own iodine-131, and they have started producing their own technetium-99 generators and pharmaceuticals. Although the number of pharmaceuticals being produced at Pakistani Atomic Energy Commission facility called PINSTEC, this is PINSTEC reactor where all these activities are happening. So they are actually going for indigenization in a sustained manner, and they are developing new pharmaceuticals to fulfill the local requirements.
The last 2 minutes of your presentation. Last 2 minutes.
Oh. So P32 was the first one, lutetium-177, they have worked on that. Samarium was 153 it is. So it was produced for a little while, and now actually they are working on lutetium-177. And because of that, radiation cyanobectomies have been being performed here in Pakistan. Our Peshawar Center, IRNAM, is like at the leading. So theranostic facility, again with the help of IAEA in Mool, Lahore, started the first theranostic lab in 2017. Now these things have been now duplicated at Noori, Shaukat Khanum and Kiran. Kiran is Karachi, Noori is Islamabad, Shaukat Khanum is in Lahore. So far at Mool we have got PRRT, PSMA, and then theraspheres labeled with deuterium. These are routinely being performed. Lutetium is now being produced from, we import them from abroad, but indigenous production is going to be started soon on clinical side. So if we talk of our nuclear medical facilities, then we have to understand that according to WHO healthcare levels, we are having this level and not much of this one. And we have to go from this to this level with the help of our governments, from the private setups, and with the help of the professional societies. How many nuclear physicians are there? Again, we lie somewhere here, only 0.1 to 5, and we are far, far behind. My lecture should have been concentrating on what to do about that, but I think I will leave this thing to the audience to understand that how this thing can be done. So this is just a repetition. I will skip this slide. We have got nuclear medicine education from the PIAS. We started in 1988. The MS program was started. PhD was added. Total fellows so far passed out of 120. Are they sufficient? They are not. Many of them, they have retired. Many of them have left the country, and certain number are still working here in Pakistan. So, and in addition, we have got addition of MD program, 4-year program, in addition to MS 2-year program, and that will be started soon. Nuclear medicine by the College of Physicians and Surgeons was established somewhere in 1998, and first graduate was passed out in 2002. So again 21 years. So far FCPS number of people like 48 of them so far. And if we talk of their roadmap, an MBBS degree is must, house job is must, part 1 clear करना भी एक बहुत बड़ा काम है जिसमें अक्सर लोग बड़ा घबराते हैं, but it can be done and people have done already. So then there are 4-year programs, and then they actually appear in the final exams and they become specialists. Ziauddin University in Karachi, they have got MD program. I don't know, I have been told that there are 3 to 5 fellows have passed out, and all of them they are for the local consumption in Karachi. PNRA is something.
Time is up.
Time is up.
Yeah.
चलो फिर मैं मुझे आखिरी slide
Go
with
to the last slide. Yeah.
Our society was established in 1995. If you see that the Dr. Saida Asghar was the first person who presided that. My signatures are somewhere here, but this person, Dr. Amir, publication secretary, left our country, now is in radiology. Talking of one became radiotherapist, another one still radiotherapist. So Dr. G.M. Shah, Dr. Saeed Asghar, they took the lead and formed this society, and up till now. So we have to encourage nuclear medical education. We have to understand, in addition to nuclear medicine and nuclear physicians and physicists, we have to have technologists, we have to have pharmacists. And I believe that this forum should be used to encourage government as well as people to come to this specialty. So 1995 and now 7 conferences have been done and 8th is in progress. And we have got our own journal. So here I think with the help of international collaboration, national liaison and international meetings, we can achieve what is required of us. Thank you.
Thank you, Dr. Ahmed Qureshi. I guess our chairperson has some comments.
Actually, I have 2 comments only. One is that you put that there are only 9 centers where cardiology, nuclear cardiology is being done, that are dedicated centers. But I think in almost all other centers, some sort of nuclear cardiology is being done. So please correct this figure. Another important thing which I wanted to mention, that I was reviewing one figure that 2018 in United States 20 million procedures were performed in 1 year. So we should not be that hesitant. But one important thing for audience is that when I started in 79, in Pakistan there were only 2 gamma cameras. Now there are, you said, about 100, so still we are progressing.
Yes, thank you. About the cardiology centers, only one thing, they are doing majority cardiology. And our other centers, nuclear medical center, they are doing cardiology plus other things as well.
That's right.
Okay, thank you.
So there is another comment from Dr. Khanans.
There's only one comment, rather one.
Take the mic,
there are
please.
120 graduates, the MS nuclear medicine graduates. Just for your information, there are 204, not 120.
You are talking of physicists as well?
No, only nuclear medicine physicians.
Dr. Shabana, your is the practical one, his is official one. So please.
Graduated from Pyas.
Okay, that's commendable. Role of Pyas is there.
Okay, thank you.
Thank you, Dr. Ahmed Qureshi. Now, our next speaker is none other than Dr. Shabana Saeed. She is currently head of Department Medical Sciences at Pakistan Institute of Engineering and Applied Sciences. She has numerous publications and conference presentations and experience of various IAEA CRP projects. Today, she will deliver her talk on new isotopes on Pakistan's theranostic horizon. Please.
Thank you very much. First of all, I would like to thank the PSNM Executive Council and our President for giving me this opportunity to present my talk, and also giving an opportunity to meet my respected seniors and my wonderful students. Okay, I start my presentation. Now it's about the new radioisotopes on theranostic, rather Pakistan's theranostic. So I would like to talk about the new radioisotopes coming up in the world and what radioisotopes are being introduced, will be introduced in the future in Pakistan. Okay. So I think nuclear medicine is experiencing a very exciting era, and it is because of the theranostic. And NM has now an opportunity to become an established partner in the therapy of cancer. Though theranostic is a form of precision oncology, a real personalized medicine. And our ability to see what we treat and see what we treat and treat what we see is unmatched in any field of medicine. And theranostic, the beginning is, not a new concept, and it has been there since 1930s and 40s, and it has a very humble beginning when first study was published on the role of radioiodine in CA thyroid. And it's because of this person, the Cyril Hertz, who is considered as a father of theranostic, And he was actually chief of thyroid clinic at Massachusetts General Hospital, who introduced the concept of radioactive iodine theranostic and first brought radioiodine from bench to bedside. I will not say much because I'm very glad to see his daughter in the audience, and she will be telling more about his illustrious father. He was a visionary person, and he said that my new research project is in cancer of thyroid, which I believe holds the key to larger problem of cancer in general, and how true he was. As the time went by, the procedure evolved as well. The sodium iodide has two different iodine isotopes, iodine 123 and 124 and 131, has become an important method for thyroid cancer monitoring and treatment. Now, over the last 80 decades, there have been a lot of advances in radiochemistry, enabling us to target more tumors using the same principle. And coming to timeline, theranostic, the first line is the year when the first human study was done, or it was the publication was done, and this is when that radioisotope was approved. And you can see there has been a gap of 10 to 15 years. But however, in the future, we have to be very fast to achieve this goal. Coming to the most important theranostic agents, lutetium dotatate and lutetium PSMA, which were approved recently. And these are actually the two most important trials, the NETTER-1, which gave us the lutetium dotatate, and the VISION trial giving us the lutetium PSMA, which are being used routinely in the routine clinical practices. So whole body images acquired after the lutetium dotatate, and you can see there is a remarkable recovery, remarkable decrease in the metastatic disease. However, still after 4th cycle, there is some disease left. So my question is, what next? What next? And I think most of you sitting here, the nuclear physicians, have seen this wonderful image, which was the image by the Michael Hoffman from Peter MacCallum Hospital in Australia, and which was the image of the year 2018. And this was the presentation which actually changed the perception of the theranostics, and you can see a dramatic change in the decrease in the disease burden, as well as dramatic decrease in the PSNM values. However, I call this good one, but there are bad and ugly ones also, and in which you can see that even after the therapy, the disease burden increased and increase in the PSA level. So my again question, what next? So I will be telling in the next slides what should be done. And you can see most of the studies and most of the trials which were done and which are going to be done in the future employ lutetium-177 because this is the most important, most you can see competent type theranostic therapeutic agent available. However, these are the data from the perspective trial using lutetium PSMA, which was done by the Australian group in this first study, and this is a USA one, and you can see that in this Australian group, there was only 57% of the men, they had their PSA value down. And in this randomized, in this UCLA study, only there was a drop in PSA in only 37% of the patients. The good news was that there was a considerable, they had more years to live. So there was a survival, their benefit was there. And then come the VISION phase 3 trial, and which the standard of care was compared with the standard of care and lutetium PSMA, and you can see there was a survival benefit of few months. So this shows that we need to continue our efforts to improve the therapies, and fortunately, we have a number of methods to do that, and most interesting is the use of different radioisotopes. So we have different radioisotopes, beta emitter, alpha, and Auger. And you can see. So this means the radiation, the Auger, and especially the newcomer, because it is extremely short range, yields the high linear energy transfer, which makes Auger electrons attractive for radiation treatment of cancer, especially if they are emitted in the close proximity of sensitive targets such as DNA molecules. And so we have a wide variety of the radioisotopes to play with, and the beta emitter, the alpha, and the Auger. So I will only concentrate on the above line. because there have been a lot of studies done with calcium, scandium, and thorium, but somehow they are not made into the clinics generally. Now coming to terbium, so I have a very little time, so I'll go fast. The terbium is called a new Swiss Army knife for nuclear medicine. Maybe because they were developed, the terbium isotopes are developed in the PSI and the Sun, which are located in the Switzerland. And it's unique, the terbium isotopes are unique that it represents radioisotopes for all 4 modalities in nuclear medicine. We have a beta emitter, we have a alpha emitter, terbium 152, a beta plus emitter, terbium 155, a gamma emitter, and terbium 161, the beta minus and OJ emitter. So I will take individual one by one. Now coming to the terbium 149 based alpha therapy. And although alpha emitter, okay, you can see that a lot of preclinical studies have been done, and you can see increased concentration in the tumor. And because of the increased half-life, it has a large half-life, so you can see, you can image at different time points. And you must be wondering if it's a alpha emitter, then we still can take the image because it also emits a beat positron. So this is called the alpha PET. However, the only problem is that it is difficult in production and chemical separation, and of course the presence of long-lived daughters and high recoil energy, and which complicates dosimetry and whole body radiation dose. Now coming to the second one, the terbium 152, where this is a PET tracer with long half-life, and this is an advantage because we can again image at different time points. And one study done by Baum et al. Is also done in humans. Again, the problem is the production of terbium 152. It is very challenging. Now, terbium 155 could be produced in the cyclotron with potentially very high yields. And as a diagnostic match, terbium 155 may be of particular value for visualization and staging of malignancy and for dosimetry calculation. It's a good diagnostic counterpart of terbium 149, 161, and actinium-225. Now, the most important one, the terbium 161, and it is considered as a new lutetium-177. It can be produced, it is basically a beta minus and OJ electron emitter. It is a very interesting radionuclide because it can be an alternative to lutetium-177, and its production is analogous to lutetium production with the help of by the radiation of enriched gadolinium-161, and a large amount of terbium-161 can be produced, non-carrier rate can be produced in reactor. And it has all the benefits just like the lutetium. I'm not going to detail in one. The most important one is because of high lead conversion and OJ electron, it delivers 3 times higher absorbed dose to the tumor. So it is much better than the lutetium. And most of the preclinical studies have shown that not only it's a good uptake in the tumor, but it has also shown that there is a decrease in the growth of the tumor in the animal model and increased survival of the mice, the animals. You can see that this is where even the DOTA, it has been labeled with the PSMA and the DOTA. Okay, first in human application of terbium was done again by the Richard Baum, and you can see that not only the biodistribution but uptake in the skeletal mets here. Although it's the gamma emission is of low energy, but still you can see we can get very reasonable images. And another study was done by the Akram and Jordan using terbium 161, and he also got very good results. So again, the question arises whether it is superior to the, it has the superior therapeutic efficiency of terbium 161 over lutetium. Indeed, there have been many studies which actually compare the terbium and the lutetium-177, and the data speaks of themselves that it is much better, it is much superior, and there is increased efficacy of terbium-161. And already number of trials, human trials, are in progress in Switzerland, and of course in Australia, the Hoffman is doing, and in Germany. Now coming to target alpha therapy, we all know that alpha particles are 100 times more potent because of their high lead. And they have been great interest in employing the alpha emitters in the therapeutics. And there are few alpha emitters, but most important, and I'm talking about the actinium-225 and lead-212. So actinium-225 has been considered a potential candidate for use in cancer therapy with high energy 4-alpha and 2-beta minus emission. As a therapeutic has been limited by, but the therapeutic has been limited by the toxicity and the availability of the chelating agents. Still, so now coming back to my previous scans, which I called bad and ugly, and you can see here one of the example. After the 2 cycles of therapy with lutetium-177, there is still quite a burden of the disease in the patients. So the question there was what next? So now we have a question we can employ, and this is an example where actinium-225 PSMA cycle, or 2 cycles were given, and you can see the disease disappearing. Same here, another patient with and this same patient another patient with 3 cycles of actinium-225 PSMA therapy, and you can see the disease vanishing. And actinium PSMA trials are being conducted by the South African group, by Sathige group, and they clearly show the excellent results, the excellent survival, and you can see that almost 100% of the patients which are being, we have a drop of PSA.
Dr. Shabana, sorry to interrupt you, the last 2 minutes.
5 minutes, please. So lead-212, and another very promising alpha emitter is lead-212, and the beauty of it is that it can be produced in generators. For the lead, there are 2 methods. Generators contain the radium source adsorbed resin, and another one a bottle or vial containing the radium source adsorbed on glass wool, and from there the radon-2 emanates, and from the source and decays into lead-212, which can be collected by using HCl. So now coming, since I have very little time, so I'll rush through my slides. So now coming to new radioisotopes on Pakistan Theranostic Horizon. So what we will be getting, we will seeing the, we'll be getting actinium-225, lead-212, terbium-161, and terbium-155. So how it is through the Pakistan and CERN collaboration. We are collaborating with the CERN, the MEDICIS, which is actually, we are the associate member of the CERN, and the MEDICIS actually is a facility contributes to medical research by producing novel radioisotopes. And we will be getting these radioisotopes through there. And they not only supply the radioisotope, they are not producing, they are not on the production facility, but they are actually, they're transferring their expertise and knowledge also. So they are producing radion-225 in a sol day, and then which is being used for the lead generators. And we, since 2021, we have already got 3 shipments of actinium-225 from the MEDICIS, and basically these were actually processed, and they were processed at Equinstic. One shipment was dispatched to INMOL for labeling for stability study, and in future, inshallah, we'll be getting shipment of human-grade actinium-225 for clinical trials in Pakistan. And in future, we will be producing indigenous production of 225 through radium. We have some radium reserves with us, and similarly with the generator. In future, lead generator shipments to Pakistan, they have promised to do that. And moreover, one of our scientists, Princeton scientists, is working at CERN and working on this generator. So he will bring his expertise to produce indigenous development, or for the indigenous development of the generator. And terbium-161, we can produce it very easily in part 1 and part 3. And unlike lutetium-177, it is more easy to produce, more easy to separate, and for which we have already purchased gadolinium-161, the target. And the only problem was with the resins, which again, CERN people have promised to supply these resins for the separation and process. And we will soon be getting shipment of these resins along with the terbium-155. So with all these new radiosondes, enjoy the ride. The new wave is here. Now coming to Theranostic in Pakistan, the past. Then I will take you to a slide presented by Dr. Shazia, our president, in 2014 in Nathia Gali. And just 2 minutes, ये बड़ी interesting है थोड़ी सी, ठीक है? Actually, at that time, she said that at time only radioisotope, radioiodine was being used for this, and very few centers were doing MIBG, P32, radiation cyanidectomy at that time in 2040. Now, come 2023, we have what we are doing, the UNMOL is doing the lutetium therapy routinely, and we have now the indigenous production of lutetium-177 with reasonable specific activity. And we are the Pinstick people are providing the DOTA kits, the PSMA kits, and Hynictate kits. So, and this has been actually used in different patients in Kiran, in UNMOL, in NUM. So future will be getting, of course, these important radioisotopes. So future of nuclear medicine theranostic in Pakistan is not that bleak, and it's quite bright because we are getting new radioisotopes. And only thing is that we should expand clinical trials network through nuclear medicine centers all over the country. We should also train our workforce and promote nuclear medicine as true precision medicine and create competent theranostic centers. So another slide I'll take, I have borrowed from Dr. Shazia. She actually, this was slide from his presentation, and she said, Pakistan ka kaum ka kya banega? My apologies with the foreign participants. So Dr. Shazia, Pakistan kaum ka kuch na kuch ban jayenge as long as we are zinda kaum. and we come out of our comfort zone. And this is one of the my favorite saying, which I also tell my students, they come out of your comfort zone. If you are not uncomfortable every day, we are not growing. Thank you very much.
Thank you very much, Dr. Shabana, for giving us a futuristic insight into the horizon of theranostic radionuclides in Pakistan. And now I would like to invite Professor Stefano Fanti, who is not in person presence here, but he is available online. And Professor Stefano Fanti is a university professor in the University of Bologna in Italy. He has numerous research on diagnostic and use of innovative radionuclides in nuclear medicine. He's a collaborator for IAE and ENM and has numerous publications. He will talk on the theranostics, science, and production. Practice. So, welcome, Dr. Stefano Fanti. Over to you now.
Please start your lecture.
Good morning, everybody. It's my pleasure. Unfortunately, I'm not there in person. I get a presentation, but send it to you. So you mind to send my presentation from there, because my internet connection is very unstable, and it would be much better if you run the presentation from there, and then I will be available for question and answer. Because during the previous presentation, my connection dropped several times. Sorry for that. Yes, please. And then, of course, I will be available to take your question and answer if you can run my presentation. Thank you.
Dr. Fanti, we are running your presentation just now.
Thank you so much. You should also have my recorded audio, or if you prefer, I can talk on that, but again, the connection is not so stable, so if you can run the presentation with the audio, that would be probably more easy for everybody. Sorry for the problem.
Sir, we'll just try running it with audio once. You can mute your mic. If it doesn't run, then you can just continue with it, because right now we can hear you well.
Yeah, I'm muting me now, and if you can run the presentation with the audio, would be fantastic.
Okay,
thank you.
Okay, thank you. Sir, I think that would be better if you could just do it live. and you can just tell me, I'll just change the slides for you.
Okay. I hope that the connection will be stable enough. Well, as said, my pleasure to be here and give you this short overview on PSMA theranostic. Next. Yes, these are my disclosure. As I used to say, my main disclosure is that I'm proudly a nuclear medicine physician. So what you will hear is a talk by a nuclear medicine perspective. Next. So let's start with a bit of history of theranostic. I'm sure that you all know that, but it's good to have in mind our history and root when we start considering the present and the future of theranostic. Next. So let's start with the definition. Again, everybody knows what is theranostic, but it's good to have in mind that it's a process will keep together diagnosis and therapy. And the goal is that individual patient should be tested in order to demonstrate that there is a target that could be used for driving either imaging and treatment. So it's purely personalized medicine. Next. Again, everybody knows that, but it's a very simple cartoon that I like to propose to, for example, our friend oncologist or the student of other specialty. The cancer cell has, of course, overexpression of some target, and that's what we want to really address. That's to say, we have a ligand, which is a radiopharmaceutical, and it's going to be binded to the target very specifically. And if we have an isotope, which is, for example, a positron emitter like gallium or fluoride, we can see the cancer. Next. But we replace the isotope with a killing agent like lutetium, yttrium, or actinium, and we have the theranostic effect. So we can cure. This is very simple, but it's good when you want to show to your colleagues how essentially it works. Next. So the history comes very far, and you will have the privilege to hear that later on today in your program. It comes from the 40s, so meaning that it's really 80 years old, and Sol Earth made it fantastic by creating the iodine therapy. Sorry, I cannot see the presentation anymore. Yes. So, after the successful introduction of iodine therapy by Sol Earth, that was of course used to cure thyroid cancer, the next big success of theranostic was in the field of neuroendocrine neoplasia, so they also called neuroendocrine tumor, by the use as a target of somatostatin receptor that was successfully introduced in the 90s, and then moved on rapidly. In about 10 years, it's been established with yttrium first and then lutetium dotatate. Next. And the concept is absolutely the same. You have overexpression of somatostatin receptor on the surface of a neuroendocrine tumor, and you can use for imaging and for therapy. Next. And these are the impressive data of the NETTER trial, because you know the principles are fantastic, but if you want to convince the oncologist, you have to run good trials like this trial that was multicentric, prospective, randomized, and it demonstrates a clear advantage when you're using lutetium dotatate over standard therapy in neuroendocrine tumor. And this is really impressive. If you see the difference between the lutetium dotatate and the standard treatment, it's clearly in favor. And this has led to the incorporation of lutetium dotatate into the guideline, which is also very important because we need recognition from the oncological colleagues. And then it comes with our target, which is PSMA, which is overexpressed in prostate cancer. That's very important to have a very specific target which is clearly overexpressed in the majority of prostate cancer. So what we want to do is to treat patients like the gentleman on the left that have an increased expression of the target. And what you don't do is treating patients with, like the gentleman on the right, a very low expression of PSMA. So essentially, you treat what you see. Next. And don't forget that not every single cancer cell express PSMA. There is always a small percentage of patients which has no overexpression of PSMA, like 5% of gentlemen cannot be treated simply because they don't overexpress the target. Next. So let's now go into prostate cancer theranostic. Next. Yeah, this is an example from Heidelberg. We are all very thankful to Uwe Haberkorn, Professor Haberkorn in Heidelberg, essentially introduced the therapy. This gentleman has already been treated with almost every possible therapy. You know, there is impressive spread of the disease everywhere, especially in the skeleton. And after actinium PSMA, this very next. This is the very first patient, again, treated in Germany, in Heidelberg, and you see, first was imaged with gallium PSMA, and then treated with more than one course of, in this case, it was lutetium PSMA. And you can see that you can follow up the patient either with imaging and with the classic PSA values. Next. This is the first multicentric trial that was run in Germany. You see in the waterfall plot that about half of the patient has more than 50% decrease of the PSA, which is a good result, but that was a retrospective trial, so it's not high quality trial. Next, please. Sorry, I cannot see the slide, but only myself. Again, very sorry for the technical issues. Yes, next. Okay, and this was the first good trial, I mean, scientific high-quality trial published on The Lancet and run by the Australians that was demonstrating that finally treating with an established regimen of lutetium PSMA, you have good PSA response in more than 50% of the patient. And this, next. And this led to the conclusion that a multicentric trial should be done. The previous study was a phase 2 study, so the Australians designed a phase 3 trials, the very famous therapy trial, which is published in The Lancet. It was 2 years ago. In this case, the patients were randomized to receive PSMA lutetium versus the standard of care, that is cabazitaxel. And patients were randomized and the results were compared. The endpoint was the PSA response. Next. And you see that on the right, the PSA response was much better as compared to cabazitaxel. So clearly superior to the standard chemotherapy, which is done in patients. Of course, we are talking about patients with advanced cancer. These are the curves, again, an advantage of lutetium PSMA over cabazitaxel in metastatic castration-resistant prostate cancer already treated with ARSI and with taxane. The side effects were much in favor, again, to lutetium PSMA, so fewer grade 3 and grade 4 adverse effects. Next. And this is the cartoon. Nicely summarizing the result of therapy trial. That is really a milestone. And after that, the VISION trial came. It was run in North America, it was sponsored by Novartis, and in this case, the randomization is 2-to-1, and it was lutetium versus standard of care. Again, gentlemen who already have exhausted the majority of therapeutical option in metastatic CRPC cancer. Next. A large number of patients were enrolled, and in this case, the primary objective, the primary endpoint was survival, and this is probably the best endpoint you can get, and there is a clear advantage, again, of lutetium over standard of care. And this has led to the registration of lutetium PSMA in North America and in many other countries, including Europe. So the treatment was associated with some toxic effect, but not so relevant. Everybody knows the main toxic effect is about the blood and the salivary glands. And again, the cartoon summarizing the VISION trial that was successful and, as said, led to the registration and the clinical use of lutetium PSMA. Next. This has led to the incorporation into the guideline. That's to say that right now for patients with metastatic CRPC, lutetium PSMA is recommended by all international societies. And also, of course, this is the first one was European. This is the American guidelines that have been updated last year to incorporate lutetium PSMA, which is now commercially available and widely used in North America, many countries in Europe. So which is the current practice and some current problem with the adoption of PSMA? Next. Well, everybody knows not all the patients respond to PSMA therapy. That's to say, we always have something like 20%, 10 to 30%, but an average of about 20% of patients which are not responding. And what we have to do is to identify those patients, because we don't want to treat patients that will not benefit from an expensive therapy. Next. So we need some strategies in order to identify the small part. You see, these are in the blue, the right part that goes up. That's to say their PSA is not lowering, so they will not benefit from PSMA lutetium. Next. And which are the solutions? Well, there are different solutions, and this is probably one of the main current problems. We may add scan or we may use nomograms. Next. This is the Australian response. In the therapy trial, they added FDG scan. It's suggested by them. The concept is simple, just like for neuroendocrine tumor. If the cancer is FDG avid, then it's likely to be very malignant, very aggressive, and non-responding to lutetium. Next. Previous speaker has already showed an images. What is here is the concept that if you are PSMA positive, then you can be treated. If you are PSMA negative, or if you are PSMA positive, but there are lesions which are FDG positive and PSMA negative, then the patient is not to be treated. This is the Australian approach for increasing the likelihood of response. The Americans, I mean North Americans, made it different. They also used the scan, but it was a conventional CT or MRI. That's to say, they got the information from the CT part, and in case they see a lesion at CT, which is cold, so not avid of PSMA, they decide to not treat it. The lesion should be of some relevant size, that's to say, it's measurable, some centimeter, different the size if located in the lymph node or if located in a parenchyma, but the concept is to exclude on the basis of CT or MRI scan. Next, please. The exclusion rate with the Australian FDG approach was 28%, and with the North America, which is more conservative, was about 13%. Next. So, other factors could be derived from the PSMA scan. We have the scan that demonstrates the overexpression of the target, but we can also use some other information, as everybody knows, like the SUV, the homogeneity of the target expression, and the low or high whole body volume expression of the target. So, for example, if you have a very advanced disease with the very heavy and high volume is worse. That's to say, the earlier you treat the patient, the better it is and the more likely that the patient has a response. Next, please. And you have several strategies to calculate this, to calculate the volume, to measure the SUV, and they can also be incorporated. Next. And the concept is you can have some clinical data and some lab data. You put them together with the SUV, with the tumor volume, and you have a sort of a predictor, or if you prefer, a nomogram. Next. And that's been done by the colleagues in California. You can also access that online, and you put all the information of the patient, and you have a calculator. The calculator is giving you a prediction, a percentage of success. It's not stratifying patient in responder and non-responder, and that's the limit. That's to say, you can predict if the patient has a high probability or a low probability, but you cannot really exclude patients from treatment just because the likelihood of response is, let's say, 50%, because in most cases those patients will not have an alternative. Yes, next please. So let's see now the future. What can we expect? And I'm happy to tell you that the future is really now, because literally few hours ago, one of the most expected trial has been reported at ESMO. It was the PSMA-4, and well, here are two other trials, which are the lutectomy, which is to say using PSMA much before CRPC, so in patients which are still in an earlier phase of the disease, because essentially the trend is to that, not waiting for the patient to be castration resistant, but adopted before. I was mentioned the PSMA-4. I'm sorry, I cannot include a slide because it has literally been presented yesterday, but it's in patient which has not received taxane yet, and the results are impressive. An alternative is to change the isotope. We already heard about actinium. This is one of the first trials with actinium. You know, few patients. The phase 3 is still ongoing, so we don't have good evidence so far, but of course it's interesting to use them. And next. As said, what we want is to use it as soon as possible. So right now we are treating metastatic castration-resistant prostate cancer. We want to move before taxane, and as said, PSMA-4 have been reported, and the advantage in terms of survival is impressive. But we want to move even further, so in hormone-sensitive patients, and probably even before. Next. Well, in conclusion, and again, many thanks for inviting me, for not being able, so sorry to be there and some technical problem. Theranostic is a fantastic approach. It really helps the future of our specialty because it's growing in an incredible, fast and successful way. Next. The patient before, if I don't know if we can come back on one slide, it's a clear example of what we can achieve. It was really one of our first patients, and it was also a colleague, by the way. You see, in 2017, he has a spread of the disease. He went to Heidelberg and was treated with lutetium PSMA with a fantastic response. And what is important to me is to emphasize the great quality of life that my friend got it because he was really working with us before, and the duration, because this patient unfortunately passed by, but after almost 4 years of great quality of life. He was treated 2 times, first at Heidelberg and then with a cocktail of actinium and lutetium PSMA, and that's exactly what we can achieve in our patients. Next. So theranostic, in conclusion, is an approach integrating diagnosis and therapy. It's used since many years. The terms is relatively new, but the use is very long-lasting, and it's based on in vivo demonstration of the target. Next. It's probably, oh, sorry, one before thanking Shazia, I want to conclude that, yeah, it's the most rapidly growing area of therapy in nuclear medicine, and it's used in right now metastatic castration-resistant prostate cancer, but more indications are coming. As said, it's clear that after PSMA-4 presentation, there will be more indication for the patient. And my last slide is just to thank you. Thank Shazia for the fantastic job she's doing, for the invitation, and a pleasure to collaborate with you. We're planning to have one colleague of mine coming and run a course in Pakistan, and compliments for all your achievement. And again, thank you so much, and sorry for the technical problems. Thank you.
Any questions with Dr. Fanti from the audience, please? So if we have none, I have a question, Dr. Penty, that what do you think the problem of treating with lutetium PSMA if the dose fractionation is reduced with the higher activity to be given rather than just giving 7.4 gigabecquerels per fraction? Do you see the problem of non-responders is going to change with that or not?
Wow, that's a fantastic question. I wish I could really address this question. I would be really a great scientist. I mean, the problem is much complicated. We really don't know which is the problem. We don't know if we should increase the dose, if we should. Some people is trying to administer like enzalutamide or other drugs in order to promote the increase of receptor, because of course if you have more receptor you can more effectively treat. So your question is fantastic, but I'm not able to address it. I don't think, I mean there are of course many studies ongoing on that. I don't think that it's really an issue of dosimetry, but rather a matter of accepting that some patients have too low receptors, and at the same time their cancer it's probably too aggressive to be effectively treated. We should try to identify them before administering lutetium.
Okay, thank you. And lastly, I would like to apologize on behalf of PSNM that there had been some internet issues on our side. Although we had your recorded talk with us, but we could not run that and you had to do it again. Thank you so much. And there is another question from the audience as well. Please.
Thank you, Dr. Fanti, for an excellent talk. This is Dr. Amna Hassan from Shaukat Khanam. My question for you is, what do you do when, as right now most patients are pre-treated with all sorts of therapies and they come to us with pretty low platelet counts? So again and again we're facing this, we keep the threshold around 75,000 and into the therapy second, third dose patient sometimes even bottoms out. We've seen 28, 20, we've seen symptoms. And clearly the patient is responding to lutetium therapy. So what do you do with low platelets? That's one question. And the other one is, have you gone beyond 6 cycles? You have an excellent responder who's doing really well, but since 6 therapies are what is approved, have you ever used beyond 6?
Again, I'm sorry, I only got the first part of the question because then my internet was frozen for a while, but it was an interesting question regarding the bone marrow activity, the platelet count. I'm fully with you. Sometimes the patient comes to a very late stage of disease with the very exhausted, I would say, bone marrow, and we know that there is a toxicity on the bone marrow, so we want to avoid to bring any, severe effect in these patients. I have to say, usually interference of taxane and also of radium is not so relevant. Sometimes we wait a little bit, sometimes we administer a lower dose in case the platelet count is like 50,000 or something like that. You are trying to adopt your strategy to the individual patients. So you can either try to promote or wait a little bit, but we all know it's patients that sometimes they cannot really wait a couple of months because their expectancy of life is sometimes very short. That's why I emphasize the need to treat the patients before they come to a very advanced stage of the disease. Probably this is the only solution. Now we are just facing the very late application of the therapy, but we are moving much before right now. So I'm fully with you. Different strategies, but not one only solution that may really fit. Probably reducing the dose is the solution, but at the same time, if you reduce the dose, you reduce the likelihood to get a response. So it's a different balance that you have to keep in mind. And I'm sorry, but I didn't hear your second question.
So my second question was, have you gone beyond 6 cycles ever? If a patient is responding well, do you go beyond, or do you wait a bit and then give them another few doses? Your experience in that?
Yeah, I have to tell you, in Italy it's not possible with the present regulation to go more than 6, but as the patient that I showed you, in Germany this is done, and usually if it's a good response or a strategy could be to administer 4 cycles and then decide if moving further, or just like in the gentleman that I showed to you, wait, and you know, if the PSA goes fine, that's to say is not rapidly clears, you can consider to retreat the patients when the PSA start raising. Again, you have to adapt to the individual patient. So there's not one strategy that could fit for every patient, but yes, it's clear that you can treat the patient with more than 6 cycles. You just have to, I mean, if you already achieve a PSA like a very, very low value, probably you can keep this for a later moment.
Thank you.
Okay, with this, we come to the end of the session with Dr. Stefano Fanti. Thank you, Dr. Stefano, for such a nice presentation and answering our questions.
Thank you so much. Thank you so much.
Thank you. So now I would like to invite our fourth speaker, who is Dr. Izwan Syed. He is an experienced consultant with more than 20 years experience in radiology and nuclear medicine. And to my utter surprise, he has triple fellowships in surgery first and afterwards in radiology and nuclear medicine, or otherwise he can tell us more. He has more than 50 publications and is a lead for PET MRI at UCLH. He's a member of E&M academic committees and a reviewer for many renowned nuclear medicine journals. Today he's going to deliver his talk, Run Through Theragnostics, a personalized approach in today and into the future. Please, sir.
Assalamu alaikum. It's an honor to be here, and I would like to thank the committee to give me the pleasure to share my experience and talk about my therapy. It's a very long topic, and I don't know how I'm going to run through, but already Shabana and Stefano has basically explained everything, so I don't need to go into the details. So anyway, theragnostics is a combination of therapy and diagnosis. Put together, it becomes theragnostics. We are into the era of personalized medicine. Before, we used to treat these patients at random pace, so hit and trial method, but now we are very personalized with the ability to offer the right drug to the right patient for the right disease at the right time with the right dosage. So this is what yesterday we were talking about. This will save cost, like Lieutenant General talked about, and we will be able to save money. So a new field of medicine which combines specific targeted therapy based on specific targeted diagnostic tests and a key focus on a patient-centered care. Provides a transition from conventional medicine to a contemporary personalized precision medicine approach. Molecular imaging is a visualization, characterization, and measurement of biological processes at the molecular and cellular level. Radioisotope will localize in the area of concern where it accumulates, thus minimizing side effects and improving the therapeutic ratio. What we need to do is we need to optimally patient selection, optimization of the therapeutic indication, and optimal patient follow-up reliable test. So we need to identify, do a diagnostic stress, identify the patients, select the patients, then you administer the therapeutic dose, the agent attaches to the target cell and starts killing the cell. So it's very personalized and targeted treatment. We have got different tracers, it's already been alluded to, but I'll talk what I'm practicing and I've been practicing. I've been dealing with MIBG, iodine 131, lutetium PSMA, lutetium dotatate, yttrium-90, radium-223. At present we don't do it, it's not available, and yttrium-90 for radiosynovectomy. Therapy depends on the age of the patient, gender, disease being treated, severity of disease, target organs, and radionuclide tracer, what we are using for the specific target organ. All the patients are dealt in a multidisciplinary team. All the patients are referred from outside, goes into the tertiary center. We discuss with all our friends sitting there, make a decision, and then approach to the patient in a very specific manner. We'll talk about thyroid. We can't get away because this was the first, basically, theranostic treatment which initiated long time ago. Some of you attended the E&M last year. There was a big discussion about the guidelines. We have been fighting about it, and especially the Europeans in one group and the Americans on the others, and we don't liaise and we don't follow the ATA guidelines. Because ATA guidelines, I don't follow Europeans. We have got a very specific means of basically treating patients, categorizing them, even though if you categorize them as the low, intermediate, high risk, but still there is a variation. So even in the low risk, where the only exception in patients with unifocal papillary thyroid cancer, less than 1 centimeter in diameter, who lacks evidence of metastases, thyroid capsule invasion, history of radiation exposure, unfavorable histology, tall cell, columnar cell, and diffuse sclerosing type. But the biology changes from the population to population, so you don't see what you see in US or in UK or in Pakistan. Is quite variable. So you need to adapt according to your where you are living, where you reside. So recommendations for ATA is RA remnant ablation is not routinely recommended after thyroidectomy. RAI adjuvant therapy should be considered after total thyroidectomy in ATA intermediate and high risk level, which everybody agrees to. The goal of iodine 131 therapy should be characterized as a remnant ablation, adjuvant therapy, or treatment of known disease using standardized definition. Adjuvant treatment should be based on multidisciplinary management recommendation. This is very important. Conclusion, unfortunately, there is no robust evidence in providing recommendation for radioiodine treatment. The medical societies together, ATA, ETA, ENM, and SNM should be committed to produce joint guidelines for the benefit of patients. At present, they are working together. Hopefully, they will come with something formulative. The next, iodine MIBG. The challenge is to improve the effectiveness of the targeted radionuclide therapy with MIBG. Possible solution using higher dose combined with radiosensitizers. We did a study where we radiosensitize the tumor. When they come to the therapy, we give them chemotherapy, and after 4 hours, we give them MIBG, and the results are quite good. The response rates were about 20 to 50%. So this was our first pilot patient, a child who comes in, we sensitize them, and then after that, a very good response with very faint uptake in the vertex. Another distribution, there is different basically modalities available, and you see the spectrum of uptake. On the left, you have FDG and MIBG. So look at the difference in presentation of the disease. So quite extensive on FDG, but not very significant on MIBG. So another case, again, patient had 1200 MCI and almost complete response after 1 year. Again, different presentation, between DOTATATE and MIBG. Look at the spread of the disease and on MIBG. So you need to do an appropriate test. In UCL, all the patients that comes for MIBG, we do FDG, we do gallium, and we do a triple investigation. And then we have got a mix and match if we want to switch on for therapy, lutetium or MIBG, because of the renal or bone marrow suppression, we can switch. Heterogeneity, we already seen between the three images, basically different presentation because of the heterogeneity. And this was our first case study of 124. It was a research project, and look at the image, spatial resolution better than MIBG, and the spread of the disease, the sensitivity of picking up the disease on 124. This is one of my recent patients who was treated in India, pheochromocytoma, had multiple MIBG therapies, and I gave him 2 doses very recently, and almost complete. His blood pressure is gone, he's not on any medication, he's not diabetic, and now basically he is back to work. Neuroendocrine tumor, probably I've got so many, so basically you know all this, basically looking at the modalities used differently depending on the high grade and low grade. High expression is basically you can see on carcinoid, gastronoma, pheochromocytoma, neuroblastoma, medullary thyroid, pituitary, meningioma, Merkel cell, and small cell lung cancer. I will go quick, and then I can probably, some of the questions which you have been asking, I'll may be able to answer your questions. This is important. So there were some questions, it overlaps with the PSMA as well as neuroendocrine. So you have grade G1, G2, G3 with the KI index less than 3 and more than 20% with mitotic count corresponding to the KI index. So now people are moving towards what combination treatment can we give. So if it is G1, you know exactly, even G2, you know exactly that you can treat with DOTA. But if it is G3, where do you do a PET, it's very avid disease, then what do? The patient goes on immunotherapy or chemotherapy. But there is a segment where they overlap in between, so you can try both. I have tried both, where patients who have come to me, young patients who are not avid on gallium and not avid on PET, but they have responded to the treatment because their diarrhea disappeared, flushing disappeared, blood pressure disappeared, though had symptomatic even though there was not morphological change. So it is important. So this is again high grade, do FDG, low grade, do gallium. So again, just using different modalities, you can see the distribution of the disease is variable. This is again one of my patients. There was a question asked, how long can you go and treat these patients? I've been doing this for 20 years, and I have gone beyond 10, 12 treatment. It all depends if the patient has reserve and is responding. This is one of my patients, local. He was working with me and asked for a treatment, and look at the spectrum of the response. So almost disappeared, but unfortunately then I took a break, gave him chance to recover, and then he came back after 2 years with liver metastases. We resected the liver, and then he came with new bone lesions, and I resumed again, but now he's gone into bone marrow suppression. So there are complications, but still alive. So different presentations, you need to think of what it is. This is a solitary uptake on gallium, FDG. There is again similar patients, so you need to think, you do a cross-sectional imaging, you look at it, there is a central lesion which is causing distal atelectasis, so FDG up in the atelectasis and gallium up in the carcinoid. So again, central lesion, no uptake. So again, no uptake in the gallium, nothing on the FDG. Okay, so a combination of treatments. So this is what I'm envisioning, and I have tried. So we have got Y90 with octreotide, we have got lutetium with octreotide, and we have, Siobhan has already talked about terbium. I've used terbium, but I'm getting problems because of DOH approval, and I'm not getting approval for clinical, but we have under the umbrella of research, I've done one patient, but amazing results. So with this one, we have got a combination with very good disease control rate. If you try combination, if you're not having results with the one tracer, then you can do a combination, but as long as the bone marrow results are there. NETA trial already basically talked about. So if you look at it, there is talk about progression and overall survival. So there is with the dotatate, there is improved in survival. But the thing is with the octreotide LAR, they go on to the high dose in combination with lutetium dotatate. So median follow-up was 8.3 years, median overall survival was 48 months with lutetium dotatate arm versus control arm that was 36.4. So overall response was 80%, stable disease, minor response 55%, complete response was 25%, and progressive disease was 20%. Progression-free survival 2 years with partial response, and overall median was 48 months in NETA-1. So looking at it, basically looking at the gray distribution, so you can see the survival is better, 44%. And in the right, where yttrium is red and lutetium is blue, and both combination is black. So looking at the lutetium has got better overall survival with compared to even both giving Y90 and lutetium. So looking at the grading, so G1, G2, G3, G1 has better survival time. And looking at the ENET, WHO 211 grade, so G1 still better with better survival in months. Again, we talked about the combination. So this one basically, looking at the combination, has got better survival. Okay, so let's talk about NETA-2. NETA-2 basically, I will not go into detail, but it says you can give 7.4, that is the standard dose, and then you do 4 segments of treatment. If they are responding, you continue. This is what I practice, and I can go up to as long as they are responding and they have got bone marrow reserve. The other thing is you can escalate the dose of somatostatin and then combination with the Lutathera. And if you need to stop, you can break and then you can continue after once the patient builds up their bone marrow reserve. I'll just skip that. So G1G patient relapse after initial batch of PRRT with either DOTATOC or DOTATATE, multiple treatments safe and efficacious, and RACES plus persists 3 months after 4 cycles. Conclusion, low incidence of long-term effects, regulating hepatotoxicity, nephrotoxicity, and patients suggest that PRRT could be applied earlier in the disease. Patient to be treated by lutetium with high SSR expression, relatively good performance, and progression under treatment, long-term SST analogs. So prostate, we'll skip this. So we'll talk about this. Basically, radionuclide treatment with lutetium PSMA have high expression rate, low toxic effect, and reduction in pain in men with the metastatic castrate-resistant prostate cancer who have progressed after conventional treatment. I think Stephanie always basically discussed this case. This is one of my patients just now treated before I came here. Look at the response. Amazing response after one treatment with the reduction of PSA 50%. With no pain. The pain is the first symptom that disappears. This is another patient of mine. Look at the response. Amazing response with lutetium PSMA. So another vision trial is already been talked about, so I will skip. We have already, Stephanie has already talked about the comparison between the lutetium and the standard of care, looking at the endpoint, and again there is benefit. So the vision trial talks about the response rate, disease control, and skeletal events, with combination is better compared to standard of care. So by adding lutetium to standard of care regime proved to be more effective to improve outcome in patients with a metastatic castrate-resistant prostate cancer who had failed multiple lines of treatment. So again here, we have talked about the extreme and the middle. So RX2, I can basically go and do a combination, and I can try with the lutetium PSMA as well as with the chemotherapy agents. Toxicity, myelosuppression, and salivary toxicity, nephrotoxicity, fatigue, nausea, and loss of appetite. So I'll skip that. It's already been talked about. Looking at predictor of response. So it is important what Stefano said as well. So looking at the CRP, LDH, AST, and if the patient has got less than normal, then you have got a good predictor response to treatment. Same 50% decline with progression-free survival and overall survival. Same with no visceral metastases. So the question was, can we go ahead? Yes, we can. Basically with 1 to 2 doses, median survival is 28.3. With more than 2 doses, median survival, overall survival is 99.4 weeks. So I'll skip the images. I'll go to the last one. Re-challenge therapy. This was another question. So you can always re-challenge once basically you have given a batch of treatment. You stop, let them recover, and you can start. And if the patient is responding, what I practice is basically if the patient is responding, the PSA drops to a level where they can sustain it, I will stop. And if the PSA trend starts rising, I'll bring them back and re-challenge them, and they respond very well. So conclusion, PSMA therapy is safe, improved quality of life, better overall survival and progression-free survival. Good uptake on PSMA scan therapy should be considered irrespective of FDG status. High-grade renal toxicity should not refrain from PSMA therapy. This was another question for Y90. Is still challenging. I've been doing it for now a couple of years now. These are the indications. This is our setup. You can do the whole liver, you can do bilobar, lobar, segmental. This is basically do 2 sets. Now with the, I think Boston, they are bringing the dose where you can do both MAA as well as the calculation. So this is MAA. There was a shunt, basically gallbladder. We basically include the vessels supplying cystic artery, supplying the gallbladder. And this was abdominal wall uptake. So this was post-therapy. In conclusion, no single tracer identifies all the metastatic site in this group of patient. Combination of treatment with radiopharmaceutical targeting different cells structures may produce better results than either agent alone. Novel tracers may be helpful, especially when other imaging is inconclusive. Radionuclide imaging may help guide therapeutic intervention. Radionuclide imaging may play an increasing role in evaluating effect of therapy. Thank you. I just need 2 minutes. I need an audience because I promised one of my patients I will discuss and I will get their opinion. I had 3 patients which were very difficult, young children, thyroid cancer. Okay, just quick, I'll give you. She's 12 years old, total thyroidectomy, 3 nodes out of 3 positive, 1 ablation, 66 MCI, 2021 avid uptake thyroid beds, 2nd ablation, 100 MCI in 2023. TSH was 5.6 and TG was 9.1, TG-NT was 13.5. 2023 rising trend TG suppressed TG 17.5. FNA right clavicle lymph nodes negative, right L3 clavicle node 3 out of 22 after surgery. In 2022 sharp rise in TG 94. Then 2022 July TG dropped from 108 to 17, PET negative. RAI 100 MCI was administered. Whole body midline level 6 uptake correlate with both images. TG no rise. Now in 2023 TG is creeping. She is a medical student and I've discussed with Mayo. I've discussed myself, my team. I have got a plan, but I just need your opinion. What would you have done to this patient now? Wait, and she's very young, or treat another?
If anyone has the answer, please get up and write down.
You said she's 12 years of age and a medical student?
No, this is not the medical, sorry. There was another medical.
Okay.
She's very young.
Okay, she's very young. Initially, the disease was locally advanced and there were lymph nodes, but you treated with a much smaller dose initially. So my opinion, in such a case, usually it's like we should treat such patients with more than 100 millicurie because you have to do subsequent dosing and which may not be beneficial in the due course of the disease because as you repeatedly treat, you may need more of the iodine. So in the locally advanced disease, I think an aggressive approach from the first dose should have been done. At present, the TG is creeping. What we would prefer to do is you have planned for 100 millicurie, and if we can, first thing is that you have to make the patient more and more iodine hungry, and we usually in such cases where the response is not good, we add some lithium for a week and that increases the residence time of the iodine inside. That I don't know what your legislations over there on the off-label uses of lithium but we do give lithium for increasing the residence time. So these are some intervention that you can enhance the dose delivered to the target and to the tumor.
I agree, and that's what I'm very aggressive with treating these patients. But in the normal oncology and endocrine team, they are very, very resistant in giving. So according to her, basically, that was the maximum we could give. I would have given 100, as I agree. And I have not given to many patients lithium, but that's good because I'd never thought of it, because I used to do it before, but I have not. So maybe we can try that. All right, thank you.
Would you consider a repeat whole body? You did a neck dissection again, right, in 2021?
And still there is uptake.
Only 3 nodes.
There is still, I can still see on ultrasound there is something there, and probably with the resolution, and again whole body is showing at level 6, somewhere in the medius supraesternal notch. So it's very difficult to go in because of 2 surgeries already done to. So the surgeons
but she's
don't
such a young child.
I know.
Repeat doses, you got to think of other issues that may come in. So
I know, that's why, and the parents are very, very, they want an answer because it's the only child.
Localizing the area where the uptake is.
It's just, I can see on ultrasound there is a soft tissue there.
There's a lymph node or something.
It's just a tissue which is not basically, it doesn't conform to lymph node, it doesn't, it's not a muscle, but it's there.
SPECT CT can help you into exactly localizing, and surgical resection can be.
No, they can't go in because they've already operated twice, and it's just around the aortic arch.
Okay.
Could it be thymus? If the patient is very young, so they may develop increase in size of thymus.
It's not thymus. It's a small nodule.
So mediastinoscopy or local camera-based surgery can be helpful in this patient.
No, we know there is disease there, but what is the option? They don't want to go in. Should we treat? Should we wait?
I think we are running short of time.
So anyway, thank you.
We will discuss this later on.
So any questions? No.
But one question is that when in research we see there are a lot of tests being done, and you say, okay, we did FDG and we did PSMA, etc., etc. Who pays for it? In England, I know NHS, but in our problem is that if you ask a second test, even the referring physician, or we ourselves cannot manage it.
No, see, as long as you justify that patient is responding, even in, I've started the service in Abu Dhabi. Abu Dhabi is all insurance based, but in NHS is NHS based. But as long as you are justifying, and then basically you can treat the patient as they are, because you are taking them off from chemotherapy, you are taking them from immunotherapy, TKIs. Those are very expensive. Okay. And as Stefano said, this is what I've been promoting from a couple of years, that I want to get the patient before chemotherapy. ASCO is going on, and this is now the first time they are talking about the patient coming in first and before the taxane. So it will be very promising to see their outcome, but I think we should be getting these patients first, because the moment we get these patients, they are already dead. Basically bone marrow results are completely gone. Okay. And your question about the bone marrow suppression is basically I normally give them a break, transfuse them. Once the immunity comes back, I treat them again. Your last question.
Okay.
So I have one question. In neuroendocrine tumors, if the disease in the lung is avid, however in the liver is non-avid, do you have any experience to use TheraSpheres for liver lesions and for primary disease like in the lung for neuroendocrine treatment?
For TheraSpheres, Y90?
Yeah.
No, we haven't done. If there is a solitary lesion in the lung, we will go and we either basically do the ultrasound guided and ablate it, or basically do the freezing. Otherwise, we haven't tried.
Excuse me, sir. I have a question. I'm Dr.
Sorry to interrupt you. Can we have the question and answer session afterwards? Thank you. Now I would like to invite Professor Nauza bin Rais. She is the head of nuclear medicine department at Ibn Sina Teaching Hospital, CHU Rabat Faculty of Medicine and Pharmacy, Rabat University, Morocco. She is the founder of nuclear medicine specialty in Morocco and director of pedagogy and research in nuclear medicine and biophysics. She has more than 120 doctoral theses in medicine that she has supervised and several publications. She will apprise us of her talk, current status of nuclear medicine and theranostics in Africa.
Thank you very much. Assalamu alaikum. It's a great pleasure for me to be here with you, and deepest thanks to Pakistan Society of Nuclear Medicine and particularly to Professor Shazia Fatima. As you know, nuclear medicine is based on quality management. Quality management is the backbone of nuclear medicine. We need qualified human resources, nuclear medicine physicians, technologists, nurses, radiopharmacists, and radiophysicists or medical physicists. Radiopharmacy is the backbone of nuclear medicine too, and quality control is the backbone. And equipment, we must have quality control of equipment since the hot lab, dose calibrator, and hybrid imaging. State-of-the-art nuclear medicine is currently based on theranostic. It consists in using the same molecule for diagnosis and therapy. Finally, artificial intelligence is also emerging in nuclear medicine and promising development to use functional imaging as a biomarker. The future in nuclear medicine, you explain, you have a relevant presentation in this field, hybrid imaging and theranostic. Hybrid imaging, PET-CT, SPECT-CT, and PET-MRI, they boosted research and development in many areas of interest, such as oncology, cardiology, neurology, and orthopedic surgery. Nuclear medicine creates images using internal radiation wave from inside the body, and its functional imaging versus anatomical imaging in radiology. The role of PET-CT is now really established, and the new in hybrid imaging is the CZT camera, cadmium zinc tellure camera. This new technology may change current practice, such as decreasing acquisition time and activity injected to the patient. The future in hybrid imaging, SPECT-CT will continue to evolve, and whole-body SPECT-CT will be common practice with absolute quantification of tracer concentration, and the gap between PET and conventional nuclear medicine will be reduced. PET domain will advance mainly due to the shift to digital detectors and the incorporation of whole-body PET camera and artificial intelligence. The field of theranostic will continue to advance with new indication and specific tracer, increasing the impact of our specialty on patient care. I just brief theranostic. Since 2000, the number of nuclear medicine procedures increased considerably, and according to the World Nuclear Association, more than 40 million nuclear medicine procedures are performed each year worldwide, with 20 million nuclear medicine procedures performed annually in the United States. Thanks to progress in radiopharmaceutical, the demand of radiopharmaceutical is increasing up to 5% annually. Nuclear medicine has become the essential tool and the cornerstone in several specialties, particularly in cardiology and oncology. Precision medicine weapon against cancer represents not only one of the priority area of research, but also an immense hope for patients in the fight against this disease. And like we see in the last presentation, one stone can kill 2 or 3 birds. we can see what you treat and treat what you see, as this picture from Richard Baum Medical Clinic. The personalized cancer therapy is an old concept since 1999 by Paul Ehrlich. And the father of nuclear medicine and of radioiodine therapy is Professor Sol Herz, and I met a great pleasure to see her daughter in this congress and this audience. The first application of theranostic for molecular targeted radiotherapy in history and the cornerstone of nuclear medicine therapy since 1941. A practice-changing paradigm, effective, affordable, and practicable. The history of theranostic, the commonly used theranostic agent therapy, actinium, bismuth, but also lead and terbium. Thyroid cancer, the incidence is increasing in Morocco too, and we can see the role of SPECT-CT to localize the metastatic disease. Gallium, lutetium, gallium dotatate, and lutetium octreotide in NET neuroendocrine cancer. In our department, we have only technetium octreotide to visualize NET disease, and obviously calcium dotatate and lutetium dotatate were approved by FDA since 2018. For prostate cancer, lutetium PSMA was approved in March 2022. The difference between chemotherapy or immunotherapy and radionuclide targeted therapy is the difference between forest fire and lighting. The success of personalized medicine is very important and relevant because it allows us to have prediction, selection, targeting, and prevention. In developing country, should technetium PSMA replace gallium PSMA, or for few countries in Africa, fluor 18 PSMA versus calcium PSMA. In treatment, iodine 131 PSMA versus lutetium PSMA. In low-income country, the four major non-communicable diseases are cardiovascular disease, cancer, chronic respiratory disease, and diabetes. Every year, 8 million victims in the world globally, an estimated of approximately 20 million people worldwide who are newly diagnosed with cancer in 2020, and 9.9 million died due to cancer. In the next 20 years, a surprise of up to 30.2 million new cases and 16.3 million cancer deaths is estimated globally. Non-communicable disease in low and middle country are responsible of premature death. Each year, 15 million people die from NCD between the ages of 30 and 69 years. Cardiovascular diseases are responsible for approximately 80 million people annually, followed by cancer with 9 million. The number of cancer cases doubled between 20 and 22 and almost tripled by 2030. So it's urgent to establish a comprehensive and integrated strategy. It requires a general mobilization to fight against cancer. And the most common cancer diagnosed in men and women in 2023, prostate, lung, and bronchus and colon cancer in men account for almost 1/2 of all incident cases in men, with prostate cancer alone accounting for approximately 30% of diagnosis. In women who have breast, lung cancer, and colorectal cancer, account for 52% of all new diagnoses, with breast cancer alone accounting for 31% of female cancers. In low-income and middle-income countries, according to the International Agency for Research on Cancer, about 70% of cancer deaths occur in low-income and middle-income countries. Good quality data for cancer incidence and survival are often unavailable in Africa, in some countries in Asia and Latin America. Cancer registries are crucial for the assessment of national control program and other preventive and treatment efforts. What about African situation? The population of Africa is actually 1.3 billion. It will become in 2052 to 3 billion, and in 2100, 4.4 billion. We have strong disparity between developed and developing countries. The area of Africa is bigger than all of Europe, China, and the United States of America combined. The African population is about 1.3 billion and would be 2 to 3 billion inhabitants in 2050. It would involve political, cultural, and ecological tomorrow upsides. In 2023, only 29 African countries have access to nuclear medicine. Many countries with nuclear medicine service are still not capable of performing some very important studies. Now with that, oncological or radiation therapy cannot be established without nuclear medicine imaging and therapy. And when I met the director of the IAEA 1 year ago, I tell him, rise of hope, it's not only radiation therapy, it's radiation therapy without nuclear medicine, without pathologists, without imaging, is not a good radiotherapy. There is an urgent knowing that oncological or radiation therapy cannot be established without nuclear medicine imaging and therapy. There is an urgent need to reduce the existing disparity to establish a relevant strategy.
Professor Nozdar, last 4 minutes.
Nuclear medicine facility in Africa. In all Africa, we have 55 countries. 29 countries was at least one nuclear medicine unit, and one country has only a radioimmunoassay unit. Among 28 countries, 16 have a unique department for all the whole country, and 13 have at least 2 nuclear medicine departments. Highest density of nuclear medicine department is in North Africa and South Africa. According to the data provided by the IAEA, this translates into 0.24 SPECT scanner per million inhabitants. 85% of total SPECTs available in the continent reside in 5 particular upper middle income: South Africa, North Africa, represented by Egypt, Morocco, Algeria, and Tunisia. Cyclotron and PET imaging. These facilities have contributed to the rapid local development of PET-CT in Egypt, South Africa, and Morocco. Priority for establishment and sustainability of nuclear medicine in Africa: human resources, equipment, radiopharmaceutical, and awareness. Human resources and education. Nuclear medicine physician, 5 countries, the same, Algeria, Morocco, Egypt, South Africa, and Tunisia, have an independent specialty and have been offering both undergraduate and postgraduate training for nuclear medicine physician for the past 2 to 3 decades. Training consists of a 4-year program, radiopharmacy and or radiochemie in South Africa, and more recently in Morocco and Egypt, medical physics too. We are very involved in South-South cooperation since 2020. Africa's need. With the exponential growth of nuclear medicine in the world over the last 2 decades, we have lack of quality human resources and relevant equipment, lack of domestic production of radiopharmaceuticals. The pandemic has made us aware of the need of local production and the lack of maintenance and quality management in nuclear medicine. And nuclear medicine is very expensive too. We haven't insurance in all the countries, practically. Africa is the future because Africa is the bigger continent with a bigger population. We need to continue to develop South-South cooperation, and it's the role of association, nuclear association, WHO and IAEA. IAEA played an important role by technical cooperation, but regional project, by AFRA training course or workshop, and also CRP. Nuclear medicine in Morocco. I am the founder of nuclear medicine in Morocco. Morocco is the first country in Maghreb and North Africa with nuclear medicine as an independent degree specialty since 20 years. The first country in Maghreb to have PET-CT since 30 years, with currently 2 private cyclotrons. The first country in Maghreb to produce fluorine 18 FDG since 40 years ago, followed by 18-fluorocholine and recently 18-fluor PSMA. In Morocco, we have 20 PET-CT with 2 digital PET, 2 first in North Africa and 3 in progress. PET in Morocco, in different centers. I am also a leader of WINME, Women in Nuclear Medicine, with group expert of WIN-Global, and I help to achieve gender parity in nuclear medicine with the global community of practice, and we develop concrete measures to attract more medical students and doctors, particularly young female students, to pursue a career in nuclear medicine, and to enhance awareness and visibility of the role of nuclear medicine to support the creation and expansion of nuclear medicine service, especially in developing countries. I am very involved in parity and actively campaigns and fight against gender disparity, fight against brain drain. Till 2003, Ibn Sina was the only nuclear medicine department in Morocco, and now we are 27 departments. Of the 75 nuclear medicine specialists, more than 2/3 are women. Men are mostly in private sectors, while university centers are practically all headed by women. All residents in progress training in the country are mostly women. Conclusion, we need qualified human resources. We continue educational training by AFRA training, IAEA platform, EINM, SFMN, SNME, train the trainers, keep young nuclear medicine specialists in the university sector. Local, we try to have local production. We have just production for positron emitter. Nuclear medicine must continue to shine in a peaceful world.
Dr. Noza, can we just...
Thank you.
Okay. So, if we have time, we can have just one question, please. Dr. Shazia.
Shazia. Thank you very much for such an informative talk about Africa, because we have been hearing about the Asian region and everything, but this is the first time we heard about what is happening in nuclear medicine in Africa. And the interesting point was that 75 percent are females. So probably if we, any of us can give any insight, I can tell that most of newcomers in nuclear medicine, they are females, but I don't have number, but probably.
I think all are female, don't worry. We are actually in a problem to find a male resident, so don't worry.
So probably we have the same numbers or maybe more.
Same is the case with the education system.
Okay, we'll call the next speaker
I think
now.
the problem is in Europe. Perhaps in Europe, not in Asia or in Africa, I think.
Thank you very much. So our next speaker is Michel Kevin. He's a radiochemist and he has his research experience in PARP-based radiopharmaceuticals. He's currently working as a product manager for radiopharmaceutical and radionuclide manufacturer ITM, Germany. And he will deliver his talk on most promising future radioisotopes, gallium, lutetium, and actinium. Thank you.
Assalamu alaikum. I feel very honored and humbled to be invited here, and thank you, Professor Shazia, for inviting me to speak on the topic. So, I will not only speak about the theranostic application of the three radionuclides just named, but I will also try to give you, from within the industry of manufacturing radioisotopes experience, how we can basically ensure and scale supply for nuclear medicine in the future. As I have to disclaim, of course, that I am an employee of Isotope Technologies Munich and dedicatedly in charge of the radionuclides. So basically, I will skip the agenda because we're already short on time. But you all know that when we look at the cultural nuclide chart, we have a really big abundance of radioisotopes available that are potentially interesting for nuclear medicine. But of course, once we apply some clinically relevant criteria to these radioisotopes, we will see that the number starts to dwindle. As we look at things like decay characteristics, the availability, but also the elemental properties in terms of radiolabeling chemistry, we'll see that only, well, not a small, but a handful of radionuclides will remain. And of course, if we look then further, we always have to ask ourselves more specifically, what decay type do we have to have for therapy, for imaging? What is the half-life? Is it suitable for the purpose we need? And when we look at the availability, of course, we don't only want sufficient activities for clinical applications, but we want to have a routine supply, regular and stable and reliable for patient planning. So, and at that, of course, also free from any radioactive impurities in order to ensure the most safety for our personnel as well as the patients. So, specifically, I want to look at the three radionuclides of lutetium, gallium, and actinium-225, which we already heard a lot today. And I will tell you, of course, when I speak why of these three, we can ask ourselves how to find the right partner between the theranostic pairing in the first place. And I think we've heard a lot of talks today already about the different pairing of different isotopes, but just briefly, of course, we can pair our radioisotopes either from the same chemical element or from different chemical elements. And naturally, from a chemist's perspective, you would say, okay, if I have the same chemistry, why shouldn't I directly just go for same isotope pairing? And because this is a new approach, and I would like to give some thoughts to instill the discussion on this. So, when we ask ourselves, when we want to do targeting with radiopharmaceuticals for imaging, for diagnostics, we want to have a high contrast, considerably fast uptake. But if we want to do therapy, what we rather want to focus on is better to have a high and maximum accumulation and retention within the tumor to deposit as much dose as possible for the efficacy of the treatment. Now, when we now look at the pharmacokinetics between the two different categories of imaging and treatment, as I said already, we have two different, let's say, kinetics at work. So if we have a molecule with exactly the same properties, we want them actually to have different properties for the dedicated purpose and optimized purpose we want to have. Also, another point to discuss and to always consider, if we're doing an imaging and radio labeling, we usually use a different mass of the precursor, the biomolecule, than we sometimes do for the treatment. So we cannot necessarily assume that the pharmacokinetics are exactly the same if we use more or less, for example, PSMA or dotatate. And of course, with that in mind, we also have to ask ourselves, can we then actually achieve a comparable molar activity of the radiopharmaceutical we actually administer? And this also is coupled to the production of the radioisotope and its specific activity. So, and last but not least, and I think we heard this in the second talk today already, that the availability is a critical issue, because we want to ensure, of course, when we build a theranostic platform, that we can supply the patient not only with one component, but with both to have and use that potential. So just concluding that on this regard, just because we have two isotopes of the same element, it does not necessarily mean that they are the ideal pairing. It can mean that, but only if all the criteria are met, and this also has to be considered. So maybe to look a little bit again into the pairing of gallium and lutetium. I mean, we've heard it today on several occasions, so I can keep myself as brief as possible. With the NETTER and the VISION trial, and now even PSMA4, of course, creeping up, we've seen that although this is an isotope pairing of different elements, this diagnostic pairing works pretty well. And this has a few reasons, which I would like to show when we look at gallium-68 and lutetium-177 side by side. So we all know, of course, that gallium-68 is perfectly established as a PET diagnostic agent or radionuclide already. But to highlight this specifically, we can see that for both radioisotopes, the production and availability is very abundant so far. With gallium, whether it comes via generator or even via cyclotron production, we can establish almost a routinely supply. And as well for lutetium-177, I think besides iodine-131, we can safely say that this is the most abundant therapeutic radionuclide today and used in nuclear medicine. Now, another point which highlights, of course, the two of them as a theranostic pairing is that their chemistry is very similar. While both, of course, have their optimized chelator systems like, let's say, DATA5M for gallium or NOTA, and also DOTAGA for lutetium, you can share common ligands or chelators for radiolabeling both, so you can still use a theranostic molecule and platform for that purpose. And what makes the pairing so well is, of course, that since both have a very stable and routine and abundant supply, only then we can really ensure and do these big trials like NETTER-1, VISION, and now PSMA4, because we have the supply. And with this, I would basically give the example for lutetium. I have a few examples, of course, from my own company, but this accounts to each and every manufacturer worldwide right now. All the criteria need to be met. One criteria is, of course, we have to look at the actual first-off production. In the case of lutetium, of course, the lutetium NCA production, you need the ytterbium-176 enriched target. This is, of course, not a very abundant resource, so it's expensive, it's hard to come by, and so it's very important that for this process it was also developed to recycle the target material. Only by this you can actually increase the stockpiles much faster and much more than if you just have to basically waste away the target material. And of course, this is something that we should always aim for when we do radionuclide production, not only for lutetium. Next up, we have to have the irradiation facilities. In the example of lutetium, these are not only research reactors by now, but recently, of course, also commercial reactors have been utilized for this purpose, successfully so far. So we can say that this also takes another step towards resilience of supply, because the more reactors and irradiation facilities we do have, and we all know this, research reactors, they have maintenance, they have other experiments running, they are not made to run 24/7, 360 days a year. And I think making a step towards commercializing reactors in addition to research reactors. We can stabilize the supply while still, of course, increase the activity we can deliver at the same time. Now, other criteria is once we have, of course, an irradiation basically established, a network, we need to process the material, because when you, and in this case we have to, for example, separate the lutetium from the target in order to recycle the target material again. So basically all these processes need facilities. And with just one facility, and this we've seen also for technetium generators in the past, or just 2 facilities globally, if there's a technical issue, we run into a supply shortage right away. So even if the network and everything before that is set, if we do not have a robust facilities and a multitude of industrial facilities for processing the radionuclide and delivering it globally, we always run the risk that problems, or even like things like a corona pandemic, which nobody could have anticipated, can lead to supply shortages and therefore impact the nuclear medicine treatment negatively. And while speaking of delivering, last but also here, not least, our nuclear medicine is so dependent on very good logistics. There is never time for customs to say this package needs 1 more day of processing. And we cannot stretch and stress, of course, how streamlined this whole process needs to be. And I think, again, here, it is basically a linear system. So even if this last step, there is a problem, then all the good work that has been put into the system beforehand is not worth if the package or the dose is not delivered in time. Now, oh, okay, good. Maybe then I have to quickly jump basically to actinium quickly as much as possible. So we've seen basically these studies today already, and just why I think that actinium will be the third part in this theranostic pairing is that from the irradiation point of view or the decay point of view, you of course have a different type of decay, and not only I mean by linear energy transfer, meaning you can deposit much more energy and sometimes see better efficacy results, but also because you have a more precise irradiation. Now, why I think that alpha therapy will not replace beta therapy at all is that when we have large or very heterogeneous tumors, the uptake is not homogeneous as well. So what we need is radioisotopes that will still be able to irradiate more or less homogeneously the tumor. And for this purpose, I think a kind of a complementary synergy between actinium and lutetium will be necessary in the future. So, and just quickly highlighting that we need the same, let's say, expertise and technical advances on actinium that we've seen for the lutetium industry already. Currently, we have 4 different manufacturing methods for actinium. The first one is the thorium cows that we all know. It's a very limited supply because we would have to wait for the uranium-233 to decay, which is just a few megabecquerels annually, globally. So this will never solve our supply solution for nuclear medicine. Instead, and I would like to focus on the 4th method just briefly, because the second one bears the risk of producing actinium-227 as a byproduct. The third one has not been tested to meet the scale yet. So let's look into the proton irradiation, because it has been a process that was established already years ago in cooperations between the Technical University of Munich and Actinium Pharmaceuticals. And this irradiation method will yield a product, or basically an actinium-225 solution where you do not have any actinium-227 with a 22-year half-life. You have good activities available and possible to scale even further. And even if there's a small chance of a PN and P3N reaction of actinium-224 and actinium-226, the usual time it takes from the irradiation to when the dose really sits at the, let's say, clinic is mostly about 10 days if you take processing, transport, and also cooldown of the target into consideration. So even then, the actinium-226 levels will be very, very low, and you will have a radionuclidic purity of more than 99%, of course. So maybe to conclude also in this regard, although this was very brief, I hope you could follow me. I think that actinium-225 is positioned with the current methods to become basically the next radionuclide abundantly available for treatment, as much as we've seen it with lutetium in the last 10 years. And I think all the criteria are currently met for this purpose. So in full conclusion then, and I hope that's fine that I still give that, I think we can say that the future of theranostic therapy is not only dependent on a pairing of one or two or like same chemical isotopes, which doesn't mean that we shouldn't be looking further, but I would still say that we basically concentrate and prioritize to use the radionuclides we can already abundantly have today to provide the nuclear medicine. And of course, I think with all the clinical trials about lutetium and gallium, we've already said enough. So I'm happy to take questions.
So if you have,
please.
no? Yeah.
Thank you very much for your wonderful talk. I have a question related with the production of actinium-225. What I understand, the production of actinium is actually very expensive. The reason is the availability of the target and the cyclotron that is required for its production, and as well as the production through the research reactor. So because it is a little bit very expensive, and right now there are some challenges related to its dosimetry, so you should focus those things as well, and you should compare the pros and cons right now. What are the challenges are there in the case of its utilization, please?
That is an excellent question, and especially I want to emphasize the point that, of course, if target material requirement and the whole irradiation process is too expensive, then again, it's another criteria that it must be met. In the case for actinium, because I had to skip through so briefly, also for the proton irradiation, it is very possible to basically separate the radium-226 target from the actinium-225. So you can recycle the target material in the same way as it's been established for lutetium, which is, sorry for that I skipped over that, but of course also another fact that I think makes it more economically viable to really produce actinium en masse.
We have another question from Mr. Nadeem Lodhi.
Thank you, it's nice presentations. I want to ask about how you separate ytterbium with the lutetium, and these resins are easily available, and we can purchase from, if someone want to purchase it, is it easily available?
So, I mean, the dedicated process, of course, is a proprietary process, but so much I can say it is basically column chromatography separation process, but these are very dedicated and specially developed resins for that purpose. So they are not so much like readily available, I'm afraid.
It is indigenously developed at your institute, ITG or something like that, or you purchase from some other sources?
That I cannot comment on,
okay,
I'm afraid.
Thank you, Kevin. Can we have the questions afterwards in the tea times? Okay. So our last speaker is Ms. Barbara Hertz. She is the curator of Dr. Saul Hertz Archives and President Nuclear Medicine at Buckthorn Tutoring and Curriculum Services. She will deliver her talk on Theranostics Back to the Future.
Thank you for this opportunity to honor my father and his work. He must be jumping up and down in heaven, so thrilled that around the globe and some 80 years later, you're building on his foundational work. My mother, this has been a joint venture, real family thing here. My mother saved boxes of primary source materials that document his work and his considerable challenges, including a world war that interrupted his clinical trials. My mother threw out very little in the 60 years that she lived in our family home. I found an old radio program from the 1940s, so he's here to speak to you.
The use of radioactive iodine has reached the practical level and has proved itself effective in patients with overactive thyroid and in cancer cases.
Saul was born on April 20th in 1905 in Cleveland, Ohio. That area of the United States is also known as the Goiter Belt. He earned his Phi Beta Kappa honors from the University of Michigan. In 1929, at the time of strict restrictions for outsiders, he graduated from Harvard Medical School. After completing his internship and residency in Cleveland, he returned to Boston and the Massachusetts General Hospital's newly formed thyroid unit. MGH Thyroid Unit was founded by Dr. James Mees, who in 1931 appointed Hertz as the director. He came as a volunteer and was not paid. A eureka moment in medicine occurred on November 12, 1936, well before the atomic bomb, when Saul Hertz went to a Lunch and Learn lecture. The president of the Massachusetts Institute of Technology, MIT, Carl Compton, spoke about what physics can do for biology and medicine. Dr. Hertz was studying the effect of stable iodine on the functioning of the thyroid. He had been seeking a non-surgical method of treating Graves' disease, hyperthyroidism. Saul solely conceived and spontaneously asked the question to President Compton, could iodine be made radioactive artificially? MIT President Compton's letter answers Hertz's pivotal question. Compton included comments on the qualities of RAI. Hertz wrote back that iodine is selectively taken up by the thyroid and that he hopes it will be a useful method of therapy. So I guess that worked out okay. A special team was established between the Mass General Hospital, MGH, and the Massachusetts Institute of Technology. Physicist Arthur Roberts, with his newly acquired PhD, was hired by MIT's lab director, Robley Evans. In 1937, Harvard sponsored the Hertz-Roberts first series of experiments with 48 rabbits and non-cyclotron iodine-128. MIT physicist Arthur Roberts made I-128. Oh, I'm sorry. The I-128, with a 20 to 25 minute short half-life, was given to the rabbits with altered thyroid gland functioning. The data showed that hyperplastic glands held more I-128 than normal glands. These studies demonstrated the tracer quality of RAI and that RAI could be used to study thyroid physiology, a giant step for what was to become nuclear medicine. Hertz and Roberts wrote and submitted their findings for publication. MIT's Robley Evans, the lab director who had hired the MIT physicist Arthur Roberts, learned that the Hertz-Robert paper had been approved. Robley Evans had taken no part in the experiments, writing the paper, or analysis of the data. Evans reminded Roberts that Roberts' employment contract included that the director of the lab, Robley Evans, be an author to any papers. Evans dictated a letter for Hertz to sign, that the publisher add Evans' name to the author's list. This was a foreshadowing of other difficult situations. Hertz's colleague, Mayasoli, read the rabbit study paper and wrote to Hertz from California, asking about copying the Hertz-Robert rabbit studies. Hertz wrote back, welcome aboard. In 1938, using the University of California at Berkeley cyclotron, Glenn Seaborg and John Livingood made I-130 as well as I-131 with a radioactive decay half-life of about 8 days. A cyclotron was needed for MIT to make a longer-lasting RAI to do clinical trials. MGH's Dr. Means received $30,000 from the Markle Foundation to build MIT's first cyclotron. What a deal, huh? $30,000, that wouldn't buy one nowadays. Means reported to the Markle Foundation, my former House officer, Mayasoli, is working on radioactive iodine. Hertz and Roberts deserve a great deal of credit in getting the pioneering work done without a cyclotron. As soon as the cyclotron here is available, we can progress rapidly. And so they did. On March 31st, 1941, Saul Hertz rushed over the Charles River Bridge with a flask of newly produced RAI made in the MIT cyclotron. Dr. Hertz administered 2.1 millicaries. One of the doctors who was speaking about this said you wouldn't even cross the street to do this experiment, and yet it made all the difference in the world. The first treatment was accepted by Elizabeth D., and it was followed by a Lugol solution to prevent her from having a thyroid storm because they really didn't know if the RAI was going to be effective. About a month later, a second dose was given, and finally her thyroid was surgically removed. The RAI did go to her thyroid, and it was noted that her thyroid did shrink, demonstrating proof of concept. You can only imagine how excited they must have been. Hertz and Roberts continued to treat hypothyroid patients in 1942. Gradually, the first series of 29 patients was developed. This handwritten data chart shows the use of dosimetry to develop a safe, effective, personalized treatment. Of significant importance are the Hertz 1942 first clinical studies to treat thyroid cancer patients with RAI that were given by Hertz and reported to the Markle Foundation. In early 1943, Dr. Hertz joined the Navy during World War II. He felt that his cases had been well established and that the protocol was in place, having used uptake testing and dosimetry in making an effective, safe dose. Dr. Earl Chapman, who treated wealthy patients, worked part-time at MGH. Hertz asked Chapman to take over his cases. Hertz had firmly established the work. Arthur Roberts, Hertz's colleague, wrote, "I would believe nothing on the subject from Chapman, who bungled the follow-up on Hertz's original series when Hertz joined the Navy. Yes, Chapman changed the protocol, making little use of dosimetry, and used a standard large dose and omitted the Lugol solution." Let's see. Okay. Chapman, together with MIT's Robley Evans, who was the director of the MIT lab, we know about him from the rabbit studies, who established 22 new patients. Chapman and Evans want to publish the work in the Journal of the American Medical Association, JAMA, without Hertz's name, and before Dr. Hertz returned from World War II. Chapman and Evans claimed propriety for the discovery of the medical uses of RAI. During the war, many professional meetings were postponed. There was no Zoom back in the day. Chapman and Evans stated in their paper, although Hertz and Roberts were encouraged by their therapeutic trials, the details of their findings have not been published. The editor of JAMA sent back the Chapman-Evans submission for editing and reached out to Hertz and Roberts for their 7th paper on the topic. So, 2 papers from the same institutions were published side by side in JAMA, May 11, 1946. 50 years later, the truth was explained by MGH's Chairman Emeritus of the Department of Radiology, Dr. James Thurall, who stated, Chapman and Evans had basically stolen Hertz's work, the most flagrant, unethical, academically reprehensible behavior. Worse yet, Chapman and Evans spent a great deal of time and effort rewriting history. My dad gathered his courage and harnessed his resources pushing forward. With no Twitter or social media, he relied on newspapers. he went to his hometown paper that gave coverage. A limited number of outsiders were being trained at medical schools. However, they were not allowed on the staffs of most hospitals. And by the way, you couldn't even be a patient at Mass General. In fact, Hertz had come to MGH in 1931 as a volunteer and was not paid. After the war, Hertz joined Boston's newly expanded Beth Israel Hospital. It's at the Beth Israel that he continued to develop and refine the RAI therapy for thyroid cancer. He had funding from a grant from the Navy to use RAI for the treatment of thyroid carcinoma. Hertz used radionuclides with the tracer targeted method. This upset Herman Bloomgart, who was then the director of the hospital, who saw Hertz's work as an economic threat. Also, people were coming from all over the world, by train, by ship, any way they could get to Boston, to understand Hertz's use of radionuclides to diagnose and treat cancer. And here's a little more about Herman Bloomgart. In the 1920s, he was a cardiologist. Herman Bloomgart used radium-C to determine the velocity of blood flow. Bloomgart became angry with Hertz for having the attention and with Hertz's success. Oops. Hertz states, "My new research project is in cancer of the thyroid, which I believe holds the key to the larger problem of cancer in general." That's what you showed this morning. Okay. The Radioactive Isotope Research, The Radioactive Isotope Research Institute was established with the mission of applying nuclear physics to medical investigation, diagnosis, and treatment. There were clinical and lab facilities in Boston and New York. Dr. Hertz was the founder and director. New York Montefiore's hospital, Dr. Samuel Seidlin, was the associate director who managed the New York facilities. Now, you saw this already, but I'm going to repeat it, give you a little bit more background on it. It happened that Dr. Seidlin used RAI to treat cancer when a patient known as BB came to Montefiore Hospital with thyroid toxicosis and metastasized cancer. Years earlier, patient BB's thyroid had been surgically removed. After consulting with Hertz, Seidlin treated the cancer patient with RAI in 1943. BB's metastasized responded to the RAI. No new lesions appeared, and some completely disappeared. However, in 1952, BB died from anaplastic carcinoma. Oops. This journal article documents that Dr. Hertz conceived of using RAI to treat thyroid cancer in 1937 at the time of the preclinical rabbit studies, as well as Hertz's 1942 limited clinical trials using RAI to treat thyroid carcinoma that he reported to the Markle Foundation. The headline reads, "Hertz to use nuclear fission in cure for cancer." Dr. Hertz stressed the targeted approach. He supported the production of I-131 off of the atomic piles that lowered the cost and increased the RAI distribution. Here's a great quote. He stated, "The goiter treatment by means of radioactive iodine represents a first in hopefully a long series of definitive treatments." Before the Anger camera, there was the multiscaler. Hertz developed the multiscaler at MIT. Dr. Hertz is demonstrating an uptake test that he used with dosimetry to make a personalized targeted therapy. The photo was taken at the Massachusetts Women's Hospital, where in 1949 he established the first nuclear medicine department, reported as opening a new division where radioactive isotopes will be used to study and treat disease. Economic pressures made it difficult for REI to be accepted. The REI treatment was $3.40. And by the way, you got the orange juice free. Surgery to remove the thyroid was much more expensive, costing from $200 to $400. The surgeons were... Okay, I could just go to the end. The surgeons and hospital administrators pushed back. You can see here that he went to get some recognition in magazines. And I just want to play this one little video here. Let's see.
The answer is thyroid cancer. That particular variant of thyroid cancer is very unique. And it's because the thyroid happens to concentrate iodine. The thyroid happens to be a unique organ in our body which takes iodine and sucks it up and puts it inside it. It concentrates, it's a little bag of iodine. And therefore, if you make radioactive iodine, it becomes like a Trojan horse. And it goes into the thyroid, and the Trojan horse, because it's carrying radioactivity, will bombard the thyroid with radioactivity and thereby cure some of these variants of thyroid cancer. So it's hard to imagine that exactly the same idea is going to apply to other cancers, but the principle of the Trojan horse, which is to somehow load a payload, an antibody, to payload a chemical to get into an organ and then deliver specifically toxic therapy or even non-toxic therapy to that organ, comes from this idea, comes from your father's, so there's a lineage.
Okay, here's the last slide. The treatment landscape for iodine-resistant thyroid cancer, additional forms of cancer, and benign conditions is changing rapidly, with many new targets, therapeutics, clinical trials, and approved treatments. Saul Hertz's use of dosimetry, REI uptaking test, REI as a tracer, and REI as a biomarker are the enduring essentials to precision-targeted approach. The Hertz-Roberts collaboration integrated the sciences and established a dream team. Globally, multidisciplinary teams are seeking to dramatically improve the human condition with radioactive pharmaceuticals. To conclude, this is from a patient. Treatment with radioactive iodine knocked the thyroid cancer metastatic to a little bit of bone and lung right out of me. I am now 81. We have a large family. Many were praying for me. The cure delivered on the wings of prayer was Dr. Saul Hertz's discovery, the miracle of radioactive iodine. Few can equal such a powerful and precious gift. Thank you.
Thank you, Ms. Barbara. That was quite insightful, and we as a nuclear medicine faculty, we are indebted to Dr. Saul Hertz for his discovery of iodine-131. Indeed. So now I would like Chairperson Dr. Khalid Nawaz to say a few comments about the session.
Well, today is a nice day, and it was first session. In the morning it was thinly attended, but now I am pleased to see that there are many, many people around, and so we all have to be thankful to them that they arrived here maybe little later, but still in time. And we are grateful for the daughter of Dr. Hertz to be here, because that is part of, and I think that tribute is there all the time and all the time to come. So we will remember him all the time to come. I think let me stop here because we are already late in time and some other things to be happen.
So now I would like to invite Dr. Shazif Atmas, President Society of Pakistan Nuclear Medicine, and Dr. Khalid Nawaz and co-chair Dr. Musab, to please present the certificates and souvenirs to the speakers. Dr. Ahmed Qureshi, Dr. Shabana Saeed. Dr. Rizwan Sayyid. Dr. Noza bin Rais. Mr. Michel Kevin. Ms. Barbara Hertz. Now I would like Dr. Shazia to present the certificate and souvenir to Mr. Khalid Nawaz. Dr. Musab Riaz. And to me, Dr. Ambreen Khawer.
Thank you so much everyone for your patience, and now we'll have a short break, tea break, and we'll be starting off again in about 15 minutes time. Enjoy your tea. Yeah. Excuse me, chai break khatam ho gaya. Everyone please be seated so we can start off with the next session. One, two, three, four, five. Everyone please be seated. And for this next session, madams. To request Nawaz Sharif Pakistan पहुंच गया. Really? I was just checking. Madam Dr. Shabana et al, Manan Saab, Dr. Saima et al. Okay, for this next session, I would like to invite Dr. Zagham, and he will be the moderator for this session, and he will take proceedings from here. Dr. Zagham. Dr. Zagham.
Excuse me, sir. Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamu alaikum. I am Dr. Zagham, and I welcome you to the second session at 8th Annual Conference of Pakistan Society of Nuclear Medicine. It is a privilege for me to invite Dr. Ahmed Qureshi to the stage and please chair the session. Professor Qureshi is Director General Nuclear Medicine and Oncology at Pakistan Atomic Energy Commission. He is a PhD in nuclear medicine, and he is among the pioneers of nuclear medicine and PET-CT in Pakistan at Anmol Hospital, Lahore. He has been a faculty member, an examiner, and a supervisor at College of Physicians and Surgeons. Sir, please.
ज़्यादा देर तक तालियां बजती हैं.
I also feel honored to invite Dr. Shehzad Afzal to please come to the stage as co-chair for the session. Dr. Shehzad is a senior consultant and head of department at Pinham Hospital, Faisalabad. Sir, please. With the permission of the chair, first announcement is not very fortunate, as our first speaker, Dr. Dennis Agostini, could not join us because of a road accident, and he had to pull out of the conference at the last minute. So our first speaker is Dr. Hajra Ilyas. She is a fellow of Royal College of Radiology and dual accredited in clinical radiology and nuclear medicine. Presently, she is a consultant in radiology and PET-CT at University of Sussex Hospital, NHS, and Shaukat Khanum Hospital, Peshawar. She will share with us her experience on cardiac amyloidosis imaging. Dr. Hajra Ilyas, please come to the stage.
Assalamu alaikum. I'm honored to be here speaking in front of such an experienced audience. I was asked to speak about cardiac amyloid imaging and also touch on cardiac sarcoidosis imaging in nuclear medicine, which themselves both are pretty big topics. I try to squeeze them in the limited time I have. So I know I'll be reminded to finish in time. So I'm going to talk about imaging of amyloid using DPD, technetium DPD scintigraphy. I'm going to break my talk into a brief overview of amyloid. Then I'm going to talk about a literature available and how DPD fits into the patient management, and look at a couple of cases according to the visual score. So as we know that amyloid is a fibrous proteinaceous deposits which are insoluble, and they have characteristics specific to them on microscopy. When they accumulate extracellularly or intracellularly in organs and give a systemic clinical disorder, it's called amyloidosis. Now, amyloid is classified according to the protein fibrils it forms. Now, the amyloidoses are referred with a capital A for amyloid, and then the abbreviation of the fibril protein next to it. That's how they classify. So AL amyloidosis is the amyloid light chain, which is what you get in myelomas, and this was previously called primary systemic. Then there are the ATTR, and then there is amyloid associated. Those are the types of, that is the type of amyloidosis you get in chronic inflammatory disorders. Now, cardiac amyloidosis. This is, in most parts of the world, it is the commonest cause of restrictive cardiomyopathy, and most forms of amyloidosis can involve the heart, but the two most common forms are the AL amyloidosis and TTR, or transthyretin related amyloidosis, and these are the two I'm going to be mainly talking about today. So what happens when somebody has amyloidotic cardiomyopathy? Clinically, they can have symptoms of fatigue, dyspnea, fluid retention, pleuropericardial effusion. When the amyloid accumulates in the heart, it can cause stiffness, which gives diastolic dysfunction and arrhythmias, and heart failure with preserved ejection fraction. Why is it important to differentiate which type of amyloid is responsible for the affecting the heart? Because the treatment is different. AL is treated with chemotherapy and bone marrow transplant, and ATTR is got medical management with different drugs. Now, how do you diagnose it? The definitive diagnosis is obviously with endomyocardial biopsy. Also use tests like echocardiography and cardiac MRI. And I'm just not going to go into details about any of these. Just going to stick to our topic for today. Now, technetium DPD is the only non-invasive modality that can identify ATTR type cardiac amyloidosis with high specificity, and then can avoid unnecessary biopsies and help patient management. Now, a little bit of review of the literature. Pergini in 2005 did a pilot study looking at the diagnostic accuracy of technetium DPD. The reference standard was histology. They looked at 25 patients, 15 with ATTR and 10 with AL. Their conclusion was that the accuracy of differentiating between ATTR versus AL was 100%. He also described these scoring criteria, which is this visual score guide we use to report these scans. This was extended by Rabezi and all, and they looked at 45 ATTR patients and 34 AL patients. Now, their study confirmed that DPD is useful for differentiating between ATTR and AL amyloidosis, related cardiomyopathy. But their diagnostic accuracy was lower than previously reported due to they found that 1/3 of patients with AL will also have uptake on scintigraphy. A bigger study by Bahar and al. Showed that 158 patients with clinical cardiomyopathy with ATTR had 100% positive scans, and the median grade of uptake was grade 2. 13 further without clinical cardiac amyloidosis had positive studies. 51% of AL with clinical cardiac amyloidosis had a positive scan, but with the median intensity of grade 1. So what is Pergini grading, or the visual scoring system we use in when we report amyloid scans? Grade 0 is there's no cardiac uptake, but there is normal bone uptake. Grade 1 is when the cardiac uptake is less than bone. Grade 2 is moderate cardiac uptake, which is greater than bone, but the bone uptake is attenuated. Grade 3 is intense cardiac uptake, with mild absent bone uptake. So a few cases with the examples. Grade 0 is, you can see there is no uptake in the heart. I'm not sure how. But there is normal bone uptake. So this would be grade 0, a negative study. Another example, we would tend to do SPECT CT in these patients to see if there is anything on anything at all on the SPECT CT images in the myocardium to confirm they are negative. Then grade 1 is when there is mild cardiac uptake, but the uptake is less than the bones. Now, these, you can see this faint uptake in the heart. So all these patients would have a SPECT CT, and then you can see on SPECT CT that there is myocardial uptake. So these will fall in grade 1. Got some example of grade 2 as well. You can see there's moderate cardiac uptake, and the bones are looking attenuated. So heart uptake is more than the bones. So the tip to differentiate between grade 2 and 3 is that if you can still count ribs and vertebrae, it would fall in 2, but long bones are more difficult to see and they may be absent. So as I said, if you compare, you can see the vertebrae and ribs in this one, and in grade 3, the ribs and vertebrae cannot be counted easily. So the grading, in a summary, you can see from grade 0 to 3, increasing uptake in the heart while reduced uptake in the bones. So a consensus was required to decide to use these in diagnosis of cardiac amyloid. So specialist centers in the US, France, Italy, Netherlands and UK in 2014 looked at patients being referred to them. They had 1498 patients referred to them. Of them, 1217 were suspected to have cardiac amyloidosis. The question they were looking at: can bone scintigraphy be used to diagnose ATTR amyloid cardiomyopathy without using a biopsy, but using other imaging modalities and lab data? They looked at 374 patients who had the endomyocardial biopsy. 261 had ATTR, 62 had AL. 4 other types of amyloid cardiomyopathy, 47 had no amyloid deposits on biopsy. They found that 99% sensitivity for ATTR, that from grade 1 to 3, they had positive scans. But the specificity was 68%. That is mainly because AL type amyloid cardiac myopathy does also take up DPD. Now, if grade 2 and 3, we just looked at grade 2 and 3, the specificity rose to 87%, but the sensitivity reduced to 91%. There was only one patient with ATTR where the endomyocardial biopsy had a negative scan. When they looked at that, the biopsy, they had very few scattered deposits of amyloid, and even the interventricular septum thickness was just, it wasn't very thick, it was 10 millimeters. So specificity rises to almost 100%. So it becomes 100% specific for ATTR if you exclude patients with monoclonal proteins in the serum or urine. So the consensus they reached was that in a patient with clinical features of cardiac amyloidosis, as heart failure, syncope, arrhythmias, if they have a positive echo or a cardiac MRI, and they don't have any monoclonal proteins either in the serum or urine, and they have a scan which is grade 2 or 3, it is reliably diagnostic of ATTR. You don't need a biopsy. So the tracers which were developed for bone scintigraphy are commonly used. Most studied one is DPD. And I think that's not approved in the US, so they use technetium PYP. HMDP has less literature, but is also being used. The mechanism of action, it's thought it binds to calcium dependent mechanism. There might be microcalcification in the amyloid deposits. So how do we do the scan? We give it 700 megabecquerel. Imaging time, it's, as we know in nuclear medicine, there are different protocols in different departments, but generally it's recommended 2.5 hours, 3 hours post-injection. How we did things in my previous hospital was that we would, after the whole body image, a consultant would review the images and decide which area needs to have a SPECT CT. Most of the time it was a thorax, sometimes we would include the abdo-pelvis as well. The total radiation dose is 6.8 millisievert, of which the CT of the thorax contributes 1.2, and the radiopharmaceutical dose is 5.6 millisieverts. So when you report these scans, how do you report them? You look firstly at the heart. Is there cardiac uptake? Yes, no. Then if it's not, you do a SPECT CT. Is it truly negative? You adjust the grayscale. What's important to look at is it is actually myocardial uptake rather than blood pool in the ventricles itself. Then you can comment on distribution. Look at the bones for the visual scoring. And if there's any incidental finding on the bone scans, obviously you're going to flag that up. Now, just a few points from the SNC and A&M cardiac amyloidosis practical points. So when reporting this suggests that if you get a score of 0, you can just say it's not suggestive of amyloid disease. If it's grade 2 and 3, you can say strongly suggestive. Visual score of 1 is equivocal. You have to interpret these results in context of prior evaluation. If somebody is echo and cardiac MRI are positive, a strong clinical suspicion, even if the scan is negative, then you would recommend myocardial biopsy. Meaning is that if it's a negative scan, it doesn't 100% exclude cardiac amyloid disease. It's also important to exclude a monoclonal process in the serum and urine, irrespective of scan results. Now, equivocal results, even positive, could represent AL amyloid or early ATTR cardiac disease. So, summary, it's a useful non-invasive method of assessing for presence of cardiac amyloid. However, negative study does not exclude cardiac amyloid. You should look at SPECT CT for subtle grade 1 effects of soft tissue uptake. Talked about the Pergini grading, cardiac uptake versus bone uptake. DPT alone cannot be used to differentiate between AL and ATTR or other types of amyloid. But if a patient has grade 2 or 3 uptake, has a diagnosis of ATTR is likely in the presence of a positive echo, MRI, and absence of monoclonal proteins. This may have a role in early detection of cardiac involvement in variant ATTR that is preclinical, that is in screening, which may allow alteration in the management early. So I've tried to summarize cardiac sarcoidosis. It's a big topic, and just talk very briefly about it. It's a granulomatous condition. It's sarcoidosis, as we know, is high incidence in women in Japan, Africa, Afro-Caribbean communities. It affects the lung and lymph nodes and other organs. About 2 to 5% are estimated to have cardiac involvement, but up to 25% at postmortem have been found to have cardiac involvement, patients with sarcoid. Now, cardiac sarcoid, it's silent, conduction defects and ventricular arrhythmia. A patient can have those, can present with congestive heart failure, they can have chest pain, they can have sudden death too, unfortunately. Pathology is, as we know, it's an inflammatory process in the heart. It can give scarring. The areas primarily involved are the interventricular septum, posterior parts of the ventricle, and anterior left ventricle. The definitive diagnosis is a biopsy, which shows non-caseating granulomas. Steroids and other immunosuppressants are the treatment, and some patients may need cardiac-specific treatments like devices, ICD, etc. A little bit about the imaging. CT, it's very non-specific, you can hardly see anything. Really, maybe you can see in advanced cardiac disease, only a bit of thinning. But then you can see extra cardiac manifestations in the lungs and lymph nodes, etc. MRI is the modality of choice, though it's non-specific. Pattern disci, which are characteristic but obviously not always present, are late gadolinium enhancement, nodular midwall T2 hyperintense foci, and areas of myocardial thickening. Echo, you can get a wide range of changes from diastolic dysfunction to focal thickening and scarring. FDG is being used, and there is FDG-avid disease in areas of heterogeneous myocardial thickening. Being used in detection as well as treatment response in cardiac sarcoidosis. FDG has been found highly sensitive for the diagnosis of cardiac sarcoidosis. A systemic review and meta-analysis showed sensitivity of 89% and specificity of 78% respectively. So the difference in imaging for cardiac amyloid compared to the other FDG PET CTs we do is the patient preparation, because the myocardium uses glucose for its metabolism. We need to suppress that to be able to look at the inflammation in the heart. So there are 3 ways it's done. I'm more familiar with the first 2, but I've read that in the literature that some people do give IV unfractionated heparin to reduce glucose uptake by the heart. Most of the time we ask for prolonged fast. 18 hours or more is considered ideal. In the fasting states, the heart starts to take up lipids for metabolism. So hence, unlike, it's not going to take glucose. Heavily restrict carbohydrates from the diet in the 24 hours before the scan, and use a high-fat diet. So there'll be increased FDG uptake with inflammation.
Sorry, we are running short of time, ma'am. Please
Sure,
sum up.
I'm just going to summarize that. So you can combine it with perfusion imaging. So this is how it's done. You can inject, wait 90 minutes. Different departments have different protocols. Some also combine, many are combined with perfusion assessment. You can see in the first, this is a well-prepared patient. There's no myocardial uptake. This one has got diffuse uptake, so poor patient preparation. If there's focal uptake, suspicious for cardiac inflammation, obviously you'll compare with MRI. If you're doing perfusion, then you will compare the perfusion imaging with the FDG imaging. You will see if there are any areas of reduced perfusion, if there is focal uptake, then that will be active inflammation. But if there is no uptake, even then it's likely to be fibrosis. So same couple of examples. You can see multiple focal areas uptake in the myocardium. So you report them as focal uptake. Diffuse can be poor preparation or no uptake. So this is a patient, this is the most recent scan I found, is 54-year-old and diagnosed with cardiac sarcoidosis on this PET, started on steroids and methotrexate, and then her follow-up scan in June, you can see there's no myocardial uptake. So PET assists in diagnosis, gives prognostic information, can also tell us about extra cardiac findings. It's being used in response monitoring as well. I'd like to thank some of my colleagues, current and previous, to help me get some of these images. Thank you for listening.
Open for questions.
Nice overview. I have got 2 or 3 questions. You don't do quantification for these?
No.
Yeah.
It's just visual. It's a visual score.
So you don't do?
No.
And
so it's semi-quantitative, it's visual. And I think even the guidelines, both the American Society of Nuclear Cardiology and ENM both suggest visual scoring.
But now there is a trend, there is a multicentric trial going on.
There's trial going on, but yes, not in clinical practice yet.
Yeah, and the other question is you don't do 2-point study. You just do one.
We do 1 point. We don't do the 1 hour and delayed one.
You don't do 1 and 3 hours.
No, we don't.
And the SPEC, there is a very recent article that has been published, which basically, on the planar images, you see the uptake in the heart, which is probably equivalent or similar. Yeah. So they basically suggest that you go back and look at the SPEC, and if there is, like what you said, there is increased blood flow.
Blood pool,
so
or if even it's muscle uptake, or it's, So yes, so we at Guy's, we used to mainly do it for grade 0 and 1, if there was doubt. But I know that many places even do it for one where it's grade 2 and 3, just for confirmation and also to map out the disease. Yes, so yes, we only do it, as you said, to see.
The last question is, do you have any comparison between PYP and DPT?
So I looked, searched a lot for it. There have been, there are no trials with big numbers, but the small ones, the results are almost comparable. I think I saw one where they said the DPD shows is slightly more reliable for the severity, and PYP for the extent. But overall, there's not much difference. So PYP, DPD, and HMDP, they are considered more or less equivalent. So the big trial I spoke about, because it involves so many countries, they used all these three. The only bone tracer I think they found which was less sensitive was MDP. But these three, they are considered equivalent.
Thank you.
Do you have any experience whether MRs are cardiac imaging is more sensitive or specific than FDG?
MR are the modality of choice, yes. PET is used along with MRI findings. So you do an MRI first.
Okay. And what's your experience, like if the patient having cardiac sarcoidosis, so does it show uptake if the patient simultaneously having brain or sarcoidosis
elsewhere?
Yeah.
Yes. So you can pick that up as well on the same PET CT.
Okay. Thank you.
My question is why MDP is less sensitive as compared to DPD or HMDP?
I'm not sure why it's not sensitive. It's how it binds possibly. But that's what, I mean, the small studies, most of the studies have used small numbers because I think you can't justify doing 2 scans on the same patient. But they found it to be less sensitive.
Sorry, I have a question because all are phosphates group. Yes, we know. And when you use hydroxymethylene, then it works. But when you use only methylene, then it
might be
low.
the chemical composition.
Maybe,
then, yeah.
yes. But do you have any comparative study? Did you do this on your patient?
No,
why?
No, we didn't do, we only used DPD. But I did look up literature for my own interest. As well, that there have been studies done, but they're on very small numbers.
Yes.
But so most of, as I said, MDP was found less sensitive.
Yes. Okay.
Madam, my question is SPECT-CT is necessary in all the cases or just grade 0 and 1? Or we do SPECT-CT in all the cases we do for cardiac amyloidosis?
So as I said, I think it's very different between departments. Everybody has their own protocols. In our department, the protocols was only for grade 0 or 1. But I know other departments do it for all, say, all the grades. So it's a very departmental choice rather. I suppose that would be dependent on the amount of patients you have and your resources and experience.
Question. You have used DPD and as you say that DPD is deposited in the granulomatous.
Sorry?
Granulomatous tissue. That's how it is.
No, amyloid, yes.
Yes. So there are other granulomatous diseases. So are there any like publications which indicate that DPD is deposited in other granulomas?
So granulomatous, it would come under sarcoid really. So amyloid is basically deposition of amyloid, and that's separate to granulomatous diseases. So yes, SPECT is used for granulomatous like sarcoidosis, and if it's a granulomatous, I suppose the other one I can think of TB, then it would be positive, but then that would be PET.
And second thing, as you have mentioned, that the imaging is done 2.5 to 3 hours after injection. And if you would do earlier, there are a lot of, maybe there is a lot of cardiac blood pool activity.
Yeah.
So
yes, I think some centers do 1 hour and then they repeat after, I think it's 2-3 hours. So people have different protocols, but we stick to 2.5 to 3 hours.
Just one more question, please. From where you buy DPD? Because DPD is not manufactured by most of the distributors. So, and it's, I think, as per my study, US has already banned to use the DPD for the cardiac amyloidosis.
Sorry?
US has banned to use the DPD for the cardiac amyloidosis, particularly because there is no FDA approval for this study.
So they haven't banned it, it's just not approved, so they use alternatives. We had a radio pharmacy. I'm not entirely sure where you can purchase DPD. I'm sorry. I'm not sure if it's available in Pakistan. Somebody else. UK. It's available, yes.
Okay.
Yeah.
Yes, we're still using DPD. And the results are amazing as compared to the PYP. So my patients, what I'm doing now, all of them are negative except for one, equivocal. And we do both quantitative and qualitative.
Oh, you do
so it's amazing the results what we see in the UK and the rest of the world is totally different.
Yeah. Thank you.
Thank you, Dr. Hajra. Our next speaker is Dr. Kaisar Hussain Siraj. Dr. Siraj is a senior consultant in nuclear medicine and PET-CT at Farwania Hospital, Kuwait. He's editor-in-chief, World Journal of Nuclear Medicine, member board of examiners at ABNM, and an IAEA expert on nuclear medicine. He will make us wise on multimodality imaging in coronary artery disease and their appropriateness criteria.
Thank you very much. It's been good to be here after a hiatus of 30 years. The talk that I've been given is it's not started yet. Okay, non-invasive multimodality imaging in coronary artery disease. It's a huge topic and I'll try to stick to 20 minutes. I've deleted a lot of slides here. Basically, the outline of the talk is what is multimodality imaging here, the role of non-invasive MMI in the diagnosis of CAD. We discussed the nuclear cardiology, SPECT and PET, coronary artery calcium scoring, briefly CT coronary angiography, echocardiography and cardiac MRI, briefly the appropriateness criteria because of the paucity of time given, and then conclude the talk. I hope to do it in time. So what is multimodality imaging for the evaluation of CAD? It could be hybrid or fusion imaging, interpretation of two images of different modalities for cardiac imaging side by side through integration of function and structure, morphology like CT angiography in a single procedure, or it could also mean the clinical role of the different current non-invasive imaging modalities in the diagnosis of CAD. You can take what you want, whether they are hybrid or they are side by side, it's still the same. What it does is increases the diagnostic accuracy and efficacy of the coronary artery disease diagnosis and allows assessment of the functional consequences such as myocardial hypoperfusion on SPECT or PET, of anatomical pathology such as coronary artery stenosis. Non-invasive cardiology imaging started with nuclear cardiology first, which is currently SPECT and PET. There's echocardiography, calcium scoring, cardiac CT, cardiac MRI, and ultrasound. So nuclear cardiology started with the advent of the gamma cameras, the Anger camera, and then we had the myocardial blood pool traces labeled RBCs and HSA, and we went in the 1970s through the introduction of the myocardial perfusion tracers, and this is one of the initial examples of what we used to do here in the Nuclear Medical Center in AFIP, thallium-201 scan, normal with left ventricular hypertrophy, and blood pool imaging using technetium albumin scan. So over the years, the nuclear cardiology evolved with the advent of single photon emission computed tomography, we had pharmacological stress agents, and then the technetium agents came in, and we started having gated acquisition and with improved counting statistics, etc. So currently, non-invasive cardiac imaging is SPECT and PET, gamma cameras and PET cameras, and they allow myocardial perfusion imaging, allows cardiac stress testing exercise or pharmacological. We have gamma cameras as well as PET now, and for quantitation we can quantitate perfusion and function to diagnose ischemia infarction and myocardial viability and also detect cardiomyopathies. So SPECT myocardial perfusion scan, as you know, HLA, short axis and VLA, and this is an example of LAD ischemia, pre-stenting and then post-stenting. Just a few examples very quickly. This is a fixed perfusion defect. This is an LAD infarct. Here is a fixed perfusion defect in the inferior wall, inferior MI, and in, as we well know, the Achilles heel of our nuclear cardiology screening short of PET is the balanced ischemia when we cannot see a relative difference, and that is our Achilles heel. We can discuss non-ischemic, we can actually diagnose non-ischemic and ischemic cardiomyopathies. And now, in recent few years, we have now SPECT CT cameras. They are 16 slice and even increasing, which allow us, in addition to the myocardial perfusion imaging, we can do SPECT CT imaging for attenuation correction, which is really very nice, as well as coronary artery calcium scoring using the SPECT CT cameras. And with the PET, we can of course do further up. This is something I did 3-4 days ago. You can actually look at your myocardial perfusion scan with the SPECT CT scans and actually look at the low resolution images to do incidentalomas, and also look at a picture of qualitative rather than quantitative picture of core calcium scoring. So just show you an example. I was looking at this and I looked at the CT part, and you can see a breast mass here on the left side, and which also has MyoView uptake, and then we put that in our report, but nobody did anything about it because they were not really interested. And 2 years later, the patient come up with this sodium fluoride scan with multiple metastases. So it is important to look, if you have done even a low quality CT, to look for something else that may be hidden there. It is done, it is there. It may be not diagnostic, but you may actually find something that is of importance. I also look at always these raw images to see if there is absent gallbladder activity, to look for gallbladder problems. And here we don't see any gallbladder activity, and then we look at that and we have a stone in the neck of the gallbladder. So interesting. Similarly, another one I showed, there are pulmonary nodules in a 48-year-old female with atypical chest pain. MPI is abnormal, but the CT component shows pulmonary nodule that turned out to be sarcoidosis. It's useful to have a look at the CT component anyway. So with the cardiac CT, we can do calcium scoring as well as cardiac CT angiography. The basis of calcium scoring is basically calcium scoring helps with the traditional risk factors, age, cigarette smoking, total cholesterol, etc. And you divide them due to the systolic blood pressure, etc. into low, intermediate and high risk group. And what the calcium scoring does, the risk category determines the therapeutic intervention and the lifestyle changes and target the LDL goals. Traditional risk factors, however, only predict 50 to 80% of the cardiac risk, whereas the calcium scoring helps qualify the conventional risk analysis and is appropriate for risk assessment in asymptomatic patient at that stage. So you can visually assess the calcium score. There is no calcification, mild to moderate calcification and severe calcification. The prognostic value of coronary artery calcium is that the survival is proportional to the degree of calcium scores or coronary artery calcification. The facts are that coronary calcium is a surrogate marker for coronary atherosclerosis. It provides cardiac risk stratification with a low radiation dose, and basically if the calcium is absent, it is a very low risk, less than 2.5%. The role is to screen patients with moderate cardiac disease. Positive calcium indicates an incremental risk. It alters the therapeutic goals and identifies patients who do not need any further evaluation and can be used as an ongoing management tool. So now we come to PET imaging. We have discussed that in the workshop yesterday, so I'm not going to go too much into it. For perfusion, we use rubidium, oxygen, and ammonia, and for viability, we use FDG. There are several technical advantages of PET over SPECT, and these are accurate depth-dependent attenuation correction, high spatial resolution, high temporal resolution, and we have tracers with higher extraction fractions and shorter half-life, and the results are less equivocal and the image quality is much, much superior. Example of a ammonia PET normal myocardial perfusion image, normal cardiac rubidium PET, and an abnormal cardiac rubidium PET MPI with infralateral wall ischemia, as you can see as marked by these arrows here. So when you compare PET with SPECT, here we are, the PET has an overall, PET is more sensitive with higher accuracy and less artifacts. PET quantification is a new thing, and it allows quantification of both the myocardial blood flow and the coronary flow reserve, and this is really very important in differentiating the macrovascular coronary artery disease from microvascular coronary artery disease. Abnormal flow reserve in regions with angiographically normal territories in patients with coronary artery disease depicts early functional vascular abnormality, which has changed the traditional paradigm of using the MPI for diagnosing obstructive coronary disease to detect patients who are at risk of developing coronary artery disease and detect patients who have preclinical, not yet obstructive coronary artery disease. Next, we come to echocardiography. Very quickly, we have dobutamine stress echocardiography as myocardial contrast echocardiography, and this is left ventricle at different stages of dobutamine stress echocardiography, and here you can see anterior wall showing abnormal velocity response, which coronary angio shows significant LAD stenosis. Myocardial contrast echocardiography is based on the detection of two basic components of perfusion, the myocardial blood volume and the capillary level and the rate of flux of that volume through the tissues. These are the examples. Here is a normal scan, and we have reversible ischemia on the second image, stress and rest, and a fixed effect on an infarct, which hasn't. So it is, however, the MCE hasn't reached its potential because the contrast agents are not available, there is no expertise, and no reimbursement. Now we come to the cardiac CT angiography. You can see the exquisite quality images, and it is used for a diagnosis of lot of pathologies, but the triple rule out of coronary angiography, you can look at the aorta for aneurysms and pulmonary embolism, all three in one go in one case. So this is an example of normal coronary arteries, and you can see here the stenosis, and look at the beautiful resolution here. So it not only gives you the luminal narrowing, but it also gives you the plaque burden, which cannot be diagnosed through the conventional invasive angiography, and you can see it here. So there is a auto-regulation when there is plaque, where it is narrowing a coronary artery, then auto-regulation, other mechanisms come in to dilate the vessel at that time, and that cannot be detected by invasive angiography. However, in here you can actually detect, here we see the plaque as well as the fact that there is no significant stenosis. So in that case it is better. The other thing that it is very good at, it is to getting and diagnosing coronary vascular anomalies, which cannot be detected by invasive angiography in most of the cases. Now we come to the cardiac CTA rule, and it is a diagnostic tool with a high negative predictive value. It adds incremental diagnostic and prognostic information, and it's probably better in the lower risk patients with the CAD, whereas SPECT may be better in patients with a high pretest likelihood. So when to refer a patient for cardiac CT? When it is low, you don't do anything. When it's high, proceed to invasive coronary angiography. When it is moderate to high, you go for the perfusion scan and you go for a CT angiography when it's low to moderate. Now we also have hybrid PET-CT with CT part component which can detect atherosclerosis with functional significance of that particular lesion provided by PET or SPECT. And now you see a normal RCA here, and we can reconstruct it various ways. And here is a very tight stenosis, which you can see with the arrow in the LAD, and the effect of that stenosis on the myocardial perfusion, which you can see on that hybrid image. Cardiac MRI, this is an example of a normal perfusion CMR and abnormal perfusion study in a patient with left main stem disease. And then this is an example of a contrast MRI, inferior MRI 6 days post contrast enhancement, and an anterior MRI here. So the advantage of cardiac MRI are multiple, but it has been very slowly accepted into the clinical practice. Coming to the appropriateness criteria of various investigation, what is an appropriate imaging study where the expected incremental information exceeds the expected negative consequences of that particular imaging modality? So score 7 to 9 is appropriate for a specific indication, scores 4 to 6 are uncertain, and 1 to 3 are inappropriate. Here, CT angiography, being the first imaging modality, is used for moderate pretest likelihood of CAD less than 50%, with and for stress echo is appropriate for the initial diagnosis when there is change in the clinical status, but is not appropriate for routine testing. So basically, when you do one test and it's equivocal, you switch to the other test. So when the myocardial perfusion imaging is equivocal, you do a CT angiography. When the CT angiography is equivocal, you go to the sister imaging modality. So here we are in summary: chest pain syndrome, CT angiography. When it is low to intermediate, do it. When it is intermediate to high, you can do stress myocardial perfusion imaging, stress echo, or dobutamine MR. For the assessment of cardiac function, echocardiography. For the assessment of myocardial viability, you can do cardiac MRI when and where it is available. So my concluding message is, there is no simple recipe. You should appropriately use all of the available technologies if they are available to you according to the clinical need and keeping in mind the appropriateness criteria. Thank you very much.
Thank you very much, Dr. Siraj. We'll take only one question because we are running short of time. And
well, I try to speed up.
It was very nicely and self-explaining presentation, sir. So I don't think there will be any more questions.
Okay, thank you very much.
Sir, my question is: is 16 slice CT enough for calcium scoring, or we need to go for dedicated cardiac?
You need to go for dedicated cardiac, but I really tell you from my experience, I look at every CT and look at the calcium first, and really I have not found it of much use. Although the literature says it's brilliant, I have seen no calcium positive MPIs, lots of calcium negative MPIs. So between you and me, I really don't trust. But it came as a part of CT, when people will go for a CT and do a whole CT just to see something and say see calcium, and then they get worried they have something. Yes, but now if you are going for a diagnostic study, it is an ancillary information that you may use and you may keep it in mind when you're actually reporting MPI, because it is there. So and then it increases your confidence when you see an abnormality that yes, the calcium is so high, there must be something. But when you actually see a myocardial perfusion defect in the absence of coronary calcium, you have to trust your own modality, at least at that particular stage of reporting.
So one more question, please. Should we report this CT, 16 slice CT scoring in our reports, or we should not?
If you do a diagnostic 16 slice through the software acquisition, not just by the visual assessment, you may do it, and we do it in the departments. We just put it as an additional score that the cardiologist may like to use.
Thank you, sir.
Thank you very much, sir.
Welcome.
Our next speaker is Dr. Humayun Bashir. He'll join us from UK. Dr. Bashir is a fellow in EBNM, CPSP and RCP UK. He's a consultant in nuclear medicine in NHS Trust Hospital, Canterbury, and honorary consultant at Shaukat Khanam Hospital, Lahore. He will deliver a talk on role of PET-CT in vasculitis.
Thank you very much, Jagam. I hope you can listen to me. You can hear me?
Sir.
Hello?
We can hear you, sir.
Thank you for the nice introduction. There's a slight glitch, as it always is in my online presentation, so there'll be some slow movement of slides. My friend there locally will be changing the slides for me. So today I'll be talking about PET-CT in vasculitis, and the talk will be mainly about FDG. Next slide, please. A little bit of background. Basically, there's an injury in the endothelium of the vessels, where the T cells and the monocytes, they actually infiltrate. There's a background of systemic inflammation which leads to endothelial damage and inflammation, and that's the process which is underlying the vasculitis and inflammation within the vessels. Next slide, please. Now, this is a long list of radiotracers which have been used for imaging of vascular inflammation, and you can see there's a whole lot of radiotracers. This is sort of tradition of nuclear medicine, that we can prove that anything can go anywhere and everywhere, everything can be seen with everything. In the end, it produces a lot of publications and research papers, and also generates a lot of confusion. Here we have FDG as the main tracer being used for inflammation. Next slide, please. Now, this is a nice publication which actually shows the pattern of involvement of the large vessels, which is indicative of what sort of diagnosis we are looking at. This red scale here actually shows that, if there's 100% involvement of these vessels or there's no involvement. So this first image is about the cranial giant cell arteritis. This is the large vessel involvement in the aorta and the subclavian axillary vessels, and in Takayasu's there's possible involvement of the renal vessels as well as the pulmonary vessels. So pattern recognition, as we know, everywhere from bone scan to all other nuclear medicine imaging, is helpful in actually directing our diagnosis towards a certain vasculitis. Next slide, please. This is a busy table. I put it here because it's a good table. It makes my task easy, difficult for, I guess, the audience to read, but it's a very good review article. Next slide, please. Okay, so here we have got these types of vasculitis in this column, but there are 4 different modalities: ultrasound, color Doppler, CT, MR, and FDG PET-CT. So there are peculiar patterns in each of these modalities by virtue of what this modality has to offer, which actually direct us towards the diagnosis and assessment of vasculitis. Next slide, please. I've added PET-MR at the bottom because of course, new data is coming up. So in this slide, you can see the examples on the top side. This is actually a halo that we see on the ultrasound for vasculitis. Here in the middle, we have got this thickening of the aortic abdominal aorta wall, representative vasculitis. This is actually a stenosis, and it can be seen nicely in the sagittal view. In this bottom, we have got 3 images from the PET-CT, nice donuts involving the ascending and the descending aorta. This MIP view shows the entire extent of the aortic involvement, carotids as well as the subclavians, cut through the base of the skull as well. In this image on the left side, there's involvement of, there's a secular aneurysm, and at the bottom we've got a few images of the MR as well. Again, we're looking at the thickening and the enhancement of the thickened wall. Next slide, please. This is a paper particularly about the imaging features of PET-CT and vasculitis, and you can see, as we saw in the previous image, there's a nice involvement of aorta all through the extent from the thoracic up to the upper half of the abdomen, almost up to the bifurcation. Patient presented with fever of unknown origin, and vasculitis turned out to be the cause. There's also involvement of the temporal arteries here. These are difficult to see because there's a lot of background activity in the brain, and there's also involvement of the vessels down in the pelvis. Next slide, please. Now, apart from these, the involvement of just the vessels, there's a lot more which can be seen as part of the FDG PET-CT. For vasculitis, of course, on the top again, we have got the aortic arch involvement, there's celiac trunk, and in the gut, there can be ileocecal involvement in this particular case. Lungs, they are affected by vasculitis. Kidneys, you know, a dodgy area because there's so much physiological excretion going on. But again, in the case of patient presenting with symptoms of renal function, you know, it can be part of the spectrum of vasculitis, sinuses, and the mastoids. So now on this image, I will just mention, I came across a very interesting paper recently looking for something else, and they used the word cartography, which is actually the science of making maps, and they say there are two cartographic imaging mapping tools to look at a certain thing, disease or abnormality, and they actually named PET-CT and bone scan for that matter, because that was a whole body scan. So this is like, you know, when we are imaging for one particular disease, since we are imaging the whole body, which essentially usually takes from vertex to the upper thighs, we are actually looking at mapping the whole disease, which no other modality can do it in that, you know, amount of time. Next slide, please. Now, all that glitter is not gold. We know that very well in nuclear medicine. There can be mimics of vasculitis, infectious disease, inflammatory disease of different syndromes and diseases, different organs, different spectrums of disease, connective tissue disease, congenital vascular disease, as well as neoplastic disease is always there to overlap anything in Pakistan, a background of subcontinent and the developing world. TB is always a factor. So basically, we have to know what we are looking for. So the background, the clinical history is most important, and that helps us decipher the patterns of uptake towards a particular diagnosis. Next slide, please. Now, as I mentioned about cartography, there's incidental findings which we are always able to see on an FDG PET-CT scan. Over here, we see a lot of second primaries while diagnosing for one malignancy we end up seeing in the gut and other places. This is a recently done study in which they actually showed that the incidental finding on FDG PET-CT for large vessel vasculitis, the incidence of incidental finding increases with age. Of course, there's a more chance of having secondary malignancies or other causes of ailment which are coming with age. So this is a good recently published paper. Next slide, please. Now, in this example, the red arrows actually show the involvement of the vessels for vasculitis, while there was an incidental pick of the left-sided pheochromocytoma. Next slide. Now, since we know that FDG is a tracer which is being used for vasculitis, it's useful, there's clinical data behind it. Now, the effort is to actually standardize how it is looked at and reported across the world. Lately, there's a nice trend that there are consensus between different organizations, as well as under the ambit of IAEA and in some cases WHO, to come up with a consensus, as much a consensus can be created, so that, you know, we are all listening to the same song and speaking the same language as much as possible. So based on this, there's been a consensus document 2018 regarding how to be evaluating FDG PET-CT for vasculitis. Next slide, please. Now, as far as the preparation for FDG PET-CT is concerned, is pretty standardized. It can be a fatty meal to reduce the myocardial uptake. Glucocorticoids are critical because, of course, once they are kicked in, and they have to be started because of clinical reasons, the ability of FDG PET-CT scan to see active disease can be, you know, sort of compromised. A study has been done which shows that there can be a 3-day window once the glucocorticoids have been started when FDG PET-CT can be done. So ideally, before the start of glucocorticoids, if not possible, within 3 days. If not possible, then do it and let the clinicians know that there's a probability of false negative results because the patient was already on steroids. Next slide, please. Now, this is the pattern, sort of key which has been provided. We are familiar with Doven criteria for lymphoma. It always helps. And in this, you can see that, of course, the reference uptake is in the liver. Low grade, which is graded as 0 is no uptake. Grade 1 is when it is higher than the mediastinum, but lower than the liver. Intermediate is equal to the liver, and high is significantly higher than the liver. And you can see in the top images that this is low grade, this is medium grade, and this high grade uptake is, quite avid. Nice visualization of the large vessels. From this, they have come up with a total vascular scoring system as well. There are seven different sets of vessels which are allocated a number, which can be from 0 to 21 for grading this. But this is clinically, basically, we're reporting grades, not the scores at the moment. Next slide, please. Polymyalgia rheumatica is closely associated with giant cell arteritis. So this guideline about standardizing reporting of FDG PET also included this criteria, which again is graded as mild, moderate, and severe. And we are focusing on the joints, the synovium, and the soft tissue around these joints for PMR. Next slide, please. PET-CT angiography, as Dr. Kessler also mentioned, with PET-CT, if they add angiography, fully enhanced, contrast enhanced angiography, we can provide more information, putting together the enhancing features of CT angiogram with PET-CT FDG uptake. At the moment, it's recommended for research, but it is there. Next slide, please. Now, this is a schema to look to work up a patient for large vessel vasculitis. At the top, you can see a patient over the age of 50 years with cranial symptoms. The first thing is to have a temporal artery and extremity ultrasound. If that's positive, giving you the halo sign and peculiar features of vasculitis to go towards the diagnosis. If it's negative, the next step would be a PET-CT, an MRA, or a CT angiogram, which would lead toward the differentiation between a large vessel or a giant cell arteritis. Between these two, above 50 years and less than 50 years, in the less than 50 years, because of Takayasu's, the head and neck and extremity ultrasound is done, and of course, the pathway otherwise is directly towards diagnosis or going via MRA, PET-CT, or CT angiogram. Next slide, please. A few clinical scenarios. On this one, like case 1, a patient presenting with the cranial presentation, 73-year-old male. He's got symptoms of lethargy, myalgia, weight loss. It has to be fast-tracked towards a review, specialist review. In case 2, there's a mention of right eye reduced visual acuity. This is much more critical than the other one. On this left side, we've got 2 cases of primary systemic large vessel presentation. Again, weight loss, fatigue, myalgia. The concern is for large vessel. And in this one, in the case number 4, we have got uneven upper limb, blood pressure, absent right arm, radial pulse. So there are different clinical scenarios. The thing in blue here is fast-track specialist review, urgent specialist review. I put the slide here with one other reason that, this actually shows how we need to coordinate. The request has to come from specialists dealing with the vasculitis, and then of course it has to go back. So, it's good to interact with the referring specialists in particular disciplines to make best use of the modality which we have at our hand for diagnosis of vasculitis. Next slide, please. Now here, I put the slide with the emphasis on the treatment options at the bottom. In the last row, you can see these pink boxes, treatment with glucocorticoid and glucocorticoid sparing agents, immunotherapy, methotrexate. FDG was always there, been there for quite some time. What has made it useful for vasculitis? Treatments. Once we have treatments for certain things, treatments with good outcomes, imaging and diagnostic modalities become very crucial. Next slide. Now, treatment monitoring. Now, for diagnosis, FDG PET-CT has a sensitivity of around 75% and specificity around 93%. For treatment response, the initial thought was we'll be able to see that heart thing, the whole theranostics phenomena, and when it will not be heart, we'll be saying it's settled. It's not that simple. The next slide. There are many factors in play, and the sensitivity stays around 77%, but the specificity drops to almost 71%. Reason, like we see in bone scans, treatment patient responds to treatment, but the uptake might just still be there. Similarly, in vasculitis, there are factors which have caused the radio tracer to get there. All those factors do not get sorted with treatment. So the uptake might be still there when we are looking at scans. It would reduce. So essentially the idea is that FDG PET-CT has a moderate accuracy for distinguish active disease from remission in patients on treatment. FDG PET-CT scans have to be interpreted in the context of clinical and biochemical findings. If the patient is fine, biochemical markers are actually settling in towards normalization, the scan findings will be residual or reactive. If the patient is clinically unwell, markers are up, we have a scan which is still showing uptake, then of course that will be interpreted accordingly. That's very crucial. Again, collaboration with the clinicians. You want to have the history, why you are doing the scan, at what time you are doing scan, what is the timeline of the treatment. It's not always easy to stop all sorts of treatment 6 weeks before to do a PET-CT scan with FDG. So, it's a complex situation. It's not that simple. And basically what comes into play here is experience. Next slide, please. Now this is a case of, a longitudinal follow-up imaging with FDG PET-CT. Initially, patient had extensive disease, entire aorta and the subclavians. With treatment, some response, some activity is still there, and towards the end, there's still some residual patchy uptake in this involved vessel. Crucial thing, what was the patient actually experiencing and what the markers were showing at that time when this last scan was done. Next slide. Now, just moving towards the conclusion, this is a review article from Dr. Alavi and team, and this nice schematic picture shows that in the FDG uptake, in this whole development from healthy to complicated lesion in the vessel, initially when it is developing, there's increasing uptake of FDG, but then when calcification starts settling in, we have another PET tracer, sodium fluoride, which can actually be taken up avidly by the calcium, and that can be of help in looking up for coronary atherosclerosis. Next slide. Now, finally, this is another editorial from Dr. Alavi and team from 2018. I think it was started emphasizing about the role of FDG in infectious and inflammatory disorders without getting into the whole data that they discussed. One of the main points that Dr. Alavi and team asserted that it may be appropriate to portray the introduction of FDG PET to medicine as compared to what X-ray did to it, because now we have tracers which can actually look into anything and everything with the right perspective and the right clinical scenario. Next slide. To this, I always like to add this comment from Thomas Baer, who is a physicist based in Austria, and he said that science and technology has delivered, and he was talking in terms of hybrid scanners and the radiopharmaceuticals which are coming up since then, and up to the physicians to make use of it. So the importance of this point is that nuclear medicine requires more physicians, more technical staff, more scientists to deliver what we have actually in our hands for a vast spectrum of diseases and illnesses, oncology, cardiology, and beyond. Thank you very much. This is a picture from Petra, which me and Dr. Shadi attended recently. Thank you very much. It has been an absolute privilege to be presenting to this PSNM 8th Congress. I'll be happy to take questions. Thank you.
Thank you very much, Dr. Humayun. Now I request Dr. Ahmed Qureshi to please give concluding remarks.
It was a very enlightening session, starting from the first. It was informative for me, and I believe that people have enjoyed DPD imaging. I've got certain ideas how to compare it with MDP, which is available freely in our country, and but the thing is that amyloidosis, how much what's its incidence in Pakistan. This is one thing. And then, of course, Dr. Kaisar Siraj is a modality of his own, and he elaborated the things very nicely, very concisely, and I believe that our PGRs here must have learnt a lot from that. And of course, Dr. Humayun, you are in UK and you have worked a lot here. You were one of the earlier FCPS fellows who passed out, and now you are in a position to transmit the knowledge to the next generation. I wish that you could have stayed in Pakistan. Anyway, again, these are things which we usually see in FDG in oncological settings, and we are not very clear that the vascular structures having this much uptake, that is how much important it is. But definitely FDG is going to play a role in the initial diagnosis, the management, and then of course the outcome of the disease. So I believe that all these lectures have very nicely narrated the whole story of the imaging, and let's go on with the next session.
Now I request Dr. Azra Ahmed, Vice President PSNM, please come to the stage and present the souvenirs. Dr. Ahmed Qureshi, Chairperson, and Dr. Shahzad Afzal, Co-Chair, please join Dr. Azra for presentation of souvenirs. Dr. Hajra Ilyas. Dr. Azra to present souvenir to Dr. Ahmed Qureshi.
I must announce that this is not the second one, the first one being presented again.
Thank you so much for the transparency.
Dr. Hajra Ilyas. Dr. Kaisar Hussain Siraj. Dr. Shahzad Afzal.
The last one for the moderator, Dr. Zaid. Okay, so before we jump on to our next session, a couple of announcements for all the presenters who are presenting for the free papers and the posters. They should ensure that the posters are with the reception area, they are uploaded, and they should check that. For the free paper session tomorrow, ensure that your talks have been passed on to the technical preview desk. Another thing, during the break sessions that we have, we encourage you to visit the exhibition area. We have quite a few companies there, and you should go interact with them over there, especially for there's a special presentation for the women in nuclear field. So I think women should also especially go and visit that stall. And with this, we'll come on to our scientific session 3. And I'd like to invite Dr. Saima Haider as the moderator of this session. Dr. Saima is the Deputy Chief Medical Officer at the Center of Nuclear Medicine in Sinam, Lahore. So Dr. Saima, please.
Thank you, Dr. Zahir, for inviting me as a moderator of this session. I would like to invite Brigadier Mehdi Raza on stage for chairing this session. He's consultant and head nuclear medicine cardiology at AFIP Rawalpindi. He's fellow of College of Physician and Surgeon and Asian Society of Nuclear Medicine. He's awarded Tamgai Basalat in 1993. And he's ex-vice president of PSNM in 2015 to 17 and has multiple research papers on his credit. Please, Dr. Mehdi, be on the stage. Thank you. I would like to invite Dr. Rifat. She is, as a consultant, PET CT Center at JPMC, from 2018. She has a vast experience of 15 years and working as assistant professor in Aga Khan University, Karachi. Please, Dr. Rifat, on the stage. I would like to call our first speaker, Dr. Catherine. She will be joining us from online from Canada. She is a professor in Department of Radiology and Nuclear Medicine at McMaster University. She is a board-certified radiology, nuclear medicine, and nuclear cardiology in US, and a fellow of Royal College of Physicians and Surgeons of Canada with subspecialty training in radiology and nuclear medicine. She is a fellow of American College of Nuclear Medicine and a fellow of Society of Nuclear Medicine and Molecular Imaging. She's also a professor in Geneva, and she has been awarded as an ACNM Best Mentor Award in 2022. She has written multiple chapters on hybrid imaging, theranostics, and cardiac imaging. She has, to her credit, multiple publications on hybrid imaging, with latest article under the process of publication on artificial intelligence in theranostics. I may hand over the time to Dr. Catherine, please.
Thank you so much for that very kind introduction and for the invitation. I'm only sorry that I could not be there in person. I'm hoping that everyone can see the screen. It looks like they can. So without further ado, my talk is a bit of a fun talk, I hope, and it's really about where we've come and where we may be headed in terms of nuclear medicine and PET. So I think one of the wonderful things about nuclear medicine and PET is that we have a very long history, and that the amount of diseases that we can image is truly remarkable. We can image using different radiopharmaceuticals. We can image processes, whether they be oncology related, whether they be infection or inflammatory related, whether they be related to cardiac imaging. And in particular, with the advances in technology, we can not only see the sites of disease in terms of targeted imaging tools, such as nuclear medicine, radiopharmaceuticals, but we can also see exactly where they are anatomically. So I've shown you a little bit of a panoply in general nuclear medicine and PET. I think that things are just truly taking off right now. So certainly the workhorse was always FDG. And we started out by looking at how to characterize solitary pulmonary nodules. I would say that the real strength is our ability for staging distant disease. And the fact that if you look at a MIP image, you can often, using PET, see the images from across, you can see the disease from across the room. So it is truly striking. It also tells us a little bit about how the disease is changing with time. And I like this image because it really underlines for me the strength of hybrid imaging and how important the PET component is to add on to the anatomic imaging, as it were. So what you see in the first column here is images of the pelvis in a patient who had cancer that had spread to the right iliac bone. And on the PET, you can see it from across the room, that there's something going on. On the CT, I would argue it's very hard to see this lytic disease. Can you see it? The answer is yes. Would you see it if you were going through your imaging fairly quickly? You had a lot of images on your pile? Maybe not. And then at the time of follow-up, after the therapy has been given, that's when we really pick it up on the anatomic imaging. But if you actually look at your imaging that was imaging the tumor cells themselves, they've pretty much disappeared. It has resolved. So in fact, the anatomic imaging would call the disease after the disease has been treated. However, it really is a wonderful match because, for example, certain things are seen better on PET imaging, certain things are seen better on diagnostic imaging, and the two are very complementary. So this was a patient who had distal esophageal cancer. You can see it on FDG PET. You really don't see the abnormality on the CT. However, if you look a little further below, you have a renal cell carcinoma, which is picked up very nicely on the CT, and which you really don't see very well on the PET alone. It turns out that about 70% of renal cell carcinomas have uptake comparable to normal renal parenchyma, and they can be quite difficult to see on PET alone. In terms of applications, I would say the sky is the limit. Almost every cancer has an application in PET. In some cases, it might not be quite as good, but I would argue that's simply because we haven't found the perfect radiopharmaceutical yet. And the beauty of it is that you can see the disease, it really jumps out, and the changes with therapy, again, you can see them. So for example, this lesion in the leg in a patient with Ewing sarcoma that was quite widespread, you can see that there still is residual metabolically active disease, but you can also see that it is far, far better than it was at baseline. And what has really shown up the power of where we're headed, I think, is a proliferation of radiopharmaceuticals, many of which are becoming more rapidly available in clinical practice today. So for a long time, we were really using FDG. FDG today is still by far the workhorse, I would say, in PET. However, there were several other radiopharmaceuticals that had more niche applications, I would say. And what this highlights for me is that it's very important to ascertain what is the question you really need to answer clinically. So this is a patient who had both an FDG and FLT PET studies at baseline and following therapy for treatment of mantle cell lymphoma. If you look at the baseline images, you can see that the FDG avidity is actually much higher than the FLT avidity, and probably the FDG would show up more sites of disease. So the sensitivity might well be higher. However, if what you're looking for is really the response to therapy, I would argue that the change on FLT is much more apparent. So if you're actually looking for total number of cases at baseline, maybe you want to choose FDG. If you want to look at response to therapy in this case, you might prefer to go with FLT. Enter on the scene one of the radiopharmaceuticals that has really made a big splash, I would say, in the last 5 years. And these are the PSMA family of radiopharmaceuticals in therapy for prostate cancer. So these images are one of the first taken in PSMA PET in Canada. And the bottom line was that all of a sudden you could see sites of disease you never anticipated were there. Basically, in this patient, there's disease going all the way up from the prostate bed, up through the pelvis, abdomen, through the thorax, all the way to the Virchow node. And in fact, based on imaging that was done prior to this PSMA study, no one knew there was any disease above the diaphragm. So it completely changes our understanding of how this disease spreads and where it can go. And it really highlights how useful certain radiopharmaceuticals can be. It also underlines the importance of where I think we're headed, which is more and more using radiopharmaceuticals to not only detect, but then also to treat disease. Now, theranostics has been around, or theragnostics has been around since the Second World War. So for a very long time, we've been using radioactive iodine, both for imaging and for therapy. It's just that in recent times, we've seen a real proliferation of therapies that are making their way into clinical practice. From radium, so this was one of the first images that we took in a patient who was treated pre and post radium therapy, through neuroendocrine type therapy. And one of the things that also comes to the forefront then is how should you do your therapy and how should you do your imaging post-therapy. So I show these images because these were actually taken at the time following therapy for neuroendocrine tumors. And what you can see is beautifully how extensive the disease is at baseline, and you can see how it's improving. And this was simply imaging the lutetium-177 after the therapy had been given. One of the other things that it raises the whole idea of is should we or should we not tailor our dose that we give for therapy in order to achieve the maximal improvement with the least toxicity. And in order to do that, should we be using dosimetry on a little bit more of a regular basis? And technically we can do it quite well using planar imaging, probably with SPECT. But you could do it post-therapy if you wanted to give everybody a standard baseline dose, but then image them directly afterwards and change your follow-up dosing depending on what you saw. Some people would argue you can do your dosimetry prior to even the first therapy. I would say this is a bit of a debate that continues to be ongoing, but I would not be surprised if going forward we do use dosimetry a little bit more than we have. Now, as with everything, as you've heard speakers before say, there is no silver bullet. There is no absolute in medicine. It's one of the things I find the most challenging about medicine, in fact. But it is something that you must always remember is the limitations. So, one of the nicest cases I saw when I looked at FDG PET in terms of limitations would be this case. The idea being that when you give a patient marrow-stimulating medications, such as GCSF medications, either Neupogen or Neulasta, they're probably the most common, you tend to cause the bone marrow to take up FDG, and you cause normal bone marrow to take up FDG. Now, the middle case is a case of a patient who had lymphoma involving the bone marrow, who had been treated with radiation, among other things. And the question that was raised was, is this widespread disease in the bone marrow? The person I was reading with at the time took a look at this and said, you know, we really don't know unless we know if this patient has been treated with Neupogen or Neulasta or some other medication. And when we spoke with the treating physician, they were unable to tell us that history. So we said, then we don't know. And we brought the patient back, and what you can see is that if you had called everything that was avid on that earlier scan, you would actually have been calling a mix of both marrow stimulation and disease involving the bone marrow. So there were sites of disease that involved the bone marrow. They were just far fewer than what you might have thought had you not realized that the patient was treated with a marrow stimulating agent. So my bottom take-home message is that whatever you do in imaging, you typically must take into account the clinical context. And you can't forget that imaging does not stand alone. Similarly, at the end of the day, you always need to do a reality check and say, does what you're saying really make sense or does it not? So this is a case of a patient with breast cancer who had spread to lymph nodes as well as distant metastatic disease. They were treated, and on follow-up, all they have is one site of disease in the contralateral lung. There was no disease there on the baseline. In fact, all of the baseline disease has almost resolved. So now the question is, do I have a new site of disease that is malignant, or could it be something else? It would make sense to consider that perhaps it's something else. Not that the disease has spread and there's just one site that's abnormal compared with everything else that's resolved, but maybe this was a cancer patient who was treated, who is at risk for something else, such as, say in this case, a pneumonia, and that's what this turned out to be. So at the end of the day, always put the clinical context and the story together to think about whether what you're saying makes logical sense. And then think about the underlying disease itself and the mechanism of how it works. So we know that for bone scans, the radiopharmaceutical is TEC-MDP. It's taken up by osteoblasts and incorporated into the bone. However, that requires that you have osteoblastic turnover. So if you have sclerotic disease where you have brisk osteoblastic turnover, you'll probably have sclerosis that's fairly diffuse on the CT, and you'll have widespread increased uptake of TEC-MDP on a bone scan. However, if you have widespread marrow infiltration without significant osteoblastic turnover, you may see virtually no disease in the bone on the bone scan. Whereas if you do an FDG PET where you're actually imaging the tumor cells themselves, you may see very widespread disease. In this case, it was every bone in this child's body. And on MRI, if you look at a T1 weighted image, you know that because the CSF is dark, all the bone marrow was replaced. So again, you have to think a little bit about what is actually the mechanism, what am I trying to image? And why is this so important? Because for standard of care for prostate cancer, until very recently, most places were doing bone scans and CTs. However, if you take a therapy that treats the bone scan itself by treating the osteoblastic turnover, you could get a situation where you go from widespread disease to no disease within about 6 weeks, which was the case. But it was not so much that we had treated the prostate cancer, it was rather a combination that we had treated the prostate cancer, but also we had damped down the osteoblastic turnover. The medication in this case was cabozantinib, or XL184, which is known to damp down osteoblastic turnover. In which case, what else can you use? Well, I think we've talked a little bit about the combination of sodium fluoride and FDG, although we just talked about it in vasculitis. It can also be interesting to look at it in prostate cancer and to understand what actually is it imaging, what is it telling us. So if you have prostate cancer, say, that is involving the femur, what you would see on a sodium fluoride bone scan is you would see the osteoblastic turnover, or the reaction of the bone to the tumor. So if the tumor is sitting in the marrow, then what you get is the osteoblastic turnover around it. That shows your sodium fluoride uptake. If you take an agent that images not the reaction of the bone to the tumor, but rather the tumor itself, such as FDG, you might actually see some uptake. But if you look at that compared to the contralateral side, yes, it's taking up the radiopharmaceutical, but is it taking it up very avidly? Not so much. And it turns out that probably the majority of prostate cancers actually take up very mildly FDG unless they become very aggressive or dedifferentiated or neuroendocrine type features, in which case they tend to become more FDG avid. So FDG avidity tends to be associated with overall prognosis, overall survival. However, it may not be quite as sensitive for picking up all sites of disease as something that, say, is overexpressed on the majority of prostate cancers, such as PSMA. So in this case, your PSMA is showing widespread avidity. Again, very hard to see on the anatomic imaging because you haven't actually gotten much more trabeculi that has developed yet. And in fact, the only site on the anatomic imaging which showed some sclerosis turned out to be a bone island, and it wasn't PSMA avid. How low can you go? With PSMA, very low. So again, in the old days when we were looking at choline or we were looking at various other tracers, your PSA actually had to be relatively high comparatively to see disease. With PSMA agents, you can see disease in up to 1/3 of cases with very low PSAs, so less than 0.2. Does this change management? Unequivocally, the early and current results in the literature suggest that it does change management. Of course, the question is that changing management isn't always good. So most things that we do in medicine have consequences. Yes, you can help people, but you can also harm them. And the question is, where do you sit on the benefit to the toxicity? And you really want to be more beneficial than toxic. But the question is raised, just how much intervention should you do? What exactly are the false positives versus the false negatives? And I would say the jury is still out, although it's highly, highly likely that if you do PSMA targeted therapy, you will have an overall benefit. But there is an ongoing study that should be closing to accrual probably by the end of this year that aims to prove that, which is that if you actually base your management on the PSMA results, does it actually result in overall improvements in terms of disease response and survival? And as I said, the results are still out, but hopefully coming shortly to a room near you. With therapy and PSMA and, of course, nuclear medicine becoming ever more prominent and ever more important in medical management, I would say across the board, the question is, where is the optimal timing of things? And I would say that is also a work in progress. We've currently had the results of the VISION trial, and that has shown us one aspect of where PSMA therapy can be very helpful. The sequence of where it can be helpful is moving ever earlier in therapy, and we expect to have results probably at ESMO at the end of this month as to whether moving it prior to the metastatic castrate resistance stage might actually be useful. So there are more results coming, and they will be coming in quick succession. I think one of the other big questions out there is exactly what imaging do you need? When you're ascertaining which patients will respond to which therapy, it's fairly clear that if you have a PSMA targeted therapy, doing PSMA type imaging can be helpful because it suggests that you know what you have and then you treat what you see. However, the question is that not everything that, say, is PSMA avid is prostate cancer. So how do you deal with this? So this is showing you a case of a gentleman who had a PSMA PET study. You can see there is disease in the pelvis, which included both bone disease as well as lymph node disease. And you can see there's this pulmonary nodule. Now, I have seen pulmonary nodules that are path proven that look just like this that are prostate cancer. I have also seen nodules that look just like this that are not prostate cancer. And is there anything we can do short of biopsy to know? Some people would argue an FDG PET is very useful. And in this case, when we did the FDG PET, the disease that showed the PSMA uptake in the pelvis and the bone and the lymph nodes was in fact less FDG avid versus this nodule in the lung, which actually turned out to be more FDG avid than PSMA avid. And all of a sudden you see a new mediastinal node, which could suggest to you that this is something different. And in fact, this patient had both prostate cancer and lung cancer. Ultimately, it becomes very tricky. What do you do? How do you know what you're dealing with? I would say the thing to keep in the back of your mind is that just because something shows uptake on a scan, such as a PSMA scan or an FDG scan, doesn't necessarily mean that it's cancer you're looking at or that it's prostate cancer in particular. So you always have to think, does it make logical sense? If there is a question, I strongly recommend getting tissue sampling if you can, or additional imaging, such as an FDG PET. It can be quite complementary. And because I always like to talk a little bit about recognizing the potential, one of my favorite ways to do this is to talk about metabolically active brown adipose tissue. We see it all the time, and particularly in climates where you get transitions from the warm to the cold, such as Canada. And if it localizes to fat, it is highly likely to be metabolically active brown adipose tissue or fat. But the issue is then that you have to be very careful at looking at all the images, because in this case, there was a solitary pulmonary nodule in the right upper lobe. That was the only site of metastatic squamous cell carcinoma versus a sea of metabolically active brown adipose tissue, where the metabolically active brown adipose tissue is actually more avid than the pulmonary nodule, which was path-proven malignancy. So just because something is avid does not make it cancer. And similarly, you always have to think, what type of cancer could you be looking at? The reason that I call it a future prospect and a wonderful chance at where we can go is because it turns out that if you turn up the thermostat before and during the 1 hour uptake of FDG, you can actually decrease the incidence of metabolically active brown adipose tissue very considerably. And for me, this is why I think there should be SPAs in nuclear medicine departments. It could be a benefit not only to the patients, but also for the staff. And I just show my picture of the marmot, which was where brown fat was first described in 1551. And this made, in fact, one of the stamps in Canada for 2023 was the marmot.
Okay, Catherine.
All right, so to
please,
summarize the benefits
5
of...
minutes more. 5 minutes remaining because we have time running short. Sorry, apologies for the interruption.
It's no problem. I'll be very quick then. There are really only two last points I wanted to make. One, FDG PET as a predictor of survival, that has long been known and shown. The big thing is that often if we work together as multi-institutional cooperatives, we can really make a difference in how we run our trials and how we get lots of patients in order to prove what we want to show. And this is just showing that the more uptake you have across a brainstem glioma, the worse the prognosis compared to little amounts of uptake in the tumor. And then lastly, where are we headed? I think we're headed more and more towards therapy. As I mentioned, this is the one area where therapy has been shown. And in addition to thyroid therapy and dotatate therapy, it's probably the newest kid on the block. And the extent of improvement is quite large. And in fact, it won the Image of the Year at the SNMMI annual meeting in 2018 because you could see patients who came in virtually with diffuse disease that were palliative almost, walking out with no disease. Now, how durable is this response? How will it evolve over time? Will we move on to more alpha-related therapies as compared to beta-related therapies? I would say we don't know yet, but this portends a wonderful future. So, where are we going? I would say the sky is the limit. And that is it.
Thank you so much, Dr. Catherine. I would like to encourage only one question because we are very short of time. Please, anyone want to have a question? There can be only one question. Sorry? Dr. Asghar will...
Thank you. I'm Dr. Asghar, working as an oncologist in Karachi. My first one question in this case, she has shown a picture where she showed that there was uptake of this FDG in the bone marrow with the GCSF stimulation. If there is already involvement of the bone marrow before starting the treatment, and now there is again with the PET scan, with the entire PET scan, it's being shown up again, there is this bone marrow infiltration. How can we differentiate that this is a GCSF response or there is some residual disease in the bone marrow after this PET scan? Thank you.
So the effects of GCSF marrow stimulation can be seen within hours of giving the medication, and then it depends on the medication how long it will last. So typically, if you use Neulasta, it lasts a long time. You want to wait about a month. If you use Neupogen, it tends to be shorter. It's about a week. If you don't know the medication, you have to err to the side of a longer duration. Alternatively, you could do a biopsy, but that's very difficult. So I would recommend waiting. And if you're dictating the case, you really should not hold judgment. You should wait. And you can just say that bone marrow is indeterminate for whether it is disease versus stimulation, and we just don't know.
Thank you so much, Dr. Catherine, waking up so late in the night for the presentation. It's a very nice and enlightening presentation. Thank you once again.
Thank you. And you look wonderful, and the room looks spectacular. So I'm very sorry not to be there in person.
Inshallah, you will be sometimes here in next conferences. Inshallah. Okay. Thank you.
Thank you.
There will be a short announcement for the next speakers. We are really short of time. I would request them to cut down their presentations 5 minutes less than the allotted time. I shall be very grateful. So our next speaker will be Dr. Sharjeel Usmani. He is a consultant nuclear physician at Sultan Qaboos Comprehensive Care and Research Center, Muscat, Oman. He is a fellow of European Board in Nuclear Medicine, Asian Board in Nuclear Medicine, and he is also a fellow of Royal College of Physicians, Edinburgh, former teaching staff at Kuwait Institute of Medical Specialization. He's the author of 4 books and over 100 peer-reviewed papers. His main research interest is in bone imaging with sodium fluoride PET-CT in non-oncological indications and gallium-68 PSMA imaging in prostate cancer. His talk of today is about the expanding horizon, the role of gallium-68 PSMA in non-prostate cancer. Over to you, please.
Thank you very much for a nice introduction. I will not take much time. This is my topic. There will be a little bit more explanation of the PSMA PET-CT. Thank you, Catherine, for introducing that, and PSMA can be used in other cancer than the prostate cancer. I have no conflict of interest to disclose. There are some affiliations, and my former affiliations with Koit Cancer Control Center and Jawar Molecular Imaging Center. So this is an outline of my presentation. So prostate-specific membrane antigen is a glycoprotein. As you know that one, it is a glucosamidase carboxypeptidase, and it is usually expressed by the name. It is expressed in the prostate, but it can be expressed into benign conditions and a non-prostate other malignancies as well. It was discovered in 1987 by a prostate cancer line. It is a 750 amino acid transmembrane protein and is expressed in the short arm of chromosome 11. And I will not go into detail how it looked like. Here are two components, extracellular and intracellular, that use in the imaging and the theranostic purposes as well. So the history of PSMA is not, it is go back in 90s. We have a tracer Prostascent, which having a lot of background activity. It was at that time it was in great interest, but because of the limitations of indium labeled, the pharmaceutical availability and lot of background activity is not popular as much. Then in 2000, breakthrough happened in 2011 by a German group. They make a gallium-68 PSMA molecule. This is a peptide, and by using a gallium generator. And since its introduction, it was used in the prostate cancer for staging, restaging, and monitoring the therapy. Very good result of PSMA in prostate cancer, as every speaker mentioned that one. So what is the mechanism of, you should know that one, what is the mechanism of localization of PSMA in prostate cancer is a transmembrane protein. Is overexpressed in around 95% of the prostate cancer. Its density increases with the Gleason score and castration strata, and expression in case of dedifferentiation, metastatic or hormonal refractory disease, the expression is also increased. In non-prostate cancer, it is the PSMA expression is also seen in variety of malignancies. The PSMA expressed in the endotheliums of the tumor-associated vasculatures of solid malignancy due to the tumor associated angiogenic factor and the endothelial cell sprouting. So that is the mechanism that the tumor has some new vascularization, and you can see the other tumor that are very highly vascular. You can PSMA can localize those tumors. The highly vascular tumors are, like for example, hepatocellular carcinoma, renal cell carcinomas, gliomas, especially high grade. They have high vascularity. So you by this mechanism you can localize these non-prostate cancers. So it also expresses in the inflammatory expressions like increase in PSMA legend, especially because of the blood flow, vascular permeability, and especially the macrophages binding that cause the uptake of the PSMA in the inflammatory. You can see a lot of esophagitis, lung infection can localize the PSMA. So this is a very non-specific imaging. So the application will be the new vascularizations of other solid tumors. It can be used at initial staging, restaging, and it can give you an idea about the prognostic significance of PSMA imaging by telling you the aggressiveness of the disease. So these are the different examples. So we are looking for the 50 or many grades of PSMA, not message 50 grade, but I will show you the half of it, of the different shades of PSMA imaging in other tumor other than the prostate cancer. So number one is the gliomas, is the most common CNS tumors. The treatment is, as you know, that one will be a safe resection, and then you have adjuvant therapies like chemoradiation. the tumor specimens show that there is a high PSMA expressions in gliomas. And as you know that the FDG is not good as in gliomas because of the normal tracer distribution of FDG in the brain parenchyma. And you will able to see a high grade tumor of glaucomas, but low grade cannot be visualized on FDG. The PSMA is very good in it because they don't have a normal uptake in the brain. So this is a case of a 42-year-old female with a GBM grade 4, treated with surgery, now presented with a headache. You can see hardly somebody can look at it, might find some equivocal findings, but obviously because of the high activity in the normal parenchyma, you are able to miss the gliomas. And this is the PET-CT images and the fused PET-MR. You can easily visualize the tumor here, and then you can look it back in the slices. Then you can. It's not working. Anyways, you can see that there might have some equivocal uptake of FDG, but there's better localization of PSMA in gliomas. Another case, a patient with GBM have a multiple resections. This is a multiple sites of GBM is there, and after resection you can see there is not only a single tumor, there are multiple tumors, and you can see it is not in the frontal lobe, it is in the posterior parietal region as well. So not only it can show you the localization, the multifocality, and initially now just we started by the radiotherapy planning and targeted therapy by using PSMA in gliomas. This is another case for target delineation, and you can see that one how good the PSMA localize the tumor, and it can help regarding the targeting the target delineation and using for the radiotherapy planning. And especially after the radiotherapy you see a lot of edema, and that limit the utility of MRI. So this is a functional imaging, tell you the residual tumor or the active tumor site showing the vasculature, and you can easily plan your therapy according to based on the treatment planning with PSMA. The studies have showed that they are correlated with the KI index, the proliferation index. There are some certain studies they can show that they have potential between the differentiating with the radiation post radiation necrosis versus the residual tumor. So it is very helpful, and it is a diagnostic challenge, especially to differentiate between the radiation necrosis and active tumor in any modality, especially the standard is MRI or FDG. So this is a better test to differentiate between the radiation necrosis and the recurrence. And there are the few proof of concept regarding the role of lutetium PSMA therapy in the cases of complicated gliomas. This is the case reported in 2020, and this patient underwent 3 cycles of lutetium therapy, and you can see that there has a very good objective and radiological response in this patient, and you can easily see that there is a reduce in uptake of this glioma tumor. The other main indication for non-prostate utilization of PSMA is a hepatocellular carcinoma. Why it is? Because FDG is little bit less useful in very well differentiated hepatocellular carcinoma. And still the contrast enhanced CT is a gold standard for the diagnostic and management of CA. Around 50% of the cases of FDGs are negative on hepatocellular carcinoma, so you need to look at it, how it is behave, and especially for the monitoring of the therapy. As you know that in hepatocellular carcinoma, targeted therapy uses the TKI plus immune checkpoint inhibitors. You need something to test functional imaging to see the response of the case. This is a very interesting case. Patient with a colorectal cancer now presented with a huge liver mass that might be a second primary, and you can easily see that there will be a very avid tumor in the liver, and it can show you the pattern of enhancement of that tumor, the highly vascular tumor. So PSMA expression in hepatocellular carcinoma is attributed to the new angiogenesis of the tumor. The PSMA uptake is correlated with the tumor aggressiveness, and their studies have showed that one of the study published in JNM 2021, they show that it will change the management of the hepatocellular carcinoma around 50% of the cases, and more than 50% of cases you can change the management. Either you can able to see an unexpected metastasis side, and in those cases. So especially now there will be a lot of talk about the targeted therapy or some assessment with the mepsagrein and angiogenetic inhibitor, that is the bevacizumab, and they are related to the angiogenetic activity. So you are a tracer, now you have a tracer that give you an idea about the tumor angiogenesis. So it will be very good regarding the evaluation of response to that therapy.
Dr. Shajil, 5 minutes to go.
Yeah, this is the one case. Another very good indication in renal cell carcinomas. Renal cell carcinoma, as you know, that there are very highly vascular tumor, and majority them of the renal cell carcinomas are the clear cell types. You see the more expression in the clear type rather than the other type of renal cell carcinoma. So in PSMA is much better than FDG. As you know that the FDG is not good in renal cell carcinoma. Around 70 to 80% tumor are not avid on FDG. So it not only localize the initial staging, and it can give you an idea of the metastatic involvement. This is the case. You can see the unexpected tumor metastasis in bone. Another case, unexpected metastasis seen in the brain metastasis with Gallium-68 PSMA. The stronger the expression of PSMA, it gives you an idea about the high grade and poor overall survival rate. And it will be very good. Now you can know that the important role of TKI and immune checkpoint inhibitors in the treatment of metastatic renal cell carcinoma. So you need some tests for the response evaluation, as the FDG is not good at it. So PSMA have a very good role in the response evaluation, especially with TKI and immune checkpoint inhibitors. Other tumors, CA lung can be positive. Lobular cancer, which is not much avid on FDG if you're talking about the breast cancers, and the studies show that the PSMA expression see more in the hormone negative as compared to hormone positive. Another more important, that will be the hormonal refractory metastatic cancers. This is an example of lung adenocarcinoma, and there will be, you can see the PSMA expression in iodine refractory thyroid cancer. Again, you need a certain tracer that can target the radionuclide therapy. You can visualize, you can see what, and you can treat the other cancer. That's it. Yes, I can skip those slides. I just want to show that one. Our case, the case of choriocarcinoma, the pre-therapy scan, the choriocarcinoma is a very, very aggressive tumor. You can't have much choices for the chemotherapy or other modality to treat those ones. If that tumor is positive on PSMA, if your therapies are exhausted, you can treat those patients. We treat with the 2 cycles of lutetium therapy, and you can see there is a significant reduction of PSMA expression, and the tumor drop from 50,000 the CA119 levels to 5,000 level, and patient survive for a quite bit longer time. So take home method, the PSMA can play a vital role in the other solid tumors other than the prostate cancer. The PSMA expression can influence the patient management, and it guides to the radionuclide therapy. PSMA, lutetium PSMA, it is here in the market for the prostate cancer. We should explore other horizon, other tumors. You can image those tumors, and if they are positive, you don't have any other choice, so you can treat those patients. Thank you very much.
Thank you so much for a very nice presentation. We'll take the question answer session at the end or in the lunch break. We are really short of time. So our next speaker is Dr. Arzu Fatma. She is a consultant nuclear physician currently working as head of Department of Nuclear Medicine and PET-CT in Mole Cancer Hospital. She has a vast experience on hybrid imaging, SPECT-CT, PET-CT and advanced theranostics. She is a chief and a co-investigator in many of her IAEA projects. So her topic of presentation will be gallium-68, DOTA-NOC, PET-CT in neuroendocrine tumors. Over to Dr. Arzu.
Thank you so much, Dr. Saima. I'd like to take just 15 minutes. Let me have that pound of flesh at least. Okay, so this is going to be the brief layout of my talk. Very brief introduction. Classifications, most probably I'll skip. Rationale as well. Interpretation is important. And clinical cases is something I'm passionate about because these are the ones that I brought from InMole archives. So I'll try to show you as many as I can. NETs, as we all know, are basically neuroendocrine tumors that arise from cells in the endocrine and the central nervous system. They're very rare tumors, accounting for 0.5% of all cancers. And gastrointestinal tract is the most common location, is responsible for 2/3 of NETs, followed by lung. So this site-specific classification is basically summing up the same histopathological classification proposed by WHO for GEP-NETs, has two major categories: well-differentiated neuroendocrine tumors, which were traditionally referred to as carcinoid tumors in the tubular gastrointestinal tract, and pancreatic NETs. Poorly differentiated neuroendocrine carcinomas is the second major category. These are high-grade, rapidly progressive. They can also be classified as functioning or non-functioning, dependent on the hormones they secrete, and carcinoid syndrome is something that you commonly come across. So approach for suspected NET, first step obviously would be the execution of biochemical tests, including tumor markers, followed by localization of primary tumor, evaluation of the extent of the disease with conventional or molecular imaging. Second step should be histopathological confirmation, conventional imaging modalities like CT, MR, and somatostatin receptor scintigraphy with indium-111 octreotide. PET-CT is of course better as compared to regional conventional imaging with CT and MR, as it is able to screen the whole body in a single study. As compared to SRS, it is of course less time consuming with better resolution, and it also provides the possibility of quantification of tracer and is of course helpful in peptide receptor radionuclide therapy, planning and response evaluation. So this is the rationale that I'm sure you all understand. I'm just going to go skip it. And there are 5 known subtypes of somatostatin receptors to which this complex binds. And the peptides that are used are TOC, NOC, and TATE. And DOTA, you need to understand, is the chelator. It's not the peptide. And the radionuclide is gallium-68. So these are the guidelines that were most recently published in 2017 in the European Journal of Nuclear Medicine and Molecular Imaging. Here is a long list of tumors with high expression of SST receptors, and these include the gastroenteropancreatic tumors, sympathoadrenal system tumors, medullary thyroid carcinoma, small cell lung cancer, and meningioma. So the indications, as we all know, are staging, restaging, determination of the SST receptor status to help select eligible patients for radionuclide therapy. This is what the normal biodistribution looks like on the image. Intense uptake in the spleen, kidneys, adrenals, and pituitary glands, moderate uptake in the liver. So what is pathological uptake then? Obviously, it's the focal tracer uptake that cannot be explained by physiological biodistribution or is higher than the background activity. Simple qualitative grading of uptake is as follows: mild is equal to blood pool, moderate is equal to the liver, and intense is clearly above liver. A semi-quantitative analysis includes parameters like SUV and the Krenning score. The commonest application for this score is to assess the eligibility for peptide receptor radionuclide therapy, usually with a score higher than 2, means greater uptake than the liver. So this is the table that summarizes the list of false negatives and false positives. False negatives include tumor dedifferentiation, tumor heterogeneity, and false positives include physiological causes like pancreatic islet cell uptake, uncinate process uptake, splenicules, osteoblastic activity in tumoral nodules and fractures, active inflammation in reactive nodes, and inflammatory diseases like sarcoidosis and TB. The common sites of METs are liver and peritoneum, and hepatic METs are the commonest in carcinoids and pancreatic NETs. So in liver METs of NET origin, the small intestine should be suspected as the primary site, whereas in brain METs of NET origin, the lung should be suspected as the primary site. The prognosis, of course, depends upon many factors, but most NETs are slow growing. Pancreatic NETs, however, tend to be quite aggressive, and the best survival rates are observed in patients with NETs arising in the rectum and appendix. So coming quickly to the clinical cases, long list. I will see if I'm able to show you all, otherwise I'll be skipping through a few. Metastatic NET liver for diagnosis and staging, status post-liver biopsy. Kindly look at the red arrows all the time and you'll be able to pick up the pathology sites. The images show a large, predominantly necrotic mass with peripheral tracer avidity in right lobe of liver, of course metastatic, multiple tracer avid hepatic METs. And there's a tracer avid lesion in a small bowel loop, which is likely to be terminal ileum, shown by the red arrow, and possible primary site, tracer avid mesenteric deposit, in close proximity to the gut lesion, shown by the white arrow. So the ileal net, particularly the terminal ileum, is the most common location for these neuroendocrine tumors, and the most frequent site is the small bowel, of course. And they typically present in advanced stages. They frequently metastasize early to the lymph nodes or to the distant organs. Case 2 of metastatic NET liver, again status post TrueCut biopsy of the liver, multiple tracer avid hepatic METs, tracer avid lesion in the jejunum, possible primary site. Look at the red arrows again. So there's another tracer avid subhepatic mesenteric deposit. I think this is a similar case, so I'll skip it. So I've shown you so far 2 cases of very typical presentation of neuroendocrine tumors. Patients come and they present with metastatic NET liver, and the possible primary site is usually the small intestine or the pancreas. So I'll now move on to the cases where your patient is presenting with pancreatic primary. So in this case, it was status post ultrasound guided biopsy, SOL liver, and there's a tracer avid mass in the pancreatic head and body, and this is of course consistent with the primary tumor, and you can see the black arrow. This is a solitary tracer avid hepatic MET. So second case of pancreatic primary. Now in this case, the patient presented after distal pancreatectomy and splenectomy. Again, you can see a large tracer avid mass in the right lobe of liver. This is likely metastatic. There are tracer avid findings in the region of spleen. This is likely to be a splenicule. Why? Of course, because the spleen is surgically absent, shown by the red arrow. Third case of pancreatic NET, so I'll just skip it. And the teaching point here is that primary hepatic neuroendocrine tumors are extremely rare. They comprise less than 0.3% of all NETs. Duodenal NET, status post endoscopic biopsy for duodenal polyp. And you can see a lesion, which is tracer avid, in the third part of duodenum. And this is consistent with the primary tumor. The tracer uptake that you can see now, the red arrow pointing, is the uncinate process, which is showing physiological tracer uptake due to the presence of SST type 2 receptors. So the teaching points in this case are that the duodenal NETs, or DNETs as they're called, are rare tumors, accounting for 11% of small intestinal NETs. They are located in the first or second part of the duodenum. Majority are limited to the mucosa or the submucosa, but METs to the lymph nodes and liver are known to occur. So stomach NET, status post endoscopic biopsy of the stomach, multiple tracer avid hepatic METs, tracer avid skeletal MET in sacrum and right iliac bone, and spine as well. So gastric nets or GNETs, previously known as gastric carcinoids, are rare aggressive neoplasms, and they account for 2% of all gastric tumors and up to 10% of all GI nets. They are often metastatic representation with a high rate of local recurrence and mortality. Okay, mesenteric net for restaging. Now, status post mesenteric mass biopsy. Mesenteric mass in right lower abdomen, and this is consistent with residual recurrent tumor. There are multiple tracer avid hepatic mets. Now, primary mesenteric neuroendocrine tumors are very unusual, although secondary mesenteric involvement is common and reported as 40 to 80% and is mostly nodal. So coming to, this is almost the end of my cases. So this is lung net, or as it is called, bronchial carcinoid. Status post endobronchial biopsy. You can see in these images, there's a tracer avid mass in the right hilar region, and the white arrow is showing the collapsed right middle lobe. So the teaching points: bronchial carcinoid tumors represent the most indolent form of a spectrum of bronchopulmonary neuroendocrine tumors that include small cell carcinoma of the lung as its most malignant member. They represent about 10% of all carcinoid tumors, and they account for 1 to 2% of all lung tumors. They are further divided into typical carcinoids, 90%, which are low grade, and atypical carcinoids, 10%, which are high grade, aggressive, and metastatic. Okay, so moving on to the tracer avidity of carcinoid tumors. Now, typical carcinoids show a higher uptake of gallium dotanoc, but atypical carcinoids have less dotanoc avidity but are FDG avid. Another case of probable bronchial carcinoid, status post biopsy of liver. You can see two red arrows on the MIP. One is pointing towards the foci in the liver, and there's another one in the left lung region. So let's see. Images show multiple tracer avid hepatic mets, and then there is a tracer avid mass in the upper lobe of left lung. This is the possible primary site. So this particular tumor does not appear to be a typical carcinoid, as only 5% metastasize, and that's usually to regional lymph nodes. This is most probably an atypical carcinoid, as distant mets are seen in 20% of the cases, usually to the liver, which we have seen in this particular case.
5 more minutes.
Okay, so medullary CA thyroid, status post total thyroidectomy. You see tracer avid mesenteric lymph nodes in the bilateral neck, in the left supraclav region, in the right prevascular region, and there are tracer non-avid nodules in bilateral lungs. So neuroendocrine tumor from the thyroid cancer or the medullary thyroid cancer arises from the C cells, which secrete calcitonin, account for 1 to 2% of the thyroid cancers, and are mostly sporadic. Up to 75% have nodal mets, 10% have distant mets, and the common sites include the liver, bone, and lung. Now, the typical CT findings are calcifications within the primary tumor and calcified lymph nodes. A meningioma, status post-excision biopsy. You can see extra-axial brain mass with marked tracer avidity. This is consistent with recurrent meningioma. Images of more caudal levels of the same tumor. Now, meningiomas are the most common primary brain tumors. They are extra-axial, and because they have high dotanoc avidity, therefore nearly all meningiomas will express somatostatin receptors. Indications for dotanoc PET-CT in meningiomas include diagnostic confirmation of equivocal lesions, surgical planning, delineation of radiotherapy target volumes, post-treatment surveillance to differentiate tumor progression from post-treatment effects. And this is, I think, my last case of a bilateral pheochromocytoma for diagnosis of malignant nature. It was a 10-year-old male with bilateral pheochromocytoma diagnosed on recent CT and clinical findings, that is hypertensive encephalopathy and elevated 24 hours urinary VMA. Now, the images show a tracer avid mass with marked tracer avidity involving the left adrenal gland. There's another tracer avid mass with marked tracer avidity in the right adrenal gland. So this is a case of tracer avid mass lesions in bilateral adrenals. Approximately 30% of pediatric pheochromocytomas are bilateral. These lesions are less likely to be malignant as they do not appear to fulfill the criteria for malignancy, including loco-regional invasion and distant mets. Now, this 10% rule you're all familiar with. This case I'm going to skip, and I'll just go simply to the teaching points in pheochromocytomas, which are very important, because approximately 10% of pheochromocytomas and 35% of the extra-adrenal pheochromocytomas are malignant. And mind you, only the presence of mets defines malignancy. And bones are the most frequent site of mets, followed by lungs, lymph nodes, and liver. So the take-home messages are neuroendocrine tumors are rare, but they are very heterogeneous and they can arise anywhere in the body. Gallium-68 PET-CT is an excellent imaging modality in the management of neuroendocrine tumor patients. Sensitivity and specificity for primary tumor localization, stage modification, therapy planning, and monitoring is more than 90%. Thank you.
Thank you so much for such a vast presentation into a very short time.
In 15 minutes.
Thank
Record
you
time.
Yes,
Thank
really
you.
on 15
I'll be
minutes.
taking the. I'm here during the lunch break, so I'll be more than willing to take any questions that you have during the lunch break. Thank you.
So our next speaker is Dr. Akhtar Ahmed, and he is a nuclear physician, over 38 years of experience in nuclear medicine. He has earned his master's degree from University of London. He is a fellow of College of Physicians and Surgeons, Pakistan, European Board of Nuclear Medicine, and Royal College of Physicians, Edinburgh. He is currently head of the nuclear medicine and PET-CT at Zauddin University Hospital, Karachi. He has served as Director NIMRA, Jamshoro, and Kiran, Karachi. He was Dean, Faculty of Nuclear Medicine, and currently member, Faculty of Nuclear Medicine, College of Physicians and Surgeons, Pakistan. He was ex-President, Osteoporosis Society of Pakistan. He has over 30 publications and 300 citations. His topic of presentation today is persist, I hope I am pronouncing right, is persist in breast cancer. Dr. Akhtar, please.
Thank you, Dr. Saima, and thank you, the organizers, for inviting me for this talk. I know because of the short of time, we have to be very quick. And I have no disclosures, and this is the outline of my talk. We know that breast cancer is the commonest cancer worldwide, and it is associated with high mortality, and it is more prevalent in transitioning countries like Pakistan as compared to transition countries. Now, the histologically and molecular subtyping, breast cancer is a very heterogeneous disease, and that reflects in the treatment outcomes of the breast cancer. And we want to know some imaging modalities which can differentiate prehand to foresee the treatment. Now, for staging purposes, we can use ultrasound and other modalities to however, the PET can be utilized for facilitating breast cancer staging, distant metastasis detection, prognostic prediction, and also evaluation of the pathological response to the treatment. Now, the objective assessment of the tumor response and treatment results has been basis for the advancement of the cancer therapies. The RESIST was introduced in 2000 and then revised in 2009, and for the last 2 decades, this has been the mainstay for all the trials which has been conducted. However, the RESIST has got so many challenges, and I'm not going to discuss all these things, but basically it fails to reveal the viability of the tissue. There are measurement variabilities, and also it lacks the concordance between the response evaluation and the time to interval outcome, like progression-free survival, overall survival, and disease-specific survival. Now, the functional assessment of a tumor, the basic for is that FDG has emerged as a useful tool capable of providing prognostic relevant imaging biomarker. It is observed in malignant tumors and usually related to proliferatory activity and tumor cell viability. Now, the PERSIST, which was defined in 2009 by Wall, it utilizes early metabolic signature and capture on FDG PET. It also introduces standardization and addressing multiple serious sources of variability, and also it can differentiate between true and false response. Now, this is a cartoon which was published by Parier recently, and it shows the protocol for PERSIST, and I'm not going to discuss it because it's available in the literature. And then there are various forms of PERSIST, and basically PERSIST 1 defines the responses, and it has been modified, and then for immunotherapy it has been modified to iPERSIST. Basically, it is used for metastatic breast cancer responses and also post-neoadjuvant chemotherapy. There are few studies on PERSIST which are available on the literature, and this was the first study which was a prospective trial from Sloan Kettering, and it shows that the 40% of the RECIST non-responders were PERSIST responders. PERSIST were more predictive of disease-specific and progression-free survival, and FDG PET could cause changes in the patient management in 25% of the cases in this study. The same group also an year earlier published the same data, and it shows that whether you are assessing single lesion or 5 lesion, the response evaluation criteria is pertinent. Another study from Patterson in Washington, and he compared the FDG with NEF, and it shows that the changes in the FDG PET parameters during therapy are predictive of time of skeletal related events and total progression, time to progression, and overall survival, but not overall survival. On NEF PET was associated with overall survival, but not predicting time to progression or time to skeletal related event, but that was not true when it was normalized for the normal bone uptake. Another study from Olener, again from Sloan Kettering, it shows that there is a 30% variation if you go from RECIST to PERSIST in terms of the grading of the response from stable and partial response to the complete response. There are 2 studies which are published in this year in 2020 from Denmark, and these are prospective trials of 87 patients which were able to receive first-line systemic therapy. FDG PET and contrast enhanced CT were both read separately, and PERSIST nadir scan was used for comparison with the RECIST 1.1 with a median follow-up of 15.9 months. There was a difference in progression of disease was first seen in PET in 78% cases, and PET has a 6-month lead time as compared to the contrast enhanced CT, and baseline measurable disease was seen with PERSIST in 87% of cases versus 53% of the cases with RECIST. The same group published another data, and this was on the basis of progression-free survival and disease-specific survival. Again, on 4-year basis, responders and non-responders were statistically different. In terms of interim PET scan, the patients classified and post 2-cycle FDG PET responders using PERSIST as significant higher 2-year progression-free survival as well as overall survival. The PERSIST is useful for predicting pathological response in prognosis and neoadjuvant chemotherapy, and an optimal % decrease in primary tumor SUV peak was 83%, was found to have sensitivity of more than 77% with equal specificity and predictive value. However, there are some challenges with the PERSIST because it's a complex analysis, and there are technical challenges like partial volume effect, physiological variation, acquisition errors, and suboptimal signal to noise ratio. Difference in various scanners, softwares, and standardization is yet to be, and again, it is available but not acceptable or utilized. Now, the advantage of PERSIST is a high degree of repeatability, less inter-observer variability, differentiate active tumors from post-therapeutic changes. It's able to assess metabolic activity in osseous or non-measurable diseases. It detects response progression earlier, and it classifies patients with static disease with progression disease more accurately, and there is a good correlation with time to event measures.
Sir, two minutes to
This is
wind
the
up,
last
please.
slide. PERSIST seem to be feasible to response monitoring in patients with metastatic breast cancer. PERSIST provide a semi-quantitative response categorization with useful variable of SUL peak rather than SUVmax. PERSIST result in most powerful and independent predictive of survival, and PERSIST parameters predict pathological complete response with moderate accuracy, which affirms that they are predicting value in neoadjuvant chemotherapy. Interim imaging performed during the treatment course may segregate responders from non-responders. Thank you.
Thank you so much, sir. Keeping the presentation well in time, I will hand over the mic to Dr. Brigadier Mehdi Raza for the concluding remarks of the session.
Thank you very much, Dr. Saima Haider. In fact, you had to perform the job of a moderator very strictly. I'm so grateful to the speakers who adhered to the timeline and tolerated the interruptions that we had to offer to their talks. The talks were very enlightening and excellently presented. I'll start with Dr. Catherine Zakotinsky's talk. She talked of future of nuclear medicine, future in nuclear medicine and PET, and complementation of patient management with ancillary imaging and use of newer radiopharmaceuticals. It was a very good talk. Similarly, Dr. Sharjeel Usmani, as always, was motivated and gave a very good talk about the role of 68 gallium PSMA in non-prostate cancers. He highlighted the role in gliomas, hepatocellular carcinoma, and renal cell carcinoma, etc. They were all well done. The last two speakers had to be rushed, and we are grateful to them for bearing with us. Dr. Arzu Fatma was presenting about gallium-68 DOTANOC PET-CT in nuclear neuroendocrine tumors, and with high expression of SST receptors. She had an interesting collection of cases from INMOL, which she shared with us. Dr. Akhtar, as always, is a very dear senior and adhered to the timeline. We just rushed him like everybody else, and he was the most cooperative of them all, and the last one to bear the brunt of everything. I'm so grateful to the whole crowd. You must be waiting for lunch, but let's have a couple of questions if they have to be very quick. If they go beyond a single question, we will head for lunch, and you can discuss your questions with the speakers during lunch. I'm thankful to the panel here, to my co-chairperson, Dr. Rifat Hussain, who is my classmate from school also, and Dr. Saima Haider, who has been with me in the Executive Council when we used to be together a few years ago in Pakistan Society of Nuclear Medicine. I thank you all so much for your patient listening. Grateful.
Can I have one question? If you have given the time for the question. So my question to Sharjeel. Sharjeel, it's a very good talk for me. I think it's a quite new thing for me also. The uptake of this your PSMA in brain tumor, in hepatocellular carcinoma, in renal cell, they all are showing the uptake on the VEGF receptor, VEGF vascular endothelial growth factor receptor. So it means it's going to have the uptake in the VEGF receptor. So do you think that all these patients will be having the high uptake, whether this GBM is having a high uptake of all GBM will be having high uptake of this PSMA, all renal cell will be, and what is the correlation with their serum PSA level?
There is no PSA correlation because these are non-prostate cancer patients, so PSA is usually in a normal range, and sometimes you have a younger patient as well. But regarding the gliomas, they are very active in the grade 4 PSMA, grade 4, or especially the wild type. They are more avid, PSMA avid in the wild type. Grade 4 glioblastoma GBM, as the grade decreases, they have very mild uptake because they are not that much vascular. So it is related to the vascularity of the tumor.
My question, all these GBM will be having high uptake on the PSMA?
GB, yes. And especially it is correlated with the polyphenotype index. If the high polyphenotype index, uptake will be high. The wild type has a more uptake. So these are the spectrum in GBM.
Thank you so much for the question answer session. I would like to invite Dr. Muhammad Inamullah Noman, General Secretary PSNM, for the certificate and shield distribution. Please kindly come on the stage. He's not here? Okay, he's coming. Dr. Sharjeel Usmani, please, for your shield and certificate.
have just requested Barbara for my support.
Dr. Arzu Fatma. Dr. Akhtar Ahmed. Dr. Mehdi Reza. Dr. Rifat Hussain. And Dr. Saima Haider. Me.
Okay, this will be the last presentation before lunch, and lunch is in the just exit on the left side in the Margi Hall. We have to be back by 2:30. 2:30 we'll start a very interesting session that's going to be a debate. So just grab quick lunch and be back by that time. Thank you. Next, I'm just so everyone on the back. जब तक सब लोग नहीं आते, kindly you can just move to the forward seats. And I hope everyone is back in another 2 or 3 minutes. नहीं सर मैं इधर ही हूँ. चलो सारी कौम बाहर खड़े होकर फोटो खिंचवा रही है. Okay, for this session, it's a very interesting session. We have a debate that will be around, will hybrid imaging make conventional imaging obsolete? And to moderate this debate, I will request Dr. Akifullah Khan to take over, and he will introduce the participants and take over the proceedings from here.
I request all the participants to please take your seats. We are about to start a very interesting session of this conference. The DG, no more. Everybody is requested to please take their seats. So today we are going to hold a very interesting debate. It's the first time in nuclear medicine PSNM history that we are talking on some subject of immense interest to everyone. And here we have got two aspects of our discussion. And one speaker will be talking in favor of the statement, and the other speaker is gonna talk against the statement. So let me introduce the first speaker who will be talking in favor of the debate. But before that, let me introduce you to the subject. The question of the debate is, will hybrid imaging make the conventional imaging obsolete? So the hybrid imaging, it's the time of hybrid imaging and the multimodality imaging. And the point to ponder is like whether these hybrid imaging or the multimodality imaging will make the conventional imaging obsolete. So I request the first speaker and who will be talking in favor of this statement. Will hybrid imaging make conventional imaging obsolete? So I request Dr. Amna Hassan to come on the stage, who's a consultant at the Shaukat Khanum Hospital, Nuclear Medicine Division. So you are allowed to talk on the subject for 5 to 7 minutes. And after that, we will ask the other speaker. So we won't make it a very long discussion.
Assalamu alaikum everybody and welcome. I would first like to thank the organizers, Dr. Shazia, Dr. Azra, and all the rest of the team for having me here. Because it's a debate, I guess I will address you as Mr. President. Yeah, Janabe Ali.
Mr. Convener.
Mr. Convener. Janabe Ali.
Yes.
ठीक है जी. और ये debate, I'm not a debater. I've never been a debater. So I like audience participation. Maybe हम बीच में audience की तरफ भी जा सकते हैं. So I've been given is, will hybrid imaging make conventional imaging obsolete? I would say it's not a question of will, it's a question of, it's a statement. Hybrid imaging has made conventional imaging obsolete. I could say full stop and I could walk off the stage right now. because I challenge everyone in my esteemed audience and my opponent to also tell me that it has not. Because it's going
He'll
to
be telling after a while.
He will be, inshallah, and I look forward to it. So, I want the audience, by a show of hand, to tell me who...
No polls. Right now, you have to talk so give some evidence in favor of this. You have just endorsed the statement. Endorsing the statement doesn't mean that you have won the debate.
जनाब आली, मैं इसीलिए ऑडियंस के हाथ उठाना चाह रही हूँ क्योंकि ये मेरे स्टेटमेंट मेरी तरफ से कर देंगे. एक सवाल की इजाज़त दीजिए.
सवाल देखिए, पहले तो आप कुछ सबूत पेश करें, उसके बाद फिर हम उनसे पूछेंगे.
मैं तो प्रैक्टिस पूछने लगी हूँ. मैं तो केस, आई एम गोइंग टू बेस द केस ऑन प्रैक्टिस. वन क्वेश्चन.
Okay, I allow one question.
Thank you.
But that should not be raise of hands or anything, because it would influence the whole debate.
I'm so sorry. I will make a statement.
Okay.
I know for a fact there is no PET scanner in Pakistan. Every scanner in Pakistan is a PET CT. I challenge my worthy opponent as well as the wonderful audience here to raise their hand and say, Pakistan mein, is there a PET scanner? There are all PET CT scanners. You cannot have a PET alone scanner. I trained at an institution which did have a PET scanner, just PET. So I have worked with just PET, and I know the problems that are associated with a PET only scan. Just to name a few, you see an uptake on a scanner. Could be anything. It could be a rib. You've done a PET scan. You've spent a huge amount of money on this scan. You have an uptake. You're going to say, please go get a CT scan. Please get an MR. Or if you have a CT scan from before, please bring it in and I'm going to fuse it. And I've done that. At the center that I trained at, they had PET and PET CT. Every PET scan, we would either tell the patient, bring your previous imaging, we will manually fuse it, or go get a CT scan and we're going to fuse it. So patient's going to come again, patient's going to have another scan. How are you going to ensure that you're fusing it together? That's point one, okay? The next thing is, if we look at history, we all love history, right? How did things evolve? You always have something conventional. You start out with basics. It's the need which dictates. You see, you've got all these wonderful scanners all around the globe, and you find that you need a CT on it. Show of hands ki mujhe ijazat nahi hai, but I know most of you, when you replace a scanner, you will go for a SPECT CT, a gamma, not just a gamma alone. As I was preparing for this debate, I actually thought, what am I going to stand there and say? I was reporting, I had a ton of imaging that day, this last Thursday. And I was like, every single scan I pull up, here's a PET scan, for example. You just put this PET up, tell me where the disease is. I challenge everyone in this audience to tell me where the disease is. It's interesting, I was looking for an image. It was right in front of me. So here's a scan, you see the liver, you see the heart, you see everything you're supposed to see. Where is the disease? Here's a close-up, where is the disease? The audience can't participate. You're going to be hard-pressed. Don't give me kidney, we know there's kidney. I have a CT with this. There's retroperitoneal disease in this patient. Without this CT, you would not have been able to say that. So here's a fusion. Here's a thyroid. What's going on? I've got esteemed members, colleagues, we can all guess what's going on. Conventional image, basic image. What is there? Esophagus maybe? So we went ahead, we said, let's do hybrid imaging. We see a little focus, enhancement, thyroid tissue. Here's a nice fused image. No longer is nuclear medicine unclear medicine. It's clear, it's there. We can tell them right away. We don't have to make our reports say, clinical correlation advised. Please get a CT scan. Please get an MRI. You have the answer. Here's a focus. There's uptake. Is it metastatic? Is it malignant? What is it? You have hybrid imaging. It's a hemangioma. Lo and behold, you've given them an answer. Patient can move on. Patient is comfortable. Why waste their time? I see the clock is being looked at. Another conventional basic image. Here's a sentinel lymph node mapping. What's going on? Do a SPECT CT. You've got a node, you've got injection sites, you direct the surgeon. It's a level 1, it's a level 2, it's a level 3. Give a specific report. It's no longer just say what you want to say. You are using resources as they are meant to be. Stop making patients come again and again, increasing their costs. MRIs and CTs are very expensive in Pakistan. Add that on to a bone scan, it doesn't make sense. As I was called for this debate, I actually received an interesting call by my opponent, Dr. Numair, esteemed colleague. He said, "Ladai na ho jaye udhar."
पहले से मिले हुए हैं। मुझे तो इस पे ये देखें ये नूरा कुश्ती हो रही है।
So ये एक debate है। But Janaab Ali, हम आपके we will rest the case with you and with the audience to decide. So,
Thank you. Wonderful. Thank you, Dr. Amna. Please, you have to stay here for a while because the debate will continue. Now I request head of the nuclear medicine department or also Dr. Arzu is here. So. तो एक और डिबेट मैंने शुरू कर दे डॉक्टर आरजू सॉरी ही इज जस्ट अ डिप्टी चीफ मेडिकल ऑफिसर सो आई रिक्वेस्ट सवाल करने की इजाजत है सर सवालात उठाएंगे सर सवालात बहुत उठाएंगे we have to that was discussed initially and now I request Dr. Numair Actually, nobody has read, I think, the whole phrase in detail. Dr. Numair Yunus, please come on the stage. Yeah, you have to take this podium. And he has to talk. Sir, ये अभी आप इस. That's the question. Now there are many ifs and buts in the statement. Say. Ji Numair. Against. Please.
इसके बाद जो है, you are all feeling this tighty and now a bit excited about this whole debate. अच्छा, hybrid. What is hybrid? So if you go to the history, hybrid says that it's involving a mixture of work or study conducted in the usual locations. And the interesting thing is that early 17th century says that it is a offspring of or a child of a free man and a slave. So here we are deciding about the hybrid, and hybrid history goes back to 17th century. So which of these is a slave, the nuclear medicine or the CT? So this is, I think, the debate. If the nuclear medicine images were providing useful information for such a long time, so the strength in all these images, which Dr. Amna has already shown, and I can rest my case by just saying that all those images were actually nuclear medicine based images. So they showed the strength of the radiopharmaceutical concentrating into some pathological or physiological process, and then okay, we have some problem with the radiological correlation. We get a CT and they see there is a retroperitoneal fibrosis. They don't know whether the disease is viable or not. So they still need a PET image or a SPECT image. So anyway, the debate today is now whether do we need conventional nuclear medicine or should we ask our people to start buying only the hybrid machines?
I think the question is conventional imaging. Not conventional nuclear medicine. So
we will stick to nuclear medicine because if we go to that, it will become a very, very long
third debate.
But this is a very important slide. All of you, please pay attention to this slide because nuclear medicine is not about imaging alone. So it's about conventional therapy as well. It's about the newly developed radiotheranostics as well. And one of the neglected portion is here, which is, if I can show you here. This is radio guided intervention. We use gamma probes, surgical probes, and it's all guided by the nuclear medicine, the radiation signal coming from a lymph node. You don't need any CT if you are doing a surgery. It's just simply a probe that you need, and it will localize the node at all. That's what is required. So the availability of the gamma camera, you can have maybe 10 gamma cameras in this city alone. So how many SPECT CTs? The cost of machine is very high. It's very technically simpler. You just inject a radiopharmaceutical, do the image, and you'll get the answer to most of your queries. And then the cost of the scanning itself. If you go for a SPECT CT, you ask for patient to pay more. And then there is radiation exposure involved. And we'll see how it goes. So I personally believe that the conventional imaging or the conventional nuclear medicine is not being fully utilized to its potential in our CTS or our part of the world. So it's basically the strength of the conventional nuclear medicine, the ability of the radiopharmaceutical to show up a pathological process or a physiological process that is more important. The only thing that we miss on the nuclear medicine images, and we have been, always accepting that truth, that there is poor resolution, there is poor anatomical localization, and there are poor morphological details. So that bit we just take a radiograph, we put up, and we can see how it is doing. We ask the patient if they have already undergone a CT, just correlate it with the nuclear medicine image, and you get your answer. So just to show you, this is a slide shown by Dr. Ahmed Qureshi Saab. I took the liberty to show it here. The SPECT CT right now are only 13 in the country, and against 37 SPECT machines or the gamma camera machines that we have. These are the beautiful images we get from the conventional so-called nuclear medicine image. So anyone from the audience wants to comment on this scan? So Dr. Khalid has correctly said widespread metastasis. Anyone wants to say कुछ और करना चाहिए इसमें? डॉक्टर लुबना, कुछ नहीं करना, कोई CT SPECT CT करा लें, कोई PET CT करा लें, काफ़ी है, ठीक है, अच्छा. So multiple osteoblastic metastasis, this is what we get most of the time in our centers. Why do we need a SPECT CT for this simple study?
DTPA, yes.
What about this one? Anyone?
No need of.
So do we need an ultrasound to correlate with this one? Do we need a CT? Do we need a PET MRI? Do we need a SPECT MRI? I think it's quite straightforward. Just a dynamic renal scan showing you obstruction. And this again, in most of the times, is quite straightforward. Again, it's a diffuse toxic goiter, it's a solitary toxic nodule, it's a toxic multinodular goiter. I think, क्यों अनम कुछ और करना है इसमें? So the only thing we might need it, अनम को मैंने इसलिए पूछा, वो मेरी ट्रेनी है, मेरी तरफ खड़े होगी ना, तो इसलिए I asked her. So anyway, usually the answer is straightforward, and so maybe Dr. Rizwan can comment on that, or probably Dr. Kaisar Siraj Saab. These are your strengths. So do we need a SPECT CT or PET MRI for this one? So it's just severe reversible ischemia in inferior wall, septum and anterior wall.
You have got 1 minute more.
Yeah, so I'm just resting my case. So this is the last image, and 2 more slides to go. So this was an octreotide scan, and it showed uptake, and here we needed SPECT CT. We did it. करना चाहिए था यहाँ पे या नहीं? चलें, कर लिया हमने. Again, it showed that CT did not show any lesion in the liver part because the lesion was isodense, and the SPECT part showed the pathological uptake. And this is from the literature. You can go to the link and you just find it out. The evidence is there that the SPECT or the nuclear medicine part is rather giving you all the information. The CT people, they were actually, since 1970s, they were wandering here and there, and they could not. So that's why there was a need of PET CT and SPECT CT, and the nuclear medicine strength was put into it. The only thing I want to stay here. Thank you very much. So
ट्रेनी बहुत हो गए हैं.
नहीं अभी इन्होंने झगड़ा कराना है.
झगड़ा कराना है, अभी कुछ ना हो.
अभी आकिब साहब ने झगड़ा कराना है. So this is just the radiation exposure that if we are using it without CT, if we do a CT, the radiation exposure increases, and if you are using only, not as a whole body CT, but only on a regional basis, even then the radiation exposure is increased. So yes, SPECT CT might be needed in some cases, but not all the cases. Just this last slide, it's a bit crowdy slide, but just look at the figures I have shown in red. This reflects the data from 2012 to 2020 from UK. It's available on the internet, just go and you'll find it. So it says that the nuclear medicine scanning, which includes only planar, dynamic, whole body images, there has been only a decline of -6%. So the number has been around 396,000 over many years. It's around 400,000 scans in a year. The SPECT part includes the SPECT CT as well, and the number has increased from 19,000 to 45,000 in a year. But does that has made the conventional imaging obsolete? I think the conventional imaging has kept its ground. So the SPECT CT or PET CT or SPECT alone, whatever you do, you will still be looking towards the conventional nuclear medicine. Thank you very much. Although, thank you. Thank you
so
I think with this picture, maybe some of the sympathies I have gained.
For both the speakers who spoke in favor of the statement and for Dr. Numair, you can have a good round of applause. Now, the house is open for discussion, but first of all, let me take a question from Dr. Brigadier Fida Hussain.
Thank you very much. Basically, interesting discussion. The only thing which I want to add, okay, in one way, adding the structural imaging with the functional imaging, it gives a more precision diagnosis in the one way. In another way, previously SPECT and CT, they were totally different thing. Nuclear medicine and radiology was totally different field. What वो एक स्टोरी हम पढ़ते थे जी, किसी जगह पे एक लीमू निचोड़ था, वो जो भी गुजरता था खाना खोलता था, लीमू निचोड़ता था, शामिल हो जाता था. अब हुआ ये कि वो CT डाल के they try to capture the nuclear medicine, which is being done in army. So that is a bad thing. Nuclear medicine is a totally different field, and radiology is totally different field. Why they are capturing us? Why we can't capture them?
Yeah. So, Dr. Humayun is on the link. So he wants to make a comment. So he is waiting for that. Please, Dr. Humayun. He's watching us from there. Unfortunately. Yes, he is there. Nice to see you, Humayun. आपकी आवाज अभी नहीं आ रही.
Yeah, how can you now?
अभी सिर्फ तस्वीर है, अभी रूह नहीं आई है. आ गई. चलें, please, हुमायूं.
Okay, thank you very much. I'll be very brief. It's a very important and useful discussion, and the arguments from both sides are very valid. The only thing is that conventional imaging will stay there. It's not going anywhere. That's the impression. What is happening in UK, they are putting up simple gamma cameras because they don't have money for a SPECT CT camera. That's a factor you need to understand. In the rest of the world, I keep telling people over here that even developing world is not buying any more simple cameras. I think what will be required will be that the simple non-conventional or conventional SPECT cameras should become more handy to do thyroid and renograms. I think the Germans had some similar smaller cameras, while bigger machines should be hybrid. As far as the argument is concerned, PET CT is not possible without CT. Many of cardiac also is done with CT over here now. So it's an overlap. One last thing I would say is that I recently had an opportunity to talk to year 1 MBBS trainees about imaging in general. And when I was trying to explain radiology and then trying to explain nuclear medicine, it's different. It was a sea change. It's like talking about where the Pacific Ocean meets the Atlantic Ocean. They'll touch each other, but will they remain separate? Thank you.
Actually, I think Dr. Siraj mentioned, but in a slightly cruel way, that this topic should not be discussed. It should be discussed, but can be modified by saying that, the word which has been used that it will be obsolete, that is not going to happen anyway. because there are many occasions when we don't need CT. For example, whole myocardial infarction, there are so many other things where really you don't need CT. Yes, we need it for localization in many, many important things, but that does not mean that other is obsolete.
Right. डॉक्टर आप मेरे ख्याल में प्रेसिडेंट आखिर में ना बोले, वो तो कदम बोलने की इजाज़त भी नहीं देते. Let the trainees have their the younger generation who are in the nuclear medicine specialty, or some are opting for radiology and they are so. करवानी है. आप एक मिनट पहले इनसे ओपिनियन ले ले, कुछ ओपिनियन बने तो सही ना. लड़ाई कहाँ
सॉरी इधर कॉन्फ्लिक्ट ऑफ इंटरेस्ट है. वो ट्रेनीज सारे मेरे अपोनेंट के साथ हैं. हमें ताली से पता चल गया. बिल्कुल आप इधर कहीं
मैं किसी और कहीं और से
नहीं ये सारे
हमारे यहाँ एक और ऐसा भी बंदा है जो न्यूक्लियर मेडिसिन छोड़ के जा चुका है, उनसे बात करते हैं.
ये इन सारे ट्रेनीज का एग्जाम डॉक्टर आमना ने लेना है.
सोच के बोलिएगा.
लेकिन it's a very simple question. Should we discuss on this? How much percentage of conventional is required now in this status, and how much physiological imaging is required in this state? I will just put a simple one question. If you're having the widespread metastatic disease, whatsoever is the primary, will that patient need CT scan or will that patient need PET scan? It's very simple answer. All those people who are reporting the PET scan, there is so much referral of the widespread metastatic disease with the PET scan. I think there is no need for simple at the PET scan. CT is going to answer this your question. When there is a need for PET scan, that is when you are not clear on your conventional imaging, then you need something in the form of PET scan. So I think discussion should be on the percentage of conventional imaging versus on that physiological.
Your point is it's not getting obsolete anyway. So there are a lot of the areas where still conventional nuclear medicine would be available to people in the coming years. आप कुछ कहना चाहेंगे?
I am having very brief question. I am just asking how many PET only scan you have done until now?
Okay, so if you no, it doesn't matter. Doesn't matter. In fact, if you go through the guidelines, none of the guidelines require that a PET only scan should be done, right? So all the guidelines, and now I think being a nuclear medicine person, I would say a PET scan. I would not write CT because it is understood that the CT is under the cover of PET. Yes. So this is my advice to all the nuclear physicians who are practicing PET CT and reporting on it. Just call it a PET scan. The strength is with the PET, not with the CT. So rightly answering your question, we do PET only, or we interpret PET only when we are dealing with the cardiac. So we don't need the CT component. We just comment on the viability by looking at the PET images. If we are doing PET images for the sarcoidosis and other things, many times you don't need the CT component.
I just want to say something in addition to what you said. He's right. The point is that we cannot not do CT because it's a part of the equipment you have. So for attenuation correction, you cannot do it without the CT. You cannot buy it, it's not your choice. You're already there.
But still there would be a lot of gamma cameras coming without a CT component.
I'm going to finish the PET debate. Let's finish it here. There are no scanners without CT anymore. There used to be. As I said, I've worked on them. But the thing is, that CT image is your responsibility. I'm talking to all the trainees back there. Whether it's a cardiac PET CT, whether you're only using it for attenuation correction, that CT is your responsibility. Each one of you now is a hybrid imaging specialist. If you are reporting PET CT, you call it PET, you call it PET CT, that's just potatoes, whatever. Okay. You got to report that CT, it's all hybrid imaging. So one aspect we can rest, all PET CT is hybrid imaging.
Okay. Actually, I am going to reiterate what Dr. Amna just said, because Dr. Namer very enthusiastically said that we should just, when we are advising the patient, we should write PET scan. I need to ask him, when we are writing reports, do we say PET report or PET CT? We always say PET CT because it's the era of now hybrid specialty. And you know, not only in Pakistan, this debate is being taken up all over the world. And over there, people are actually trained in both the modalities, nuclear medicine as well as radiology. So it's no longer, you know, just nuclear physicians or radiologists. If you look at it, most of the training courses that are coming up, they are involving both the specialties. Number 2 point I need to make again, because both the people standing on the dais, they showed kind of biased images. Dr. Numair showed a bone scan image that spoke for itself. But then you come across many images where you do need the CT part to characterize and localize the lesion. Similarly, Dr. Amna showed the images that did not need, you know. So I think the statement in itself, obsolete, is the catchy part. The thing is going to be obsolete. They are going to go hand in hand.
देखिए आपको साइड पिक करनी पड़ेगी, आप दोनों की साइड नहीं ले सकते.
Okay, just two questions, 2 comments we are going to take, Dr. Rizwan and Dr. Shazia, and then we will get a raise of hands, and then after that we will decide about what उसमें 3 options मैं रखूँगा.
नहीं नुमैर जैकेट वापस पहन लो.
सीरियस हो गई है मुख्य से.
जैकेट वापस पहन लो. देखें आमना, जब मैंने भी शुरू किया था, I started with the pets and I worked really hard, and first paper that came out with the pet was basically, it was there. What you need to understand that nuclear medicine is nuclear medicine, and that comes on top of radiology. I am dual, but you know, when you request, like what Numair said, a pet, you are always asking a question, what is the activity? You're not asking what structure. So structure comes secondary. So anything, I didn't have the time, and I wanted to ask a question on thyroid. A child who had therapy, and then I did a 1, 2, 3 scan and multiple dots in the lung. I reported as, so I said I will go and have a look at the chest CT. I couldn't find it. The patient again had repeated after 3 months, again similar pattern, went back to look at the CT chest, nothing there. So what does it signify? The metabolic activity oversees the structural imaging in oncology and the otherwise. So nuclear medicine still stays on the top, depending how you are going to perceive that eventually.
डॉक्टर रिजवान, आपने तो मेरी टीम की बात कर दी. आपने जो स्कैन किया और सीटी को आप, you looked at the CT as well. You wanted to make sure there's nothing in the bones. We know tiny metastasis in the lungs may not be apparent on CT. However, if any of that activity had gone onto bone, your dose would have been modified.
No, no. So I would, yeah, but I could have seen it on the planar and the SPECT images.
You couldn't have been sure without your SPECT CT.
No, ribs and the lung, I should be able to.
Ribs, it was possible one of those was in the
You
ribs.
don't need to answer every comment.
Okay.
Can I add a brief comment here, please?
Who's?
Humayun, here.
ये कहाँ से आवाज आ रही है? मैं भूत भी बोल रहा हूँ.
I just have one small point. Dr. Amna raised a very good point. Whatever the equipment, there is no such thing as a non-hybrid trained nuclear medicine physician in 2023. If anybody is, they should change their trade. Every nuclear physician should be able to interpret the CT done with a PET CT or a SPECT CT. Thank you.
डॉक्टर शाजिया, आपकी कमेंट के बाद फिर हम इसको क्लोज करते हैं. Sir.
In debate, actually, always it is looked what is written in the sentence.
Yes.
I think if the sentence is written like this, that the other things will be obsolete, then probably many people will not vote. But we are not denying that CT is not required. We say it is required, but it will not obsolete the other investigations.
So ये तीसरा ऑप्शन रख लेते हैं ना, 4 ऑप्शंस रख लेते हैं. हम तो वैसे भी मल्टीपल चॉइस क्वेश्चंस बना रहे होते हैं. All of the above, none of the above.
इस डिबेट का जो ये टॉपिक रखा है उसके लिए अगर किसी को वो एग्री नहीं करते तो आई थॉट अबाउट इट एंड देन वी चेंज अ लिटिल बिट, बट उसका ऑब्सोलीट रखना इसलिए ज़रूरी था वरना ये डिबेट बनती नहीं थी। तो फॉर द सेक ऑफ डिबेट वी रोट, एंड द अदर टॉपिक हमने ये सोचा कि ये अभी इसलिए नहीं करते कि
अंग्रेजी में बात करें,
जिंदा रह जाए, तो उसके बाद दूसरी में भी कर लेंगे क्योंकि वो ज़रा ज़्यादा कंट्रोवर्शियल था। डॉक्टर हुमायूं से मैं मिली हूँ एशिया ओशियाना में, एंड देयर वाज अ टॉक बाय जीटिंग ली फ्रॉम ऑस्ट्रेलिया, and they were telling about the regulations of theranostic in Australia, and in that एक slide थी और जिसमें she said के in regulation they are going to call the physicians which are trained in theranostic theranosticians. That was the term. And मेरा सवाल ये है कि ये जो हम कहते हैं कि हम 200 बैठे हैं उसमें से कुछ तो हो जाएंगे हाइब्रिड इमेजिंग स्पेशलिस्ट, कुछ थेरानोस्टिशियन 10 एक हो जाएंगे और कुछ क्या बन जाएंगे। इतनी सी स्पेशलिटी को, डॉक्टर हुमायूं का एक पेपर भी है, आप सब लोग उसको पढ़ें, कि इतनी सी स्पेशलिटी को हम और डिवाइड कर रहे हैं। वी आर ऑल न्यूक्लियर फिजिशियन एंड वी शुड बी अ प्राउड कम्युनिटी और प्राउड न्यूक्लियर फिजिशियन होने चाहिए। वी शुड नॉट कॉल आवरसेल्फ ये वो, और जो डिपार्टमेंट्स कर रहे हैं दे आर डूइंग फाइन। हम पेशेंट्स के लिए सारी चीज़ें करते हैं ना, डिबेट तो डिबेट के लिए होता है। और आप हमेशा क्वेश्चन पूछते हैं कि होना भी चाहिए, एक हर चीज़ का प्रो एंड कॉन होता है। ये एक समड अप तो यही करेंगे कि लोग क्या कहते हैं, लेकिन मेरा ये ख्याल है कि हाँ,
Thank you.
फिजिशियन है एट द एंड ऑफ द डे।
अभी टाइम इज ओवर, आई एम ऑलरेडी प्रेस्ड। अभी आप अपना शो ऑफ हैंड में अपना पॉइंट बता दें। Yes, adding color to it. Thank you. Wonderful. Okay, who is in favor of the for Dr. Amna ने जैसे present किया? Who thinks that the hybrid imaging will make the conventional imaging obsolete? Who are in favor of that should raise their hands. सवाल गलत था।
Leading question.
अच्छा, मैं अब दूसरी साइड नाउ सो ये तो सवाल तो खैर मैंने नहीं बनाया था, मुझे तो फंसाया गया है। तो एंड who thinks that conventional imaging, conventional nuclear medicine will stay there and along with the hybrid imaging, so who is in favor of that? So थोड़ा सा इसमें a bit of a bias we have over here as well. Like most of the audience are nuclear physicians, so one should be proud to be a nuclear physician, but the bias is also there. So let's take this question to the RSP conference. लग पता जाना है। Okay, so thank you the worthy speakers. Yes, yes, shake the elbow. Yes, yes, yes. जो तस्वीर लेनी चाहिए, एक पिक्चर हो जाए, एक पिक्चर आपकी होनी चाहिए। हाँ, दोनों।
पाकिस्तान हारा तो हंस के निकले।
Thank you. And thank you everybody for your very vibrant contribution to the discussion. I request Dr. Ahmed Qureshi to present the certificates to the worthy contestants. I request Dr. Amna to collect her certificate of participation in this debate. Sir.
मैं इसमें देता हूँ। यहाँ पर बहस तो बड़ी हुई है। उधर आ जाओ।
सर ऊपर आ जाओ।
नहीं यहाँ सुखे। लेकिन मेरे ख्याल में इन जो भी बातें कर रहे थे उसी के अंदर आंसर भी था। आंसर was there. They were calling it SPECT CT and PET CT. जबकि I'm sorry शौकत खानम के वेबसाइट पे बहुत अरसा CT PET लिखा जाता रहा है। पता नहीं अभी तक करेक्ट हुआ या नहीं हुआ। बट द थिंग इज अभी आप चले इंटरनेशनल लिटरेचर में देख लें, वहाँ पे CT SPECT CT PET अब नहीं लिखा जाता. तो मेरा मतलब है कि इसमें CT का रोल relatively कम है. It is there, लेकिन relatively कम है, and we are getting help from them. That's it.
We are helping them. मेरा इख्तिलाफ है इधर.
नहीं, मगर आप जिस साइड पर थी तो आपको ये बाद में दूंगा सर्टिफिकेट.
अच्छा.
नहीं, लेडीज फर्स्ट. आ जाए. नहीं. मैडम.
बॉक्स के बगैर करने की यहाँ से रखें. एक और
Dr. Numair Yunus for it was Thank you. मैं इतना सारी देर खड़ा रहा हूँ.
आपका चूंकि यू आर ऑन द लाइक बॉर्डर पे तो आपको इसी नजर आना है.
On the behalf of BSNM and PIC, I am thankful to all of you making this event successful. And now we move towards our fourth session, and I would like to invite Dr. Arzu Fatma, Head of Nuclear Medicine Department in Mole Hospital, Lahore. Please come and moderate this session. Thank you.
Amna and Dr. Numair. Both were very interesting in their presentations, and the best purpose that they served was that after lunch I can see everybody wide awake for the next session. So this is going to last I think around 2.5 hours, and so without further ado, because we have removed the chairs from the stage, I would like to invite the chairperson, Brigadier Dr. Fida Hussain, to please come and take your seats somewhere here. And the co-chairperson, Dr. Muhammad Mansoor, please come. Okay, so almost 3/4 of this is going to be online. Only, I believe, our first and last speakers will be presenting physically. So the first speaker is Dr. Kaisa Siraj. We've already had his detailed introduction, I believe, in the morning, so I'm going to cut it short. Dr. Kaisa Hussain Siraj is a senior consultant in nuclear medicine and PET-CT at the Department of Nuclear Medicine, Farwania Hospital, Kuwait, for more than 10 years. He has worked in several teaching hospitals in London, and he has a vast clinical experience in the field. He is an examiner for the Asian Board in Nuclear Medicine, an IAEA nuclear medicine expert, and has worked on the certification and quality panels of the General Medical Council UK. His specialty interests include nuclear cardiology, neurology, genitourinary medicine, PET-CT, endocrinology, and sentinel node imaging. He is the editor-in-chief of the World Journal of Nuclear Medicine for the last several years. So he'll be talking about dual tracer radionuclide imaging in hyperparathyroidism, thallium-201 parathyroid imaging revisited. Thank you.
Thank you, Arzu, for such a detailed introduction. From the previous discussion, all I would like to say, and everybody likes to say the last word, it is in the practice. You look at the practice of conventional nuclear medicine and the structural nuclear medicine, and they are now hybrid, and as my talk will demonstrate, there is the function that is the most important thing, and the structure comes in secondarily. But I am biased because I am a nuclear physician married to a radiologist. So hybrid is really the thing. Here what we are going to talk about today is dual tracer radionuclide imaging in hyperparathyroidism. The outline of the talk will be, I will briefly discuss the parathyroid anatomy, embryology, the parathyroid physiology, the clinical context of hyperparathyroidism, parathyroid gland imaging, the radiopharmaceutical, the scintigraphic techniques, but very, very briefly, and I'll try to stick to the time, and how to optimize the image and display SPECT, CT, thallium, and SESMID imaging cases, and then I will come to the main topic of parathyroid thallium imaging, which used to be and then was discarded, has now has a re-advent, and then what is the tailored approach to radionuclide parathyroid imaging. Parathyroid anatomy, as we know, there are two pair of parathyroid glands, superior and inferior, 2 to 6 in number, 50 grams in weight, and they are mainly composed, and I want to underline this fact, of chief cells which are responsible for parathyroid hormone secretion, and a smaller number of oxyphil and transitional cells. The oxyphil cells are what are imaged by SESMID, not the chief cells. So this is a very strong point to note at this point. The parathyroid embryology is important because of the ectopic location, the embryological origin of thyroid, parathyroid and thymus glands. The inferior parathyroid glands and the thymus develop from the pouch 3, and they go along with the thymus downwards, whereas the superior parathyroid glands develop from pouch 4. Therefore, the parathyroid ectopic glands, which could be 15 to 20% in number, range all the way from the angle of the jaw to the pericardium. And you can see there are multiple locations. They could be undescended, retropharyngeal, intrathyroidal, posterior superior mediastinal, anterior superior mediastinal, and true superior mediastinum. So these are the locations. Parathyroid physiology, parathyroid hormone is responsible for calcium homeostasis through 4 different mechanisms, through a direct action on the skeleton, stimulating the osteoblastic activity to promote calcium release from the bone, the facilitation of calcium absorption by the kidneys through an increased conversion of 25 hydroxy vitamin D to 125 hydroxy vitamin D, and increasing calcium absorption from the GIT and blocking reabsorption of phosphate in the proximal tubule, while promoting calcium reabsorption from the ascending limb of loop of Hindley. So symptoms of hyperparathyroidism, it was classically, it was known as a disease of bones, groins, and renal stones. However, in current days, because of the early diagnosis laboratory, we rarely meet patients with such classical symptoms. And the types of hyperparathyroidism, primary, secondary.
Interrupting you for a second, I need to make
what
an
happened?
announcement. Well, the posters are there outside for evaluation, so kindly all of those, the evaluators as well as those who are being evaluated, kindly move. Thank you so much. And I need to tell you, you have 7 minutes left.
All right. Well, I was given this, okay, so primary, secondary, tertiary. Primary is mostly due to a single adenoma and 4-gland hyperplasia in 15% of the patients. So parathyroid hormones, adenomas are most chief cell adenomas, and hyperplasia as chief cell hyperplasia. So I said before, the current diagnosis of hyperparathyroidism is based early on due to early diagnosis of hypercalcemia, and which is known as the normal borderline or sporadic elevation in serum calcium, known as the eucalcemic or normocalcemic hyperparathyroidism. Now the previous, for the last several years until the advent of the invasive surgical techniques, parathyroid localization was deemed only feasible for the best localization test was said to be to localize. A good surgeon will take all of the glands, but now because we have non-invasive surgical techniques and intraoperative parathyroid hormone assays and intraoperative gamma probe localization of the culprit parathyroid lesion has revived the need for preoperative localization. Here's a picture of a gamma probe, radio-guided minimally invasive surgery compared to bilateral neck exploration. Minimally invasive approach is a small incisions, less complications, can be performed under local anesthesia as an outpatient procedure. The structural imaging are ultrasound, CT and MRI. Radionuclide imaging is planar, subtraction imaging, SPECT CT, and now PET CT. The radiopharmaceuticals historically a cyanocobalamin, thallium-201, maybe tetraphosphamine, and selenobethunine was introduced in 1960s, poor biological and imaging characteristics. This was superseded by thallium technetium subtraction scanning in 1980s, and this was the first practical parathyroid imaging agent. Then when MIBI came in, it took it over. I will try to show the mitochondria-rich oxyphil cells are responsible for for sesame retention and localization, because the washout tissue from the parathyroid glands is slower than that from the thyroid, but the sensitivity ranges widely. And that's why we used to have a dual subtraction scanning, we still have, whereas thallium, maybe tetraphosphamine can localize the thyroid and the parathyroid, with the thyroid being localized by technetium pertechnetate or I123 iodine, and you then subtract one from the other and you lift with the image of the parathyroid gland. Early cases, I'm very proud of that. This is the first case I performed at the Nuclear Medical Center in AFIP in Rawalpindi in long time ago in 1986. 3-year-old girl with primary hyperparathyroidism, parathyroidectomy failed, thallium scan, and then the technetium scan and the subtraction scan shows a parathyroid adenoma. Another case of which I did at that same time, ultrasound shows two nodules with the right thyroid lobe, and the thallium scan shows uptake in the upper right lobe, and the thyroid scan shows a hot nodule in the lower right lobe, and this is a subtraction scan shows the interest focus of activity in the upper right lobe. So here we have a case of a large thyroid adenoma as well as a parathyroid adenoma diagnosed that far back. So you can see how thallium was so very specific to this. I will not go into this. This is just the image optimization because the time limits, because inverse grayscale is better, and again by compressing the lower levels and expanding the values of higher pixels, giving you a better image as you can see here. And I prefer the red, blue and green, which actually extrathyroidal are in blue, thyroid is intermediate level, and hyperactive parathyroid is in red, and it's easy to do it if you have the workstation. The current cases, I will just show you this thing. This is a primary hyperparathyroidism, and you can see a parathyroid, left lower parathyroid adenoma here with SMIBI, and this left lower parathyroid adenoma on the SPECT CT. And another case here, you have the pertechnetate, maybe planar, etc., and it shows something ectopic, possible ectopic parathyroid adenoma, which is very easily localized by a SPECT CT scan. Now there are very many factors that affect this SMIBI uptake, including size, cell type, mitochondrial structure, metabolic, secretory activity of the cell cycle, and the expression of P-glycoprotein, I think, is not that important. So in my early experience in patients with persistent biochemical hyperparathyroidism, primary or secondary, with a negative SMIBI scan, which was successfully localized accidentally by thallium-201, and I'll show you a couple of fake cases here. You have these planar images, and they are negative, but when you do maybe technetium subtraction scan, you see technetium, thallium technetium subtraction scan shows a right parathyroid adenoma in this case, and a false negative technetium SMIBI scan. And this patient was taken to the surgery, and they was successfully we took out a right upper parathyroid adenoma. So it's a case of a maybe negative thallium positive parathyroid adenoma with no P-glycoprotein expression. Another case, again, there was no adenoma seen, but it was seen on a subtraction scan here. So the results of these early planar cases encouraged me to investigate patients' biochemical, both primary and secondary hyperparathyroidism. Well, I have to finish it. With SPECT CT scan with a follow-up thallium scan. And this is a study that was published in the Nuclear Medicine Communication, dual stage tracer radionuclide imaging in hyperparathyroidism to revisit thallium parathyroid scintigraphy. The aim of the study was to look at the possibility of an incremental diagnostic role of thallium parathyroid SPECT CT in patients with presumably false negative SPECT CT scan results. And there were 22 patients, 16 primary, 6 secondary, where SESMIB scan was negative or inconclusive, or where additional lesions were suspected on structural imaging. And these are the imaging techniques. And here we have the planar images being negative, but when you do a technetium MIBI scan, you see a right-sided parathyroid adenoma, and a thallium scan again shows a right-sided parathyroid adenoma. So dual tracer MIBI and thallium thallus chloride avid right parathyroid adenoma. So here both the MIBI and the thallium were equally effective in localizing the adenoma. This is a patient with primary hyperparathyroidism. MIBI scan shows uptake in the smaller adenoma up there with the green arrow, whereas the thallium scan shows uptake in both the smaller adenoma as well as one in the lower one. So it's a double parathyroid adenoma. Only one was maybe avid, whereas both were thallium positive. Another case here with uptake in bilateral lower parathyroid glands, you can see on SEST-MIBI, but when you do a thallium scan, you can see uptake in 4 parathyroid lesions here. So 4 gland parathyroid hyperplasia, 2 SEST-MIBI avid glands, and 4 thallium avid glands. So here is a case where we have a technetium MIBI scan in a patient with secondary hyperparathyroidism, which is negative. However, when you do the thallium, you see a 3-gland parathyroid hyperplasia. So we come to the results of the study. Further imaging with thallium 201 SPECT CT showed 46.5% additional lesions in patients with hyperparathyroidism. In primary, caused by adenomatous or hyperplastic glands, thallium 201 imaging showed 59% additional lesions, hyperparathyroid lesions. And patients with secondary hyperparathyroidism, 33% hyperplastic additional parathyroid lesions were seen. The reason I said, and I've said it earlier, it is because of the localization of thallium in the chief cells, which are actually the main culprit factor of the is that. And because in the planar imaging was superseded by planar MIBI imaging, and because it's superior physical characteristic, thallium imaging was abandoned. But when you do a thallium SPECT CT, it can not only not provide equivalent physically and technically equivalent result, but because of the biological characteristics is superior. So these results of this pilot study strongly advocate a role of thallium parathyroid SPECT CT imaging in patients with primary and secondary hyperparathyroidism with initial technetium MIBI scan is deemed to be false negative in the presence of biochemical hyperparathyroidism. And I'll stop here.
Having question answers at the end of this session. So please, if you have any, just note them down. The next session is going to be a bit extensive, and it will be online. It will be primarily on neuro-oncology, and it will be led by Dr. Arif Sheikh. So let me introduce him. It is indeed an honor, Dr. Arif, to be introducing you. And he is the medical director /PET at Kettering Network Radiologist. He is director of targeted radionuclide therapy, who introduced advanced clinical dosimetry that is pharmacodynamics and kinetics, co-founded and led multidisciplinary thyroid and endocrine tumor board, and developed targeted radionuclide therapy clinic. As director of cardiovascular nuclear imaging, he introduced advanced clinical imaging as routine standard of care. He has extensive teaching experience of trainees in multiple specialties: nuclear medicine, radiology, cardiology, radiation oncology, general internal medicine. He has extensive didactic teaching experience both locally at UNC, at national meetings, international venues. He remained part of graduate thesis committees as involved in mentoring of postdoctorate students in the joint schools of biomedical engineering, UNC and NC State University. He is Radiology Quality Assurance Officer for peer review activities. So I invite you, Dr. Arif Sheikh, to kindly take over and conduct the rest of the session. Your allocated time is 1.5 hours. Thank you very much.
Thank you very much. Just checking to make sure you can all hear me. Hello? Just can you all hear me?
Yes, sir, we can hear you.
Okay, wonderful. Thank you very much for inviting me to this session today. We are broadcasting from the United States, and it is indeed my great pleasure to have put together a session with some of my colleagues and some very good speakers from across the US with neuro-oncology. And so I will be giving a presentation on the uses of nuclear medicine, at least in imaging in neuro-oncology. I'm going to start my slides and share that with you. And again, yes, I think you can see my slides and you should be able to hear me. So for those of you who know me, I've been actually jumping around a bit. I am now at Kettering Medical Center in Ohio, where I'm the director of theranostics. And one of the wonderful things that I found here is an excellent neuro-oncology program that I will be talking briefly about, which I think I hope you find interesting. Okay, so in terms of disclosures, I have no particular disclosures except some of the stuff that we're doing here is not officially FDA approved, although we're doing it under special permission by the FDA. And I'm also very deeply appreciative of Dr. Martin Jacobs, who is my colleague in nuclear medicine. And since they've been doing imaging for quite a while in this field, he provided me the lion's share worth of the slides that I'm going to show you today. I'm going to very briefly touch upon what it is that we've been doing. Kettering Hospital is actually not itself an academic institution. We're just very much a run-of-the-mill community hospital. And I would say almost run-of-the-mill because one of the jewels that we have here is that we have a cyclotron program, a PET imaging program that is, even though it's a community hospital, it rivals that of some major academic centers around the country. Just to kind of give you a timeline of what's been accomplished here, after the first PET scanner was approved in 1985. That's the world's first PET scanner. Kettering Hospital was able to acquire a cyclotron facility and a PET camera by 1990. So within 5 years, they already had one. And I will let you know that everybody else, including all the other major academic medical centers, started getting their first PET cameras 10 years later, 2000. And there are certain medical centers that still don't have PET cameras in the US, surprisingly. But certainly Kettering has been leading the charge. And with the PET camera, they've done some fairly advanced research, a lot of it in the neurology side and neuro-oncology side. But upon my arrival, I have added on the theranostics aspect, especially now that it's taking off so much. So I'm really proud to be a part of the center. And what I will be doing is actually laying some very basic groundwork. So I'm going to be actually talking about some of the clinical stuff that we've been doing and setting it up for my colleagues that I have assembled together to go further into depth about with what our capabilities have been thus far. So in neuro-oncology, in terms of imaging, what is it that's really needed? We need to identify the malignancy, at least find out initially if we see a lesion, is it benign or malignant? Maybe is it infectious or is it really a cancer that we're looking at? Once identified, go through initial staging, and then we want to be able to treat the person with surgical, radiation-based treatments. And then once the treatment's done, if there's an issue of recurrence, figuring out if there's radiation necrosis or is it just scar tissue left over from surgery versus malignancy recurrence, that's an issue. And then some of the stuff that comes in the future might be molecular profiling of lesions based off of imaging. We won't be touching on that much as much today. I'm just kind of putting it out there as a general thought. So we were just talking about thallium imaging. Thallium imaging has been used ubiquitously in a lot of areas. This is a case where a lesion was seen on the MRI and a thallium imaging was done to try to correlate the uptake, and there really wasn't much uptake. It was a very mild uptake, showing that this is likely not malignant. It turned out to be a toxoplasmosis. And but of course, going away from SPECT, PET has become a much bigger issue in and player in this field. Now, most people are very familiar with MRI because of its high resolution and because of its superior aspects of being able to do surgical planning and radiation planning. You see what is there. And it gives you the great soft tissue contrast, but it is also understood that there's often non-specific findings that we see, and it may potentially under and overestimate the extent of the disease. FDG PET has come along, and there's been greater specificity with regards to PET, and we know that it picks up more aggressive sites of disease, but the problem with FDG PET has been there's been high background and signal limits, which limits the sensitivity of what we see on PET. It is lower resolution, and it still has some issues with inflammation, albeit could be better than MRI. Now, most places, even though they have PET, neuro-oncology tends to use MRI a lot, but I will hopefully show you where some areas where PET can at least add information, if not more. Here's an older case where there's some amorphous changes in the brain based on MRI and CT, and we can see on FDG PET that there's a little small focus of uptake in the right frontal lobe, which turned out to be an oligodendroglioma. So before they went in, they were able to find the tumor, localize it a little bit better amongst these amorphous changes, and also confirm that it's likely going to be malignant in order to do appropriate surgical planning. This is a case actually done with PET-MR, where there's a lesion after the patient's being treated with radiation, and the question is there radiation necrosis? An FDG PET scan was done in conjunction, so this is really a PET-MR rather than a PET and MR, and that those findings suggested that this was more akin to radiation necrosis because, again, the uptake was very mild, and that was sort of also confirmed with more advanced MR sequencing. This is a case where I did on PET-MR back when I was at the University of North Carolina, where we see a main lesion on the left side, which only has mild FDG activity, suggesting that that probably may not be a recurrence. but we see a much more avid lesion in the left occipital region corresponding with the MRI findings suggested that that is the malignancy that we would be much more concerned about and would need to biopsy and or surgically or radiation therapy. Likewise, here's a case where a PET MRI was done on a patient where we saw a lesion. There was a question of, is this recurrence or not? And as we can see with the fusion, what happens is that only part of the lesion lights up. So that's very helpful because, again, part of it turned out to be necrosis, but we were able to localize that part of the lesion that was most active where they biopsied and confirmed that there was recurrent disease there. So if you can imagine if they'd just done the MR and they felt that, yes, this is going to be recurrent disease, they might have very well could have biopsied the wrong place and gotten the wrong information, not realizing that there was a nidus or recurrence within the area of necrosis, and the patient would not have gotten the appropriate treatment. But one of the things that we are doing here at, and we have been doing, as pointed out, since the early to mid 90s, and that's before the approval of PET, is the use of C11 methionine imaging. C11, carbon 11, has a half-life of about 20 minutes. C11 methionine is metabolized by transmethylation, and it is ubiquitous. It's found everywhere, and when given, it is rapidly incorporated into protein synthesis. And the usefulness is malignancies because there's increased avidity for methionine in a lot of tumor cells. It's known as the Hoffman effect. There's rapid uptake in metabolism into lesions. Given the very short half-life, that is very important that happen. The good thing about methionine is that unlike FDG, that there's low background uptake in the brain, there is uptake there, but not much. In terms of whole body imaging, there's high liver uptake and it limits liver evaluation. It is liver renally excreted. There is some bowel activity as well, but again, over the time period we're imaging, that's not as such of a big deal. But there is higher uptake in many malignancies where there's lower FDG avidity. For example, in low-grade malignancies, methionine will have better uptake than, say, FDG would. And this is just one of the cases, one of the many cases my colleague, Dr. Jacobs, gave to me, where we can see that there's concordance of glioblastoma uptake on both the methionine and the glucose FDG PET imaging. And then you can see in the MRI, it is not as well seen, but you kind of look at it carefully, you can see where the how the images correlate with the MRI. This is a slide for fluciclovine, which one of the colleagues that I've talked about from University of Pennsylvania will be talking about today. But basically, amino acids have very similar ways of uptake into the cells. There are two transporters, amino acid transporters that are upregulated in malignancies, particularly LAT1 and ASCT2. LAT1 is the one that's primarily responsible for uptake of methionine into tumors. So, give you another case where this is methionine uptake and FDG uptake, and superimpose it onto MRI. You can see the MRI abnormality, but what you will see here that there's a significant discordance between the methionine and FDG uptake. So if we had only done FDG scan here, we would have completely missed the lesion that the methionine imaging is clearly showing. And you can see the background uptake. There is background uptake in the brain, but not as bright as what we see in FDG imaging. So the way we're performing methionine, as I said, it is not FDA approved, and yet we're a community hospital doing this. But we do have a special expanded access program where a special permission is granted by the FDA. It turns out we're one of the 2 sites that are really given this special expanded access, and certainly one of the only adult sites in the US to be able to do this. The other site is St. Jude's Children's Hospital. Again, they use it in pediatric patients. It's not to say that other sites are not using it. They have special INDs, research INDs that they can do it for specific studies, but we're kind of doing it as very routine standard clinical care in our patients, at least under this particular program. So how do we do it? Patients usually fast. Now we usually do methionine and FDG in tandem together, so the patient is fasting anyways. We inject about 20 millicuries or 740 megabecquerels. Uptake time is about 20 minutes. And then again, you want to minimize patient stimulation after the injection. And then once that's done, we immediately follow it up with FDG injection for brain imaging, since the patient has already been prepped for that. Again, same thing, same concept, where we show you that there's uptake in the methionine, but not FDG. And I believe this was the same patient where at a different location in the brain, the patient has another lesion which actually does have methionine and FDG uptake. So this is important now, because as you can imagine, automatically you start thinking that there may be something different about these lesions, and indeed that is what the future is going to hold in terms of being able to decide what kind of therapies to give and how aggressive we should be with these lesions with the various modalities we have to treat these patients. Again, just a quick cartoon to show you, as you know, how FDG works. C11 methionine works by the same overall sort of analogous mechanism by going through transmethylation. But as I showed you, the transporters are the LAT2 and ASCT1, which take up amino acids across the cell. So this is a case of where there is a very low-grade tumor, and both methionine and FDG do not have uptake. So what we know, that this could be a benign lesion, and unfortunately it could also be a very low-grade tumor. So yes, there are some lesions that even methionine may not pick up that could be malignant, but what's very encouraging here is that this lesion is probably not going to move very well, and the overall prognosis is quite good. This lesion can be fairly well extracted if it need be surgically, without worrying about too much about where the margins have to be exactly. So, as I mentioned, C11 methionine does pick up the lower-grade lesions. There is some blood-brain barrier dependence. For example, methionine uptake does not rely on the blood-brain barrier to be breached from the tumors. There is going to be some uptake, but there is transport across the blood-brain barrier, so that does become a rate-limiting step. The higher-grade lesions will have increasing uptake. So, as I mentioned, as I showed to you, that could be of great interest to us in terms of figuring out whether we're dealing with a more aggressive lesion or not. And not only that, we know that deactivation of amino acid transport may be an early indication of therapy response. So often we can use it serially. Our own experience at Kettering Network has been that using all three MR with PET, FDG PET, and methionine PET provides the most useful information clinically in order to make the decisions we need to do. So there is added benefit for PET in staging, particularly at the time of recurrence. This is a case of an infiltrating glioma. If you look on the slides on the left side, you will see on the top FDG images in the temporal lobe. In the left temporal lobe, there's sort of lower grade FDG uptake and a little bit higher grade methionine uptake in that same area. So this was a patient who had diffuse astrocytoma, a lower grade tumor, and the recurrence was a glioma which progressed to a glioblastoma. So we're seeing that demonstrated over here. Now, there's more advantages to this. For example, we see a lesion, which again, the question was, is this recurrent or not? This is the MR findings, and then we have the CT findings, not much on the CT. And of interest was that when we did the PET imaging, which is the FDG PET at the top and MR at the bottom, notice on the FDG image, you'll see there's a very slight decreased uptake on the in the right hemisphere compared to the left. That's because the patient's been treated with radiation in the past. But we look at the methionine image, that doesn't exist. And so particularly the area of lesion, both the FDG and methionine images are negative. But you will notice that on the left side, there's a focal hotspot. And if you go back to the MR image and we fuse that, we actually see that there is a little tiny nodule that's sitting there. It's there on the MR, but was missed on the initial read. And the MR and the methionine was able to help us light that up and find it. So again, PET is adding to things that, even though it's there on the MR, it could be very difficult to pick out and really assist in the patient's management. So what are the implications? So more, again, as you all know, we're in the era of molecular imaging. So we're really beginning to look at all these modalities as biomarkers. It's not just that we like to diagnose something, but they're using it as a biomarker along with genetics and all the other clinical information of what the tumor is potentially doing. So again, we could assess the aggressiveness of malignancy beyond just what the surgical pathology tends to show. And then we can use this to guide treatment paradigms such as, do we do surgical resection, or how do we do it? Radiation usage, how do we use the radiation? How do we sequence these therapies? And can we relate this uptake to the actual genetic profiles of the tumor, non-invasively? So I'm going to just run through some other tumor types that can show up. For example, this is a case of an astrocytoma, grade 2. There's FDG, not much uptake in the tumor, which you can see in the right mesotemporal lobe. Methionine uptake also just kind of has a very mild low-grade uptake in this grade 2 tumor. But now as we get to sort of a higher grade tumor, you can see that there's more methionine uptake in a similar area, whereas the FDG uptake, there's also starting to be FDG uptake here, again, showing you that you can have a more aggressive tumor that will light up metabolically much more. This is a case of a metastatic adenocarcinoma of the lung, where we see FDG uptake on the top and methionine. Notice again, the uptake is not as robust on the methionine imaging. So one of the points and going to yet another tumor type, here's a patient who started developing changes in the MRI, and we can see that on FDG, these changes are developing slowly. And when the methionine imaging was done, a little bit more prominent than the FDG, but again, not super hot on the methionine, which kind of shows to us that we have to kind of judge how we look at these scans based on what kind of pathology we may potentially be looking at. So it's not easily just, you get high uptake across the tumor lines, but you kind of have to look at what tumor line you're looking at and what that implies for its aggressiveness and grade of the tumor that we may be seeing. So one of the important roles of PET, and I'm hoping my colleagues will be able to do a much deeper dive into this, is therapy planning. For example, it's a well-known fact that the lesion margins on MRI are often exceeded by the metabolic margins with tracers such as C11 methionine PET. Again, what are the surgical and radiation oncology implications? My colleague, Dr. Satter, will be talking about. There's often the problem of radiation necrosis versus recurrence, which again will be discussed a little bit later. Again, that is problematic with MRI, and I won't say it's perfect with PET, but it certainly improves the differentiation between the two when added with the MRI data. But again, like I mentioned, the diagnostic criteria may be different based on what kind of tumor that we're looking at. Just to kind of show you a slide of how therapy planning is done, and you can see that the methionine uptake here kind of seems to extend beyond what the MRI margins may tend to show, and we certainly are using the methionine data to enhance what's seen on the MRI. I would say most everybody else that's not doing PET does not do that. So we are certainly integrating PET into our treatment areas. Again, this is a patient with a renal cell carcinoma. The question is, this patient's gone through surgery and external edema. Is this a recurrence or not? We're getting similar uptake on the methionine and FDG type images. This would tend to sort of lean towards more of an inflammatory response than a true recurrence based on the pattern of disease we're seeing. And again, the pattern is going to be very important in nuclear medicine. I'm not going to get into much about using SUV ratios and other things like that and other quantitative parameters that are useful, but suffice it to say we don't tend to use that as much because we feel that it doesn't really add a lot of information in these cases. This is a case where a patient was suspected to have a recurrence for an adenocarcinoma of the lung. So they did an early FDG PET scan down, you can see at the top in the posterior right parietal and sort of occipital region. And then that was the early post-op staging FDG, then a suspected recurrence. You can see there's a little bit of FDG uptake in that area. And then the suspected recurrence with methionine also showed some irregular uptake at the margins. When the biopsy was done, this actually turned out to be negative for a recurrence, and I believe the scans are also read as being negative for recurrence. On the other hand, if you were to look at something like this, where we have FDG uptake and methionine uptake, there's quite robust uptake in both there. And one might think that this is recurrence, but actually this did turn out to be necrotizing granuloma and consistent with chronic inflammation. So this is a case where it is false positive. So yes, we do get them, but again, it just improves what we see MR. Here's a case where on the left side, a patient had methionine and FDG imaging done once upon a time. And the patient came back with seizures and there's having frequent seizures. There's a question of whether they had radiation necrosis or recurrence of tumors that were triggering these seizures. And when we did the methionine and FDG, remember we do the methionine scan, then we do the FDG right afterwards. There's this sort of diffuse uptake that we see on the methionine scan and not much there on the FDG scan. And this is due to seizure activity. Now the question is, did the patient have a short seizure right before the methionine injection, or was it that they're just having frequent seizures and that part of the brain was just active and took up methionine anyways, even though that they may not have had an active episode at the time of injection? But nevertheless, it is pattern recognition, and this is not all tumor. This is indeed seizure. And there are case reports out there, but it's interesting. Being a community hospital, we do this all very advanced kind of imaging, but we don't have the manpower to publish our results, which is a shame, because I think the world needs to know it. You know, these are published as case reports, where we see these quite frequently in many of the things that we do. Here's a case where we have glioblastoma, where a positive methionine scan, negative on the FDG scan. But when they biopsy, it turned out to be a high-grade glioblastoma, which is surprising because, like I mentioned, that those are the lesions we tend to see positivity in both the FDG and methionine. So it's interesting. Like I said, we're really looking at biomarker imaging. So even though the pathology shows a certain type of high-grade tumor, the PET is kind of adding to all the profile we already know about the disease and adding a layer that this may actually be a less aggressive variant of a high-grade tumor. And again, what the treatment implications for that would be very interesting to be able to study. But there are future tracers coming up because C11 methionine having such a short half-life is dependent upon a cyclotron being in the vicinity. There's a development of fluorine-18-based tracers, such as FET, which is fluoroethyltyrosine. But there are some of the older ones like FDOPA. I've mentioned C11 methionine here. One of my colleagues will talk about their research at the University of Pennsylvania in Philadelphia with regards to flucyclovine. Dr. Satter will very briefly touch about PSMA agents. But again, these are all sort of not specific. There are now very specific agents being developed specifically for glioblastomas. And then there's some other also non-specific agents such as somatostatin analogs, and I will be showing you just a couple of quick examples of those. The F-DOPA mechanism, for example, it is a catecholamine analog. It's taken up by neuroendocrine metabolism, concentrated into neurosecretory granules, and it is very useful in the use of, again, low-grade brain tumors. The radiochemistry is rather difficult for F-DOPA. Otherwise, it is F18 based, so not so much in a rush to image that as compared to C11-methionine. Here you can see a low-grade lesion lights up on the F-DOPA PET scan, where it did not on the FDG. And there are several papers showing that to be the case, where F-DOPA is going to be a lot more useful to use than, say, FDG imaging in figuring out and identifying these low-grade tumors. This is a case where this is a lot of slides here, so it's a little confusing, but at the bottom is an MRI where methionine and FDG PET were done. If you look at the right periventricular space laterally, there is a small area where there was thought to be potential early recurrence. And when they did the methionine and FDG imaging, there was not much uptake in those areas. But over time, on the top, that tumor was that area seemed to progress and grow. So again, on the left side at the top, we see going from right to left that the tumor became larger and this area became larger and larger on the MRI. And we did, because this was an anaplastic meningioma, we tried correlating with a DOTA-Tate PET scan, and you can see that actually has uptake in that area, which turned out to be tumor recurrence and tumor progression. So again, another tracer that is familiar to most of you. In this case, it's gallium, gallium-68. We are using the copper version at this point. But again, if we know what tumor we're dealing with, we can pick out the right agent to use to image. This is from the literature in regards to using FET PET. This is a patient who had a baseline imaging and a retest. They did it just to look at the variability of uptake. And you can see that there's a fairly robust uptake of FET. But interestingly enough, after chemotherapy and radiotherapy, there's a lot of uptake. And this scan was done only 1 week after chemotherapy, radiotherapy was done. And so again, timing of that imaging is very important because the therapy has been completed, and yet we see a lot of uptake in the tumor. So it's important to let the inflammatory component sort of die down before we go back to re-image. So in summary, PET imaging does provide incremental advantage over MRI imaging. It assists with initial staging, provides some biomarker and metabolic information, and can be useful in monitoring treatment and recurrence. And future tracers hopefully will improve imaging performance and provide incremental prognostic information and will be disease specific. I have not even touched upon the diagnostic implications with regards to all these, what I've showed you, because I think there's a lot to cover just from the imaging standpoint and the program that we have set up. And I thank you for your attention, and I will now turn this over to my colleague, Dr. Peter Booz, who is one of our neurosurgeons, who very much are dependent upon a lot of the C11-methionine images that we use, and I will let him give a short talk on how that influences his clinical management and decision-making. And I would like to turn the session over to Dr. Booz now. I will stop sharing. Dr. Shazi, I don't know if you wanted to give a quick introduction to Dr. Booz as well.
Actually, Dr. Arif, we would appreciate it very much if you could provide the introduction yourself.
Okay.
Hello?
Yes, yes, okay. So Dr. Booz, as I mentioned, is my colleague here in our neurosurgery program. And one of our physician champions. I will say that, again, being a community hospital, several years ago, our cyclotron was up for renewal, and there's a big question whether or not in a community hospital setting they really needed a cyclotron. And I must say it was really the push by our entire neuro-oncology program to say that, yeah, they really did want that. It was very useful for them. And so, Dr. Booz, would you please take the, I know you're on, take control of the session.
Okay, can you hear me, guys?
I can hear you. Can the audience hear Dr. Booz?
We can hear you, Dr. Arif, and
Okay. Again, my name is Peter Booz. I'm a neurosurgeon here at Kettering Hospital with Dr. Arif, and predominantly involved with the cranial procedures, tumors, and vascular. Wanted to kind of collaborate a little bit on the talk from Dr. Arif. It is very important for us to kind of push the advancement of the PET imaging. We heavily rely on them during the surgical decision making, and would like to see that field of medicine to get a little bit deeper and broader in the assistance of diagnosis, and especially in the age of where the resection is very much tailored to the pathology here. So I do rely heavily on PET imaging, and I'll share a few examples. Some of the surgery are mine, some of them are borrowed from the utility of the PET imaging. So this is a case from last week of mine, where this is a 62-year-old gentleman who presented with seizure, and as you can see there, the ring enhancing portion is a contrast enhanced image on the left side of the screen, with the ring enhancement portion measures approximately 17 millimeters, so relatively small lesion. With bottom slide shows some of the FLAIR imaging, bit of a FLAIR signal around the lesion that extends somewhat beyond the margin of the tumor itself, which we would anticipate. However, on the PET with methionine image there in the right corner of the screen, you see that the borders of the tumor is significantly larger than what we see on the contrast enhanced imaging. The way that I approach this type of a pathology, first I plan my craniotomy to extend beyond the margins of the contrast enhancement, as I anticipate resection that will incorporate the methionine or the PET imaging margins. I do suspect that this would be a high-grade glial neoplasm based on the PET imaging. Therefore, I plan my craniotomy accordingly. We start with the biopsy, or small sample is being taken from the contrast enhanced segment, which I confirm then that this is indeed a neoplasm, and a glial neoplasm. And then I proceed with the resection of this lesion, incorporating the margins that we would fuse then with our navigational system to resect all the portion of the PET imaging as indicated there, where the high-grade neoplasm is suspected. So this is kind of how apparently small lesion on the contrast-enhanced MRI, if that was used as your guide in the resection of the tumor, would significantly underestimate the extent of the tumor, leading to significant residual and quick recurrence. So some people would use the FLAIR signal as their guide in the resection, and I've used that too before we had the utilization of the PET images to the extent that we do right now. But even with the FLAIR, the signal can be pretty extensive. Sometimes you in the brain, especially in this case, you encroach on a premotor cortex. So you don't want to rely on a FLAIR signal because that does not correlate with aggression. However, resecting the FLAIR signal would be very much desirable, but not always possible given the location of the lesion. So that's how this pathology did turn out to be a high-grade glioma, and significantly wider margins were taken compared to what the contrast enhanced MRI showed. So that's kind of a utility of that. So extent of the lesion beyond the sort of traditional approach utilizing the contrast enhanced imaging is kind of how I utilize the PET imaging. We talked about some of the borrowed slides. These are the decision making in radiation necrosis versus recurrent lesions. We are often faced with an almost entire population of high glial neoplasm patients will come in with some sort of abnormality on the surveillance scans. We image them at 3 months interval, and we do often see abnormalities in the tumor cavity. Obviously, the cavity itself will have some scar formation as apparent on the surveillance imaging. However, the decision lies in kind of determining, is this just a postoperative scarring? Is this a radiation necrosis, as we utilize significant amount of radiation in these patients? Or is this truly a recurrent type lesion? And this is kind of where the decision-making surgical decision-making is important. Are we just watch the lesion that is radiation necrosis, or do we go back for resection? And if we do resect, what exactly we are resecting? Are we resecting the scar tissue, or are we truly incorporating the area where the true recurrence is seen? And so oftentimes we have, as a matter of fact, in entire population of some of these glial tumors, you will have the combination of postoperative scarring, radiation necrosis, and true recurrence. So to be very precise in the surgical approach, one would have to make sure that we incorporate, most importantly, the metabolically active portion of the tumor. And so that's where the PET imaging is vital in making sure that that we're not compromising the well-being of the patient and truly resecting stuff that is needed. That also will influence the postoperative recovery and prognostic values to the patient. So these are the kind of images that illustrate that. Another example of a decision making in regards to, is this a low-grade glioma, or is this a truly a tumor that has a higher grade within it? And some of these slides really illustrate the validity of methionine and in determining whether this is a low-grade glioma or not. All these cases are often called by radiologists as a low-grade glioma, since there's no contrast enhancement on the T1 imaging there with contrast. So traditionally they were thought of as low-grade glioma. We're utilizing the PET imaging. We're starting to see that there is a higher activity that leads to a different pathologic diagnosis during the surgery. So I was also asked to talk a little bit about the lid therapy and how that influences, and how does the imaging that we get utilizing the PET scans contribute to the surgical intervention. So there are several surgical advancements that are currently being sort of used and advanced through our in our specialty. Lid is the laser-induced interstitial thermal therapy. The notion that a little brain damage is okay is actually something that I think was behind the development of this technology. Especially when we're dealing with the recurrent tumor, some going through previously radiated skin, going through the scar, or even treating a tumor in a very eloquent territory. We don't have the luxury of utilizing the aggressive surgical approach here with these patients. Therefore, the minimally invasive type of approach is being often used, and LIT is a very advanced technology that's being utilized at our institution heavily, one of the large volume of treated brain tumors using LIT in the United States. So how is this differ from our routine standard type of surgeries? Is the LIT consists of several steps. So patient is taken to the operating room first, where we place the frame. We utilizing the navigation system. The navigation system again uses traditional contrast enhanced imaging, often fused with the PET imaging, and that kind of gives us a trajectory of entrance, point of entrance and target. We select those. We place a access port, if you will, in the cranial area of interest, and then patient is taken to the MRI. It's a complex setup. However, we have a well-oiled flow with these type of technology, where in the MRI, through a variety of probes, the heat is being delivered to the area of interest. You know, the heat, basically, if you will, we essentially cook the tumor. If that's kind of how I would describe it to those who are encountering, or to the patient even. You know, so if we got the tumor, we can either go in and resect it. Oftentimes that is not possible. We can get back through a little probe with very little damage to the brain tissue as we get into it, and essentially cook it at the type of a temperature that will fry the cells, destroying them and destroying the blood supply to the tumor, leading to the cell death. And as you see, there's the image down below. What I have is the temperature settings that we can adjust. We can control this via the robotically controlled probe. A variety of probes, variety of territory can be incorporated. We do our planning based on the anatomy, based on location, size, etc. So there are several. We have multiple probe types that can be utilized depending on the shape. And in the MRI, where we confirm adequate placement and the zones that need to be treated, we deliver the thermal energy to basically fry the tumor. Again, that's where some of these images here also borrowed, that you can see on the left upper high-grade glial neoplasm incorporating eloquent, non-resectable territory. This is something that is traditionally would be told to a patient that this is non-resectable tumor. You would not go into the deep basal ganglia thalamus type of territory. However, the LIT therapy has been proven to be very useful. Some other images there, kind of, where some metastatic lesions can be they can be treated. We can also use the same probe that we would deliver the thermal energy. We can use that as a biopsy. So often we would biopsy through the same probe and then induce the energy to treat some of these tumors, showing a pretty good resolution with time. And that's all for my presentation.
Thank you very much, Dr. Booz. We'll be saving the questions till the end. As I mentioned, we're doing, again, being a community hospital, we're doing very exciting stuff with not only PET imaging, but novel surgical techniques, which are also being used very rarely and mostly at academic centers, let alone community hospitals, and being able to marry something very advanced, such as amino acid imaging, with these techniques such as LIT, is very exciting for us to be able to offer our patients. I think we truly are a hidden gem with terms of neuro-oncology and our abilities to work with this. Our next speaker is Dr. Martin Satter. He is our medical physicist with the official designation of Chief Molecular Imaging Scientist. He's been basically around Kettering almost since the inception of the PET program, and certainly with methionine imaging. So he assists a lot with regards to radiation oncology and our neurosurgical colleagues in terms of their treatment planning. So I will hand the session off to him so that and he can talk about some of the stuff that they've done, some of the things that we're thinking about doing, and I think a lot of what he says, he's passionate about nuclear medicine. A lot of it is preaching to the choir, but hopefully he can kind of show you some of the innovative ways we have integrated PET into treatment paradigms for neuro-oncology patients. So, Dr. Satter, I'd invite you to help take over.
Hello, everyone. Can you hear me?
Dr. Satter, we can hear you.
And can you see my presentation?
Yes, we can, but there's a slight little problem. We are seeing your presenter view right now.
Okay. Let's see here.
If you go to display settings and duplicate slideshow, so that'll be great.
I want to share. Is that better?
Not yet. Oh, yes, it's okay. Okay to proceed.
Okay. All right, thank you very much. Good morning, afternoon, or evening, depending on where you are. My title of my talk is PET molecular imaging, kind of in the era of precision neurosurgery, a new paradigm. In terms of disclosures, no disclosures, but I would like to point out sort of the miracle of PET molecular imaging at Kettering can really be attributed to one person in particular who retired about 4 or 5 years ago, Dr. Joseph Mantle, who is our director and fiercely fought for getting us a lot of the technologies, in particular PET technologies at Kettering. So I'd just like to acknowledge him in this talk. So just as a preamble, I'm a PET physicist, and as Arif has mentioned, I've been here a long time. In nearly all that time, I've been working very closely with neurosurgeons. This talk, done at behest of Dr. Jake, is more of an observation at 40,000 feet. It is not a clinical talk. I'm not a clinician, but more of an observation and an optimistic prediction. In short, my talk might be better entitled PET Molecular Imaging. We put the accuracy back in precision neurosurgery, and in all likelihood be more valuable if I gave it to neurosurgeons. Finally, these observations I have may already be common knowledge over there where you are. I'm aware that actually PET molecular imaging in many other countries has actually forged ahead where it stands here in the United States over the last decade or so. So how do I define precision neurosurgery? Well, a picture's worth 1,000 words. This is from an NVIDIA conference on using artificial intelligence and machine language for medical imaging. And what you see is this incredible data set. This is actually data from a patient. And you look at this in awe because it's literally, almost virtually, a human being that they've recreated. And you ask yourself, how do you do this kind of thing? The answer is you get information from many different sources, and you very carefully patch it together using technology called image co-registration. In this particular case, you're looking at the combination of MR and CT, magnetic resonance angiography, computerized tomography angiography, diffusion-weighted imaging, diffusion tensor imaging, so on and so forth. So we've been doing this for a very, very long time at Kettering. This is an image from a little over a dozen years ago where same kind of thing. Here's an MR image on the left showing a motor strip activation, and then on the right the diffusion fiber tract imaging. And of course, when you put that virtual patient together on the computer, The next thing, of course, that makes it of value is you have to match it to the patient as they're laying affixed on the surgical bed. And so basically the patient is co-registered to their virtual brain as it exists in the computer. And this link is usually performed through some kind of spatial tracking technology. Now, this weird looking thing that you see here is actually, again, a slide from many, many years ago, because we got the original viewing wand, as it was called, circa 1996 or 97. And you can see there, this is basically a mechanical six-jointed arm that you can monitor the position of the tip of that probe in real time. And that obviously then provides the link between the patient and their data set. So we used this technology back in 1995, and we're one of the first or second organizations in the country to incorporate PET molecular imaging into this technology. And you can see kind of the value of this. In this case, this is actual footage from one of our early surgeries, and you see one of the neurosurgeons is positioning the probe. You can then take a look and see, in this particular instance, the probe, the tip of the probe is projecting down through, I think that's a draining sinus or a vein of some kind, on its way to get to the green tumor that you see there. And obviously when he adjusts his hands a little bit, now you can actually get out and under, you can get to the tumor without intersecting any of the vasculature. So this is the power of this kind of imaging, and certainly back in 1995, the expectation was this is going to make a tremendous difference. I mean, if you imagine up to that point what neurosurgeons had to do, they literally looked at a two-dimensional film, they walked over to a three-dimensional head, and they made a hole trying to estimate exactly where the tumor was underneath all of that. So it's amazing they did that in the past, and certainly the idea that you could quantify that and improve the precision of that made everyone very, very excited about this technology. But eventually the mechanical arm that I pointed out was replaced with different types of tracking, providing even more accuracy and precision. The stage was set again for what we believed would be a remarkable improvement in the treatment of brain tumor patients. And there was an improvement via reduction in surgical complications, you know, as image-guided surgery technology allowed surgeons to then open up much smaller holes, much smaller craniotomies, as well as avoid, you know, brain's most critical structures, as I kind of demonstrated earlier. However, what was not seen was a significant improvement in the treatment, in the eradication of the brain tumors themselves, in actually extending patient lifetimes. And this was attributed early on to something called brain shift, for example, and brain shift is kind of the loss of calibration of the patient to their virtual brain during the course of the surgery due to actual patient brain motion. So, for example, when I've been at and witnessed certain neurosurgeries when they open up the craniotomy and literally the brain can ooze out or suck back in based on differences in pressure during the case. And obviously when that happens, all your carefully pre-planned image guidance goes out the window. And of course that then stops your ability to maximize the gross tumor resection and improve the probability for your patient to do well. So, for example, we attempted to fix this with intraoperative imaging back in 2005 via this battery-powered portable CT originally designed to be used by the military. And the bottom line was what we found is even though potentially, certainly we could try to detect bleeds and percent resection, and it could improve biopsy, spine surgeries obviously, and correct brain shift as a big one. In reality, at least back then, although coined intraoperative, it was still crippled by a lot of logistical obstacles and poor resolution. So we didn't really see much of an impact. There's other things we did where if you're combining all this information and you have a neurosurgeon that has to keep looking around, what about projecting that information directly to the patient or to the neurosurgeon's vision? This is microvision goggles. These are laser goggles that literally raster a laser image to the back of the retina of the neurosurgeon. They're see-through, so you can put all kinds of information up and into these goggles and put them into and allow, for example, overlay. So you could, for example, see the diffusion tracks in overlay on actual brain tumor during the course of the neurosurgery. And everything just kept progressing. You can look here, just taken from online. This is a Stealth Integration web page. So you've got all this capability now to track the location of your instruments via electromagnetic navigation. You can attach robots to your image-guided system, microscope integration, obviously, O-arm, which is kind of a poor man's CT, or full-blown CT, much better CTs now, ultrasound integration, MR scans. In fact, if you want some very serious precision neurosurgery and you have a lot of money, you basically can purchase basically an MR on wheels, where basically you have an MR on one side of a wall where you use it typically for your radiology imaging. But on the other side of the wall, when a neurosurgeon needs it, you can push a button, doors open up, and the MR comes marching into the neurosurgical OR to be used to address those issues where you might have brain shift correction, those kinds of issues. And again, very serious precision neurosurgery can include something like proton therapy, where again, the idea here is even more precise deposition of your dose so that you can extract and have better tumor killing and obviously spare normal brain tissue. So with this kind of onslaught of technology, actually I got one more slide, I'll go forward. There's one other piece actually Dr. Booz had mentioned. This is the NeuroBlade system where you're allowed to go in and in real-time MR guidance basically melt a brain tumor with real-time thermometry. So I'll just go back here and then say with this onslaught of technology that we've had over the last 25 years, it sort of begs the basic question, how are we doing? And you can look on the literature, for example, this is a publication out of Japan from April this year looking at proton beam therapy for gliomas, multi-center prospective registry study, with the disappointment that for glioblastomas in particular, that the outcomes of proton beam therapy are pretty much equivalent to what we've always done, using basically old school radiation therapy. Or you can look at intraoperative MRI, and again, a recent publication looking at a multi-center trial, trying to compare intraoperative MR, the MR on wheels, and see what its impact might be. This is a case that I think altogether had over 700 patients. And again, additional supporting evidence is still needed to determine the clinical value, basically, of intraoperative MRI, especially in the management of glioblastomas. And unfortunately, even in the case of LIT, neuroablation, we're seeing in multiple papers that you're really not seeing much of a difference in terms of patient longevity, in particular for things like GBM. There's a couple cases here. So with all this precision, how are we doing, in particular looking at glioblastoma? And again, I guess having been doing this for a long time, I'll be a little bit arrogant to go ahead and grade these technologies, and pretty much these very expensive ones I'll get a C because they haven't really moved the needle very much. And they're all extremely expensive. We'll give NeuroBlade a break because it's not nearly as expensive and does offer a lot of opportunity for addressing treatment of tumors that you don't have with traditional image-guided surgery systems. So we've got to come back to this original picture and say, what are we doing here? What are we missing? So if you look carefully, this is actually a brain tumor case. If you look at that red arrow, that's pointing to an MR image of a brain tumor. And so you sort of have to go back to the very basic question of what you're doing and wonder if perhaps you're not like the gentleman that's looking for his keys under the street light because that's where the light is, even though the keys aren't there. So it seems logical that to destroy biochemical processes, you need biochemical information about those processes rather than biophysical information. And here's a case, this is our third case where after we developed our own image co-registration, this is an FDG and an MR scan. The MR had contrast, and you can see clear evidence of a GBM, grade 4 GBM on the PET scan, and not so much on the MR scan. So the PET detection of a tumor, one not really easily seen or not seen at all on a high resolution MR image is a rare occurrence, but you have to understand the reason for the rarity isn't because it doesn't happen nearly all the time, or perhaps nearly all the time, but because PET is still so barely used relative to MR in clinical practice. So one of the things I do to try to get everyone to think about this a little bit, I have a simple kind of thought experiment about what MR and PET are really all about, kind of at the molecular level. And so if you were like me and old enough to remember, there was a movie back in 1968, excuse me, where they shrunk everybody down into a little submarine and injected it in the human body. And I'll show you in this thought experiment again, then if you do this, how you can create an MR, CT, and PET scan if you jump in this little submarine. If you do that, you jump in the little submarine and you're trying to do a CT scan, all you have to do is go to all the little places in the body you want to measure and get a voxel on your CT scan. Take out a scoop of a uniform size, scoop up a piece of tissue, and go and weigh it. Just put it on a scale and weigh it. Keep track of that information of where you're at, and literally you could create a CT scan of a patient. Again, a thought experiment, but just based on the idea that what CT measures is really density, electron density. And of course, in the case of an MR scan, a little more sophisticated, but not that much more sophisticated. Here you could jump out, and of course the patient's in an MR scanner, so there is a uniform magnetic field pointing in a given direction. You could just take out your Boy Scout magnetic compass and pull the needle off where it was aligned to the MR image or the MR field, and then time the amount of time it takes it to snap back to where the MR is pointing, where your uniform magnetic field is in the MR scanner. And based on that time, you could literally, per voxel, report that information and create an MR image. So biophysics measurements have really little relationship to biochemistry, and cancer is really a biochemical process. And this is especially exacerbated or can be thought of when you realize that most of the time you don't even get that typical brain tumors, as they exist normally, don't have tremendous differences in what they weigh or in their magnetic properties. So obviously we enhance them using contrast, but that contrast in that brain tumor then only appears after the tumor grows to an extent that it creates its own leaky vasculature, allowing the contrast to leak in, and then you can see the tumor in the first place. So what we've done here, I think, over the last 25 years is focus on precision, but not accuracy. So precision up in the upper left, it looks really good. We have a nice bunching, we have a nice reproducibility, but unfortunately we're missing the target. In the case of the ideal situation here, obviously we want high accuracy and precision. So we've kind of gone gangbusters on the precision side of things, but forgotten that we're really not hitting the target. So PET molecular imaging provides new and better information because it really enables biochemical assays to be performed in vivo. And here you see an example, I think you've seen this before. This particular case of a methionine scan, the brain tumor volume via the methionine scan is 5 times larger than what you can get out of the MR contrast. So in this particular case, if you were to treat the MR to the MR image, you're only treating about 20% of the brain tumor. So PET molecular imaging is imaging biochemistry, and it's as simple as when you jump into your little submarine and you have a Geiger counter, you're simply going to measure the positron density. And that's all that the PET scanner does. But a PET image is a mapped positron density, and in contrast to MRCT, that positron density is dictated by biochemistry and not the properties of the tissue or the contrast material. So we need tools for accurate personalized medicine, and the result is, I think the future is dictating that to combat diseases which are biochemical in nature, we need tools whose mechanism of action are biochemical in nature. So biochemistry obviously hasn't changed much in the last 25 or 30 years. But what has drastically changed over the last decade especially is the information we have learned about biochemistry in both healthy and disease processes. And this exponential growth in understanding is really attributable to the Human Genome Project, initiated in 1990 and completed about a decade later. So when you look to the future, and you look at these PET brain tumor agents, you have some traditional ones, such as FDG and methionine and fluoroethyltyrosine, but newer ones that are even more specific going forward. And understand that it currently, if you go out on the web, you can search for the number of PET radiopharmaceutical vendors, and I found at least 55 of them. And if you add up their pipelines, they have over 140 different PET molecular imaging agents that they're working on. Some of those will, of course, be even more specific to brain tumors and other types of cancer that exist in the body. So what we do, for example, with brain tumors now, as mentioned a little bit by Dr. Booz, we get a methionine scan, we get a PET scan, we co-register that data, and then to work up the patient, a mirror image of the PET brain tumor as segmented by the user is mapped to the contralateral side of the brain. The methionine activity is measured, and the brain tumor is further delineated by segmenting regions only above a certain tumor to contralateral tissue ratio, typically in the range of 1.5 to 2. The PET lesion is then marked as an RT structure, put in a DICOM data set, and sent on to the MR-guided neuroblade system. Currently we use the Monteris system. And again, as Dr. Sheikh mentioned, excuse me, we can perform these procedures due to an expanded access IND for PET methionine granted from the FDA. And we typically average about 60 to 80 of these kinds of studies a year. So the last thing I want everyone to consider is a timing issue. So for nearly all the PET scans ever done for brain tumor, and probably nearly all the PET scans ever done for any type of cancer, they almost always come with a precedent anatomical scan. So the real question you want to ask yourself isn't just location, 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 but one of timing. And so I've yet to see sophisticated studies, long-term and big-time studies, where the PET scan dictated when the biopsy was done. In almost all of these cases, and all the literature, you have some MR trigger that triggers the PET scan being done. But of course, again, if you think about it from a biochemical standpoint, it stands to reason that the PET signal is going to show up first, and especially in something like a brain tumor, that's going to have an even greater impact. So more than just the augmented value or whatever that currently you see with an MR scan, where you have an MR tumor and you see a slight difference, I think the future is going to be one where you're going to actually use PET imaging first, and it's going to trigger the treatment and the biopsy. And of course, a lot of this is going to be pushed by genetic testing, your early cancer detection via blood sampling. If you think about it, what are you going to do when you have a blood sample, you do your genetic profiling on it, and it indicates a lung cancer or a brain cancer? and then you go do an MR or CT scan and you can't see it, it's going to push PET molecular imaging into the fore because your earliest chance of seeing it is going to be from a biochemical standpoint. So in conclusion, PET molecular imaging is an entry point to accurate medicine, and it should greatly improve brain tumor treatment as it grows exponentially in the clinical arena. Thank you very much.
All right, thank you very much, Dr. Satter, for that presentation. It is my great pleasure to introduce our last speaker, Dr. Ali Nabavzadeh, who is, I've heard him talk over the web. He's at the University of Pennsylvania. He's an assistant professor of radiology at the Hospital University of Pennsylvania, with a research appointment at the Children's Hospital in Philadelphia. He's also the director of the Translational Imaging Unit at the Center of Data-Driven Discovery at the Children's Hospital, and the imaging lead of 2 consortia. These consortia are respectively dedicated to the biospecimen-driven data generation and precision medicine clinical trials. Dr. Nabavzadeh has been his research has focused on multimodality imaging using structural and physiologic MR imaging with additional PET probes and molecular imaging techniques to better understand the complex nature of brain tumor microenvironment. He has more than 100 peer-reviewed publications in prestigious journals such as Nature Communications, JAMA Neurology, Clinical Cancer Research, Neuro-Oncology, Radiology, JNM, and has served the principal investigator of multiple prospective imaging trials, including investigator-initiated trials and industry-sponsored FDA registry trials. I have been very fortunate to be able to get hold of him to present for us. And without further ado, I give to you Dr. Nabavzadeh.
Thank you very much, Dr. Sheikh. I'm trying to share my screen, but I can't because I get this message that someone else is sharing.
Oh, Marty, I think you may have to unshare your screen.
Perfect. Can you confirm, please, that you can see my screen and also hear me?
We see your screen. It's not in full screen mode yet, but it's working.
All right, wonderful. It should be good now. So, Dr. Sheikh, how much time I have? I think that we are.
I know we started late. Try to get through as much as you can.
Sure.
I think we have about 20 minutes, if I'm not mistaken, or more.
Sure. So I'm going to focus. I'm going to give a 15-minute presentation to leave some time for questions, if any. And thank you very much, everyone, for attending. And also, I want to thank the organizers and Dr. Sheikh for inviting me. I'm going to focus on fluciclovine PET imaging, and through that, I'm going to also mention some of the relevant literature. And these are my disclosures. And I'm going to focus on the different amino acid transporters, and Dr. Sheikh also mentioned. I'm not going to talk about FDG because already quite some slides have been shown in previous talks, and comparison of fluciclovine to different amino acid PET tracers, and some of the available literature in glioma and brain metastasis, and some of the ongoing efforts. So when we talk about PET imaging in glioma, in the past couple of years or so, there has been a significant interest in the field, and people have come together and published guidelines. This is one of the initial papers that came from ENM, EANO, and RANO kind of groups that put together the practice guidelines for imaging of glioma using FDG and other amino acid tracers. And And what they concluded was that the added clinical value of PET imaging with superiority of PET imaging with amino acid compared to FDG, with the limitations that we are aware. And this guideline actually provided a framework for use of PET to assist in the management of patients with gliomas. So when we do amino acid imaging in glioma, we are dependent on two transporters, PLAT1 and ASCT2. And amino acids play a key role in many cancers, including glioma, and they contribute to cancer cell growth, signaling, and tumor growth. And so amino acid PET tracers, they come in flavor. Analog have a 20-minute half-life, which limits it to centers that have an on-site cyclotron. Then we have 18F-FET, which is a tyrosine analog. It's widely used in Europe. And some of the centers in US, fluciclovine is an L-leucine analog. It's a synthetic amino acid. And F-DOPA is a phenylalanine analog. That is also FDA approved for Parkinson's disease. And it's being used in some academic centers. So this is an animal study using multiple, basically, GBM cell lines in rat GBM models, as you can see here. And why I'm showing this slide is that the beauty of amino acid imaging is that you're not dependent on contrast enhancement. Like you can see on these two animal models, the tumor is enhancing, and you see a lot of uptake on PET imaging with fluciclovine. And this is ASCT2, this is LAT1. But you don't have to have enhancement. Even in tumors that you don't have enhancement, you still see increased radiotracer uptake, which is great. So we're not dependent on a blood-brain barrier disruption. One thing about fluciclovine that makes it appealing is that it's FDA approved for prostate cancer, which means that there is a wide network of commercial radiopharmacies that can manufacture fluciclovine, and then it means that it can be used in a broad scale across the US. So in terms of comparison of different amino acid PET tracers, this slide shows a comparison of FET and F-DOPA. Sorry about that. You can see that they're kind of there are no significant differences. You can see that this GBM kind of shows similarly in between these two patients. One of the limitations of F-DOPA is that because there is uptake in basal ganglia, if the tumor is in that region, it can be hard to differentiate the tumor from the basal ganglia. But we can see comparison of FET and C11-methionine also has been done, and there has been shown to be a strong linear correlation between the SUV uptakes of both tracers, both at the normal brain and also at the level of the lesion. As you can see here, methionine and FET PET kind of show kind of similar uptake, and both tracers have been shown to differentiate tumor tissue from treatment-related changes. This is a study comparing fluciclovine with C11-methionine. And again, it showed that both tracers correlate very well. One difference is that there is significantly higher image contrast on fluciclovine PET compared to C11-methionine. In other words, the brain uptake is much lower on fluciclovine PET on normal brain compared to C11-methionine, which you can see that if the lesion has shown a high uptake, again, lesion can be seen on both, but if lesion is kind of borderline, only mildly elevated, you can see that basically it's easier to identify the lesion on fluciclovine PET because of much lower brain uptake. And so looking at the indication of what we use amino acid imaging for, we can use it from the time that the patient first presents with a mass, and we're not sure whether we're dealing with a neoplasm or a non-neoplastic entity like an inflammatory process or some weird infarct or other things. So we can use it for problem solving at that level. And during resection or biopsy, we can use it for assessment of the resection extent. We can use it for basically before doing the surgery. We can use it for planning the biopsy or resection. We can target the hottest area of the tumor, and subsequently we can, after surgery, we can use it to evaluate the extent of surgery, plan for radiotherapy, and also the imaging could be used as a baseline for monitoring response assessment after chemoradiation. And similarly, after we treated the patient with radiation and chemotherapy, PET can be used to differentiate progression from pseudoprogression and to further monitor response assessment. This is a study that was published from Emory that used fluciclovine to differentiate between glioma in terms of grading, low grade and high grade. And they actually found that the cutoff value of 4.3 gives a high sensitivity and specificity to make that discrimination. And basically, this is what they published. And the ratio to the normal brain was considered to be less relevant compared to absolute SUV values. And the reason is that the uptake in normal brain is so low in fluciclovine imaging that it's hard to differentiate from noise. So the absolute SUV values are more important when we do fluciclovine PET imaging. So I'm going to skip some of the slides that are related to FET PET in the interest of time. But this is a nice slide showing that basically when a patient first come after surgery before starting chemoradiation with some residual tumor, this is a very common finding that we see increasing enhancement after completion of chemoradiation. But looking at PET imaging would be very helpful because even though the contrast enhancing size of the lesion increased, we can see that the radiotracer uptake significantly decreased visually, and if we measure it, indicating that this is not tumor progression, but this is a treatment effect. So I'm going to skip these FET slides and focus on fluciclovine and how we can differentiate progression from true progression. So discrimination of pseudoprogression and true progression is a real question every time we have a brain tumor board. So we have 5 patients every week that the neurosurgeons and oncologists are asking, is it true tumor progression or pseudoprogression? And it's very difficult on MR because what we see is that lesions that increase in size over months, and there is no way using conventional MR to differentiate between these two entities. And eventually the lesions declare themselves, but it takes many months, which means like a lot of anxiety for patients and uncertainty and lost time in terms of recruiting patients into clinical trial that could potentially benefit patients. So, and it's not always that simple. Sometimes it's complex, it's a combination of both. Like in this patient that you can see this lesion A, over time, the lesion A kind of decreases, as you can see, turn out to be pseudoprogression. However, this lesion start to develop after many months and eventually declares itself to be true tumor progression, as evidenced by both conventional MR and perfusion MRI, which is helpful when we have access to it and when it's not degraded by artifact. The problem is that perfusion MR is frequently degraded by susceptibility artifact, like in this patient that you can see with this nodule, and that's why it's not helpful in every case, and that's why we need PET imaging, which is more powerful than perfusion MR. Like this case that the perfusion MR was non-diagnostic, you can see that the fluciclovine PET showed increased uptake, indicating that this is a tumor progression. And so in terms of diagnosing patients with pseudoprogression in glioblastoma, there has been significant literature using FET PET. But I'm going to skip these slides and focus on our study in fluciclovine. So this is a clinical trial that we performed at Penn a few years ago, actually during COVID, because we had a great collaborator where we were able to recruit 30 patients. And every patient had surgery, most of them within 1 week after they had fluciclovine PET imaging. And so what we found was that the patients who had true progression, and mixed progression means that patients who had true progression, they had 50% more tumor, and patients who had mixed progression, they had 10 to 50% tumor, and the rest was treatment effect. And the patients with pseudoprogression were patients who had 10% or less than 10% tumor. You can see there is significant increased uptake in patients with tumor progression compared to patients with pseudoprogression. And looking at the ROC curves, we can see that the SUV max, both at 20 to 30 minutes and 40 to 50 minutes, demonstrated high accuracy in distinguishing progression from pseudoprogression. And another interesting finding of our study was that when we combine the PET and perfusion MR, the accuracy even increased more, which is really good news in terms of how we can use the modalities and kind of in our advantage given their synergy. One example of a patient having kind of with true tumor progression, showing a progressive enhancing nodule in the tumor bed. Perfusion MR was non-diagnostic. You can see that there is some artifact, but also in the area that there is no artifact, there is no significant elevation. So this is a false negative perfusion MR. But PET showed a SUV max of 5.4 above our threshold, and this turned out to be 60% tumor. So this is an example of a patient with true tumor progression, mixed, and pseudoprogression, and you can see the SUV max 6.7 in the progression, 4.7 in the mixed, and SUV max 2.6 in the patient with pseudoprogression. So important thing is that when we do fluocycline PET imaging, there is always some uptake. So it's important to measure the SUV and use the thresholds to be able to distinguish between progression, mixed progression, and pseudoprogression. In terms of the role of fluocycline imaging in delineation of tumor extent beyond signal abnormality, there is already literature from this study that's published from Japan that they showed that in 26 patients that they had, all of them had fluocycline uptake beyond what they could see on contrast enhanced MR. This actually was also consistent with our experience that in some of our patients, we saw signal abnormality beyond what we saw on MR. It's a multifocal GBM that you can see that the bulk of the tumor is in the right posterior temporal lobe. However, there's a very faint MR signal abnormality, faint enhancement, a little bit of flare. When we look at the PET imaging, the extent of the uptake on PET is well beyond what we see on MRI. Another patient that on our study that we see the bulk of the tumor, large nodule kind of abutting the midbrain. But when we look at PET imaging, we see in addition to this nodule, there is another smaller nodule medially, which we can't really see on MR, not even enhances. Flare may be something, but not clear. The patient underwent partial resection, and eventually, after a few months, we saw that the tumor is kind of growing and progressing in the direction of the nodule that was seen on PET a few months ago, indicating that there is a potential for early tumor recurrence detection, or at least the projection and the location of future recurrence on MR can be predicted by PET. But this is just an anecdotal case. So I'm going to skip these in the interest of time and focus on two clinical trials that we have at Children's Hospital using fluocycline PET imaging. One of them is in high grade to differentiate progression from pseudoprogression. The other one is in low grade glioma to assess the response to targeted therapy or chemotherapy. Both of them are recruiting. This is one of our patients with diffuse midline glioma. And we can see very nice uptake in the tumor, very low uptake in the brain. And this shows the SUV max, and this is the normal brain. So this is a study that we're recruiting. So hopefully we'll have some preliminary data to show in future meetings. And I think that I'm going to also introduce some of the studies in fluocycline in brain metastasis. This is a small study that's published from Cleveland Clinic, and they showed that using fluocycline, they can differentiate between treatment changes and recurrent brain metastasis. This patient on top row shows this lesion, which turned out to be radiation necrosis compared to the bottom row, which is a smaller lesion but much higher uptake. turned out to be tumor progression. They actually showed that the SUV max got up of 4.3, which is not that different from our SUV max from our study. It was able to differentiate these two entities. And these are two clinical trials that are finished recruitment in US using fluciclovine imaging in brain metastasis, the PURSUE and the REVELATE trials. And this is the initial result from PURSUE that included 7 US sites, and UPenn was also one of the US sites. And they actually showed that the SUV max greater or equal to 4.8 can differentiate true tumor recurrence from radiation necrosis. And with that, I think I'm going to conclude by indicating that amino acid PET imaging has been increasingly used in neuro-oncologic imaging. One limitation to widespread use has been the lack of FDA approval and reimbursement, and there has been some successful centers like the Kettering Health and St. Jude that have been able to kind of use as expanded access, but that has been an exception rather than a rule. So hopefully with the FDA approval coming in the next few years, there will be more widespread use of amino acid PET imaging in US to better care for patients with glioma. And with that, I would like to thank the audience and the organizers for inviting me. Thank you.
Okay, thank you so much, Dr. Arif and your team, for very illuminating and very comprehensive talks on the role of PET imaging in neuro-oncology. So the session is now open for questions and answers. Anybody?
All the presentations were very nice, very elaborative and very much informative, and I'm sure we all learned a lot by such a nice and informative presentations. One question I would like to ask from Dr. Peter. One of your slides, there is an image of brain tumor on MRI, and the tumor size is appears larger on PET image as compared to the MRI image. What I would like to ask from your experience, from where you cut the tumor, do you depend on the PET image size of the tumor regarding, or while you are operating and looking directly on the lesion and you can differentiate directly this is normal brain or this is tumor size? What is your experience, please, kindly?
Thank you for the question. Yeah, that's a very technical aspect here. When we resect the tumors that are that show contrast enhancement, where there is a breakdown of the blood-brain barrier, contrast leaking in, necrosis center, those are very easy to distinguish from a normal brain. So the contrast enhanced portion, I can always tell the difference whether that's normal brain or abnormal brain. Once we start going into the PET active, especially in this particular case that I showed, this was my last week case, very vivid in my mind. The actual consistency. So if I were to describe it on the intraoperatively, the area of necrosis or the area of abnormality as seen on a contrast enhanced MRI, it looks kind of grayish, necrotic, irregular. Then when we go into the margins of the flare signal, which correlates and extends past it with the PET scan, that area of the brain has a bit of a kind of a softer, suckable feeling. You can definitely detect the difference in the normal brain versus abnormal in that case there. Now, it's not always the same. Obviously, there are some more dense area where you go into the deeper portions, white versus gray matter, and not always you have a luxury of very good sort of view. This one is more superficial, so you can kind of tell. But oftentimes it looks and feels normal. However, you're kind of still taking out the tissue because you know that it's abnormal on a PET scan. However, in the appearance of that, it just feels like you're taking a normal brain. So that's kind of how it is. So it all depends on amount of fluid, amount of swelling, amount of edema. And if the flare signal very closely correlates with the PET scan, you will feel a bit of a softer tissue, but it is very unreliable. So going simply by the appearance or by the view and the feel, it varies, and it's not reliable. So therefore, what I do is I basically then mark it using the anatomy. So once I open the craniotomy, I try to incorporate all of that PET images or PET density into my surgical field. I mark it with the special marker, and then even if it feels normal, I still go in and resect it. I trust the PET image and PET guidance. If it's an area where I can resect it, I would resect it, even if it looks and feels normal.
Right, thank you. One more question, please. Difference between necrosis and recurrence of tumor. In one of your slides, you showed that on MRI, there seems to be necrosis, but on performing PET image, there was a small nodule which was a recurrence. So what should be normal protocol if we find MRI, only necrosis on MRI, and there is no other symptoms? Should we also do PET MRI, PET CT or PET image to look for a recurrence, or just we should rely on MRI? If it is just necrosis on contrast image, we should stop further, don't go further ahead. Or we should also try to find out, just like a small nodule as you showed in one of your images. What should be the protocol? What you would do?
Perfect. So we do have a protocol established. Whenever we have a questionable tumor necrosis, in my practice, I always use PET scan, because it is the MRI appearance is very unreliable. So whenever there I see whenever I question, is it a scar, is it a necrosis, is it a recurrence, as my protocol, and which we have already established here, the PET images comes into play always, and that's how we would confirm. If it confirms to be necrosis and there is no metabolically active center from the PET scan, then we will implement medical management, treatment, surveillance. If there is any suggestion of recurrence, we'll go for it. So I think anytime there is a question or suspicious or question raised by radiologists whether there is a necrosis, we automatically suspect that within that necrosis there can be an active lesion, and it's that until proven otherwise using PET.
Okay, so we can take a couple of more questions.
Anybody? Thank you very much. I am Dr. Fida, and I have a question from Dr. Ali. You are talking about the fluciclovin. This is basically FDA approved amino acid for recurrent prostate CA. I am wondering, in cases of male adult, if PET scan is done and there is uptake in the brain, how you could say it is a primary brain tumor or it is a metastatic from the prostate? Thank you.
That's a great question. So, amino acid increased expression is not specific to any cancer. It is shown in many cancers, including prostate cancer, meningiomas, and gliomas. So I think that if a patient with prostate cancer, we do fluciclovin PET imaging whole body and we see uptake in the brain, then we need to do dedicated imaging of the brain with MR, and then to see what is the pattern. Is it just a single lesion or multiple lesions, and what are the imaging findings kind of point us to whether this is a metastasis or a glioma. So I think that this is something that is not uncommonly seen, but I think that if we look at the constellation of the patient history and metastatic burden, and also the imaging finding in the brain with PET and MR, usually we can get the answer. There has been quite a few case reports published on this, on meningiomas, that they incidentally were discovered, but then once they did MR, it was clear that this is an extraaxial lesion. And then the distinction between meningioma and metastasis, again, we can get help from other techniques such as somatostatin receptor imaging, which are very high in meningiomas compared to prostate cancer. So I think that this is something that we need to problem solve, but it would be feasible.
Okay, is that all? Shall we proceed to the next speaker? Okay, thank you once again, Dr. Arif Sheikh, Dr. Peter Bose, Dr. Martin Sitar, and Dr. Ali Nawabizada for sharing your knowledge and experience with us, and particularly on a weekend for sparing your precious time. So moving on to the next speaker, Dr. Akifullah Khan. He is presently working as director of one of the largest nuclear medicine and radiotherapy facility of KP province, known as Institution of Radiotherapy and Nuclear Medicine, IRNAM, at the historical city of Peshawar. He is former president and vice president of the Pakistan Society of Nuclear Medicine, a renowned nuclear physician of Pakistan who loves to share his knowledge and thoughts with fellow colleagues and young nuclear physicians, medical physicists, and technologists. So right now he will be talking about theranostics in gastroenteropancreatic neuroendocrine tumors, that is GEP-NETs, past, present, and future.
First of all, let me congratulate the PSNM officials, especially Dr. Shazia Fatma, for putting such a good show and providing me this opportunity to talk at this late hours of the day. And I appreciate all those who are still here and attending the session. So I'll be talking briefly about theranostics in pancreatic, gastroenteropancreatic neuroendocrine tumors, because we have recently started some theranostics at our institute, so I wanted to share those experiences along with some perspective of the disease as well. So this is the institute where I work, as Dr. Arzu Fatma mentioned, the first institute in the province, and it has been now almost 50 years that IRNAM is serving the people of the region. Now, the radionuclide therapies, as all you know, that it's expanding, and when I used to teach radionuclide therapies in PIAS some 20 years back, it seems fairy tales at that time, and most of my fellows used to ask me, would it be possible that these things come into practice in Pakistan someday? And today, listening to all these talks and having lutetium-based therapies available, now I think that dream has come true. And now we understand the disease pathophysiology much better, and there are lesser complications, as we know, with radionuclides used in therapeutics as compared to the conventional modalities. And then we have longer survival due to better clinical and critical care at our oncological setups. So we are having these radionuclide therapies more popular. When I did the PubMed search last week, so I found that for theranostics, there were almost 20,000 publications in the last 1 year. And if you look at the trend, it is ever increasing. And the 2023, still there are a few months left, so it may overtake the 2022, hopefully. When you compare, when you give a search of theranostics in oncology, still you get around 9,000 papers in the literature of the PubMed. So I'll be briefly talking about the gastroenteropancreatic neuroendocrine tumors, or GEP-NETs. Its pathophysiology for those who are new in the field, of the somatostatin receptors, and what are the treatment options. These GEP-NETs are 70% of the total neuroendocrine tumors, so they are the commonest of all the neuroendocrine tumors, and they originate primarily from the small and the large intestine, rectum, and pancreas, of course, but to a lesser proportion. the overall statistics are not that clear about JEPNETs, but it's estimated that around 4 to 5 per 100,000 new patients are diagnosed in the Western population. And this is the incidence, but the prevalence is increasing because the patients are now living longer with their diseases. So the incidence is remaining stable, but the prevalence is increasing and over time due to better clinical and oncological care. This kind of a disease, these JEPNETs, they are diagnosed very late in the course of the disease because they initially visit primary physician for their vague symptoms, then they are referred to multiple specialties, and usually imaging is ordered later in the course of their diseases, and it takes around 5 to 7 years on the average to get the diagnosis after the start of the symptoms. So histopathology proven neuroendocrine tumors are diagnosed very late in the course of the disease. By then they are metastasized. So we have to keep in mind few things related to JEPNETs. One is we have to identify whether it's a pancreatic or a non-pancreatic JEPNET. Is it functional or non-functional, whether it is secreting some hormone or it is not secreting hormone. It is slow growing or it is fast growing, whether the cells are accumulating somatostatin receptor analogs or they are accumulating the FDG. So I'll be talking about how to decide about the treatment option, especially when it comes to PRRT. Now, the degree of differentiation is very, very important when you are employing the radionuclide therapies, and the Ki-67 index help us in understanding the proliferation, and if the Ki-67 index is less than 2, we consider this tumor to be well differentiated. If Ki-67 index on histopathology is between 2 and 20, we consider this tumor to be intermediately differentiated and grade 2, and further if more than 20, we consider it G3 or grade 3 disease. Various receptors are expressed on different cancer cells, and same is true for the neuroendocrine tumors. They exhibit a large array of receptors and proteins on their cell surfaces, but what we are interested in is the somatostatin receptor, and these somatostatin receptors will be binding our analogs and the radiopharmaceuticals. In cancer cells, these somatostatin receptors are overexpressed, so make them a target for the theranostics. So these somatostatin and somatostatin receptors need to be slightly elaborated. Somatostatin exists in two isoforms, the short chain and the long chain, and the short chain are 14 amino acids and the long chain is 21 amino acids, and they attach to 5 subtypes of receptors, and the things are more complicated when it comes to which tumor will be targeted, which tumor will be exhibiting which kind of a receptor. So this is summary of the picture of the types of somatostatins, and in the lower panel you see all the synthetically prepared somatostatin receptor analogs. Now, in simple words, with in theranostics, what we do, we take a molecule shown in the red in this image that would be attaching to the tumor cell's receptor, while the blue schematic diagram is showing the linker which will link the radiometal to this biomolecule. So this is a simplest form of description of how the theranostics work. And the attachment to the tumor cell would depend on a lot of factors. As Dr. Irfan is here, he would be he's the master in preparing such radiopharmaceuticals at his labs, and there are a lot of things which need to be considered related to ligand, related to the radioisotope, which ligand should be used, which linker should be used, and then there are factors in the patient or in the target, like how it has to be transported, what are the binding sites and the concentration and the retention at the tumor site, and then the pharmacological intervention. If some concomitant pharmacological intervention is also being done, then it will enhance the efficacy of these theranostic efforts. There have been a lot of isotopes and a lot of radiopharmaceutical tried in these JEPNETs, and ultimately the lutetium labeled dotatate made its way to the clinics, and now we'll be not complicating your life further with the chemistry and going to the receptor. So the receptor for the somatostatin is three subcomponents, has got three subcomponents. It's a G protein, and it has an alpha, beta, and a gamma subunit. And these are some of the diagrams of these, and these are the various types of receptors and the affinities of gastrinoma, insulinomas, and the non-functioning pancreatic tumors and the carcinoid tumors with all these receptors. But we are not treating statistics, we are treating patients. So what we do, we try different kind of ligands in the imaging, and whatever ligand is attaching to a particular receptor, then we would be using that rather than looking for statistics. So this is how a somatostatin reacts with a G protein at the receptor site. It activates the receptor, and the alpha unit separates from the beta gamma complex, and it activates adenyl cyclase, phospholipases, and various kinases, and the tumor and this complex, when internalized, may upregulate or downregulate the receptors on the surface. So this is how a tumor, the isotope is getting into the bloodstream, then it is accumulated and it's taken up on the surface by the receptors, and then it is internalized in the vesicles, and inside the cell it destroys the cell when it is inside. So different kind of isotopes have been employed. The isotopes which are low energy would deposit their energy in the near vicinity, while the higher energy beta emitters would be having more collateral or the crossfire damage, while the alpha emitter would be delivering the dose in the near vicinity. So various efforts have been made, and we also commend the efforts of INMOL in this regard, and they have been the pioneers in starting theranostics in Pakistan, and Pakistan came onto the map of all those countries which are employing theranostics, and we are lucky to have friends everywhere, and especially at INMOL, and who will be supporting other centers now to start their efforts in the theranostics as well. And IRNM has taken few steps, and we would love that these efforts may be further strengthened and these services may be extended to other centers as well. This is one image where you can see a lot of activity all around in the mediastinum, in the liver, and then this patient was, when treated with lutetium dotatate therapy, this is also an image from INMOL, is a very historical image, and it got the recognition from every corner of the country. Now this slide is slightly important for those the beginners. Like if the what we call differentiation, degree of differentiation is very high, the tumor would be more octreotide avid, and if the tumor is more undifferentiated, it would be more FDG avid. And this is an example of such a patient where you can have very high FDG uptake in the liver, and you see the Ki67 index is 20, but you don't see a lot of activity on the DOTA-TATE image in the same patient. Similarly, here the Ki67 index is 2, so you don't see any FDG avid tumors, but you see a lot of DOTA-TATE foci, DOTA-TATE avid foci in the other image. So keep in mind these 5 points when you plan to treat a patient with lutetium DOTA-TATE. That is, the grade of the tumor is very important. Whether the tumor is progressing or not, if the tumor is not progressing, it's better to not to treat those patients and to treat it when the tumor shows signs of progression. Then the functionality, if the tumor has got potentials of producing hormones, and that hormones are causing symptoms to the patient, then these tumors need to be treated. And then the burden, if the tumor burden is too high, then you may you may opt for therapies. And then the comorbidities. One should not sit all the class fellows in one row, because then they'll be talking too much. So they should be made to sit in different corners of a hall, and they are not even listening to me like I'm talking about them. Yes, so you all class fellows should sit in different corners of the hall rather than sitting together, because and especially when they are female, there should be some yeah, but you are gents, you see, that's the difference. So, sorry for the gender biased statements, but I would have been sitting with them. Okay, so this is another case of 54 years of age male, and he has got a very high urinary 5 HIA, and it was biopsied, and it was a neuroendocrine tumor, and you see the regression in the disease in this case. This is an image from IRNM, and this was the first patient that we treated, and after 4 treatments, still you see some activity there in the liver, but the uptake is very good in the initial images and the subsequent images. Still after the 4th dose, we had activity, but this patient was in a presented in a very moribund state, and he was in the wheelchair and on the bed. But after and he had a very high bilirubin levels. He had obstructive jaundice, and now the bilirubin levels has significantly, drastically reduced, and patient is up and about and doing his normal routine activities. And this patient was also interviewed by a worthy chairman, and he was asked, and this is when we took the picture when he was meeting the chairman on an online meeting. This picture has been taken and presented here with the consent of the patient. This is another case, and you see a wonderful uptake of these. These are all Pinstec produced radiopharmaceuticals. So I congratulate the team Pinstec and the IPD, including their head technology as well, Dr. Wasim, and Dr. Nadeem Lodi, for being with us all the time, providing us all the support, and the response of all the patient was objective response, and the quality of life significantly improved. But as you see, all these patients presented very late in the course of the disease, and the tumor burden is too high. Let me show you another case that will open your dimensions more. Like if you see so huge tumors, then how can you expect that they'll be treated with 3 or 4 or 5, 6 doses? So that is why I was asking Dr. Rizwan in the last session that should we think about escalating the doses and about other. So we may plan to have yttrium as well. So Nadeem, think about yttrium for such big tumors, because the lutetium will not be very effective in such big tumors, and we would be needing some high energy beta for such patients. So this is a very famous curve everywhere shown in the NETTER-1 trial, and I won't be going into further details. And just to emphasize, the quality of life in the NETTER trial was discussed, and it improved significantly. This kind of treatments should be further explored, because most of the time behind every radiopharmaceutical there is not that big commercial motive as we have behind a lot of pharmaceuticals which have a commercial motive behind it, and they are promoted in that way. In radiopharmaceutical, unfortunately, when some people who are implying that treatment, when they are away or when they are not in their commanding posts, then the things go into the back burner, and the efficacy on one part, but these things are not that much in use after they go from that place. So I would be more interested in sustainable development of such therapeutic agents from the PINSTEC, and they should treat these lutetium, and they should be looking forward to many, as Dr. Shabana in her previous lecture elaborated, that there are many things to come, especially the alpha emitters. And I wish in my lifetime we see some alpha therapies as well, inshallah. And that would be another dream coming true, to see alpha emitters. And I'll conclude my talk with one more suggestion, that the medical physicists need to be further engaged into the dosimetric processes. They are very much reluctant into the internal dosimetries. For almost in every medical center, we have got multiples of physicists available to us now. PIAS is producing quite a significant number of medical physicists, and they are there in our department more than the doctors. I had 6 physicists in my Sinor center, while 2 nuclear physicians, including me. So this medical physicists are too much, but they are more interested to work in the radiotherapy department. So the internal dosimetry should be more, and I request my worthy colleagues from PIAS that help us in calculating and in doing all these. Yes. Okay, so this is just to emphasize on this forum, and I'll just the algorithms are very simple, as they look very complicated on this slide, but you have to choose all those patients, you have to separate all those patients which are operable from those which are inoperable. Then the inoperable, you should look for those patients who have got a progressive disease or a hormone producing disease, and those can be referred for PRRT. So these are very promising tools in the management and care of selected patients with inoperable metastatic neuroendocrine tumors. Symptomatic improvement does occur in all patients. Even in those patients, the trial have been done, G3 patients, in those patients symptomatic improvement have been documented. The yttrium and lutetium results are very encouraging in terms of tumor regression. Kidney protection is very important, and one should be very cautious about the kidney doses to the kidney. We have a patient who have got a single inoperable but single lesion in the liver, and we are hopeful that he would achieve a cure. But the problem is he is excreting too much of the like in multiple tumors, most of the tracer is taken up by the tumors, and little is left for the kidneys to be excreted. But if the tumor is small, there is a chance of a cure, but at the same time, a lot of medicine would be excreting and delivering a dose to the kidneys. So the kidneys' safety is of immense importance. And then comes to the self-assessment questionnaire, quality of life. The lutetium has done wonders in this regard as well. I'll just briefly touch the future. In the future, we should look for alpha emitters in selected patients. Then antagonists, the somatostatin receptor antagonists are known to bind tightly to the target and they are retained for a longer period of time, so they are also considered adjuvant therapy with the consent of and with the help of our oncologist. Dr. Asghar is here, and they can guide us like which kind of adjuvant chemos we can give along with the lutetium dotatate therapy to enhance the efficacy of these. Some are capecitabine or temozolomide have been under the trials, and then intraarterial injection directly, like we had a big tumor, the huge tumors in the liver in one case. I think those were the candidates for the direct injection into the intraarterial, and then immune check block points along with lutetium dotatate. And then there are certain off-label uses. I won't go into the details of them. So thank you for your patient listening. This is our 20th Center of Pakistan Atomic Energy Commission, where nuclear medicine has reached the northernmost frontier of the country. Thank you for your patient listening. Thank you.
Thank you very much, Dr. Akif, for your nice and interesting talk. Any questions that anybody would like to ask? Okay, we have a question over there. Can we provide him with the mic, please?
Thank you very much, sir. It was very nice talk. I have a comment regarding internal dosimetry. Tomorrow's I have a talk. Tomorrow I have a talk that is on the internal dosimetry, and I have carried out some studies related to the internal dosimetry regarding the PET imaging of neuroendocrine tumors, TMSA, renal scan, and cardiac imaging. So you will see that we have carried out some study, but the problem over there is that the availability of the patients and the availability of the equipment. For example, in our case, if we are to do the internal dosimetry, we have to scan the patient for multiple times, and it's time consuming. And sometimes the patient is handicapped, like you told that your patient was not on the wheelchair and it was not possible for him to retain for the longer time. So this is one of the reasons that when we go for the internal dosimetry scans, we have to retain the patient for longer time, like 4 hours, 6 hours, or sometimes more. And secondly, I told you the equipment is the problem. So if you are interested to carry out such studies, we can help you.
Yeah,
in this regard. Thank you very much, sir.
IRNAM would be pleased to collaborate with the PNRA and with the people who are interested in dosimetric assessment, especially in theranostics. My opinion is that if your kidney dose can be is lower than the critical dose to the kidneys, then you may enhance the therapeutic doses of lutetium in terms of each dose, and as well as the number of cycles can be enhanced, and that will benefit the patient, but keeping in view the dose to the marrow and dose to the kidneys. So if I'm sure about my patient that he won't go into the renal toxicity, then these are. Regarding the equipment, yes, we do have problems with the time on the equipment, but now IRNAM is doing a lot of late hour sittings, so that can be managed somehow. And we are also doing all these PRRT imaging later in the afternoon, so to save the morning time for all those emergency and the routine patients. Thank you, Shahid. Shahid is a friend from PNRA, and he has been a very critical observer of our activities, and we are seeing each other for the last more than 20 years and flourishing together. Alhamdulillah.
Sir, I have a question.
Yeah. Yeah, that is a part of the Nutter trial too, and that trial's result would be officialized by the end of this year. So I think we should wait for that, and some of the fragments have been published, yes, but as I said earlier that yes, these can be used for G3 lesions, but if the uptake is positive. Yes, Saad Abdullah.
Sir, since morning we have been talking regarding theranostic. As you have mentioned the need of a medical physicist in dosimetry, my question is, or we can say my suggestion is that why we are not focusing on radio pharmacy or the need of radio pharmacists? Why PIAS is not offering MS in radio pharmacy?
Yeah, it's a very good question, and most of the time, even the PNRA would at a certain point ask us to have a radio pharmacist rather than a radio chemist with us. In many of our institutes, we have chemists available, and we had to train them on job later on. Some were just MSc at that time, and then we trained them as a radio pharmacist, and they are now excelling. I'm not undermining their efforts. They have done wonders. Like we had Haji Abdul Manan Sahab, who was so good in preparing all these agents on site with us. Dr. Asghar was with us there, and many of the isotopes, many of the kits he used to prepare right there in the wet form. I totally agree with you. For a pharmacist, at least an MS program should be considered, and that MS should be the radio pharmacy, MS in radio pharmacy. And the atomic energy, because we are having 6-7 physicists right now, at least a job of a radio pharmacist is always. I had to transfer one of my pharmacists to the radio pharmacy because ultimately when I was supposed to start my PET clinic, so I had to have a pharmacist over there as a requirement of my setup. So I totally agree with you, Saad Abdullah. Your comment is very well taken.
Thank you so much, sir.
Okay, any more questions? Because like Dr. Akif said, theranostics and a very efficiently run radio pharmacy go hand in hand. So there's an information for all the participants of the conference. Dr. Gopinath Ganeskaran's talk, which proves to be an excellent talk, has been rescheduled to tomorrow, and it will be the last talk of tomorrow's session. So I would urge all of you, in fact, to attend it. And the topic is clinical applications of FDG and non-FDG tracers in oncology, a tool for theranostics. And so with this, we come to the end of this rather long and enduring day, and I would invite now Dr. Shabana Saeed to please come up, Dr. Shazia Fatma as well, and distribute the certificates and the shields. We have physically only one speaker present, so we'll start with him, Dr. Akifullah. Okay. So I will interrupt it a little further. Dr. Arif would like to make a few comments. First, let's listen to him, and then we can continue with the shield distribution.
All right, it was a great talk. In reference to the other question, so you have not started treating grade 2 and grade 3 tumors as yet? As a first-line therapy, is that correct?
Grade 2.
Because the NETTER-2 results have been, well, at least Novartis has said that the results have been finalized. They have
Dr.
not
Dr.
released.
Arif, as I understood your question, like you want me to say why we don't give it in grade 2 and grade 3 tumors. We first image the patient. It's admissible to be given to the G3 tumors, JEPNETs, but if the uptake is good. In the initial studies in the NETTER-1 trial, only the G1 patients were included and which had higher uptake. But now the other trial, which the NETTER-2 trial, it's also including all those G2 and G3 patients which are inoperable, and there are chemotherapy is not effective on them, and all the other conventional modalities have failed. They have included those patients, and there have been results of improved quality of life and improved in the longevity of those patients as well who have been given lutetium dotatate therapy.
And are you doing FDG imaging in conjunction with your somatostatin receptor imaging and making
At present,
clinical decision
yes.
as to get treated?
At present, at our institute, we don't have a PET CT available. We are in a process of installing a cyclotron, and soon we'll be having a PET CT scanner available at our center. So then we'll be doing gallium dotatate scans before doing a lutetium dotatate therapy. At present, we are doing for the diagnostic purpose, we are doing a technetium high-nectate, or we send the patient to InMol for the gallium dotatate scans or DOTA-NOx scans. And then when they tell us that the tumor is avid for the somatostatin, then we give them lutetium dotatate at our institute.
Sorry, one last question. You mentioned large tumors in the liver. Do you have endocrine surgeons who are willing to do tumor debulking prior to giving PRRT?
Yeah, as in other specialties, the surgical departments in our setups as well in oncological settings, they are not that heroics in doing surgeries of bigger tumors. But you are right, huge tumors can be debulked, but still the surgeons are not usually willing for in those patients who have got multiple other lesions apart from those huge tumors in the liver. Then when they say that what difference would you want us to make after doing the surgeries, making the patients remaining few months or few weeks more miserable. So this is how we are tackling the situation. We and the oncologists are stuck up with all these neuroendocrine tumors. Surgeons are usually reluctant here to do a very heroic surgery in such cases.
Appreciate it. Thank you so much.
I have a comment about Dr. Akif. It's my recommendation next time, if he is talking somewhere in the conference, it should be in the morning session or in the evening session, because his talk was so informative and so full of knowledge that definitely we are learning from him. Thank you very much. Yeah, I recommend he must have another talk tomorrow morning.
So
thank you, Dr. Akif. Thank you.
It was meant as a joke as well, but you can consider it both. Okay, great. All right, so can we call upon Dr. Akif to please come and receive your shield as well as the certificate.
यार ये मैंने अपने ऑफिस में लगाया है।
बहुत ही अच्छी जिससे है वैसे है
उससे बेहतर है जैसे है तो कोई भी बना ले
लोग ना एक तुम भी ले लो भेज देना ही तो पता नहीं कब आएंगे जल्दी करो भेज लो प्लीज जी माशाल्लाह don't know this is the famous class of 96.
Yes.
96 na hai.
96. So all of you kindly need to convene here at 8 sharp tomorrow. Thank you.
आज शाम की डिनर के लिए
सुबह का नहीं पता ना okay
this is the end of academic talks for today and we will reconvene for the dinner and gala evening at 8 o'clock. The dinner is in Maki and then we will have the cultural evening in this same hall.
Good.
8 o'clock हाँ यहीं से